dentistry field, rubber dam, and ergonomic. He held many lectures and courses locally and internationally. He is a member of European Society of Endodontics and a member of Jordanian Endodontic Society. Please welcome with us Dr. Muhannad Takruri. Please.
Thank you very much. Thank you very much. Can we start the presentation? Okay, thank you. Good morning. I really appreciate your efforts to come early here and attend this lecture. And I hope you are well going out having some maybe small tips or tricks or maybe small informations you are not familiar with regarding vital pulp therapy in immature permanent teeth. Immature permanent teeth is a very tricky situation in our clinics, in our daily practice. Why? Because we are dealing, or we are in the medium between pediatric dentistry and endodontics. And usually, both of them arguing each other. So this patient is our patient or pediatric patient. But in the conclusion, we have to treat this patient as a pediatric dentist or as an endodontist. First of all, thank you, KDA, for this invitation and having me here on the stage. And to be honest, presenting in KDA was one of my dreams when I just started to give lectures. So thank you for giving this opportunity. Before starting, I always like to post this slide, because after we finish our presentation, nobody will follow me. So I give you 30 seconds to scan the code if you are interested to follow me on Instagram. What you can find in my account on Instagram, that I'm doing live cases. So sometimes I am treating patients live from my clinic, so you are seeing what I'm seeing instantly. And before start, I always like to give this, to tell this small, short story. Maybe you heard about the boiling frog. Frog, or all of us, we like to stay in our comfort zone. So we are staying in that comfort zone, not doing anything new, and the water is boiling, 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 and then we can't jump. So the frog in the cold water, then medium water, then hot water. Here, he will die, but he can't jump. So you have to jump when you can jump, not when you have to jump. Thank you for the sponsored company, Marucci, and you recently have a dealer here in Kuwait, Medcare. I will present some cases using this material and other materials as well. Before starting I will present this case. This case came to my clinic, referred from a doctor. The doctor told me that I can't pull out the gutta percha from the canal. So I looked at the X-ray. I say, oh, it's very easy one. I can treat it in 5 minutes, pull it out, and that's it. But when I was trying to pull out the gutta percha, you see what happened here. But my question, I will go back. How the gutta percha went out like this? Who can tell me? Lateral canal, perforation, right? Any suggestions? Okay, I managed to pull it out easily, but the trick is the gutta percha wasn't even inside the bone. It's overlapping on the rubber dam. And this is why we are sometimes, when we are doing retreatment and taking X-rays, we are thinking that the gutta percha or the file we see that we retrieved the file, but the file is still there because the file jumped on the gutta percha or on the rubber dam or somewhere else. So we have to be careful about that, and we have to be careful more about social media posts because sometimes they are posting something not real. So here, when I go back, when you look at this X-ray, you are certain that the gutta percha is inside the bone, but it's out of the body. We will talk about indications, case selections, tips, tricks, and technique itself. A lot of us is familiar with Kakehashi study. Kakehashi study generated in 1963, the experiment was on germ-free rats. So this guy, Japanese guy, he performed RCT for rats, but in aseptic situation, no bacteria, sterilization, high level, everything, and obturated with nothing, air, only air inside. And he made a follow-up, and the success rate was like 100%. No gutta percha, no obturation, nothing. But the environment of the procedure was sterile. On the other side, he treated another group of rats, but without a septic protocol, and the failure rate was very high. And he concluded what? That if you are performing X-ray, if you are performing RCT under strict disinfection protocol and obturating with nothing, but performing a very good coronal restoration, you will come out with a very good and predictable outcome. And this argument, if I'm asking Dr. Muhammad here, or Dr. Rawabi, or Dr. Muhammad, when you are doing RCT, what is the most important thing? One of them will tell you obturation, the other one rubber dam, the other one coronal seal. So this is a very huge argument, and we can't argue each other about that because each step in RCT is very important. This case, why I'm presenting this case? Because this is a malarized premolar. When the patient came to my clinic, referral case, just for a prosthesis. So the doctor wants me to perform a redo because the patient will have a crown on this tooth or a bridge because the four will be extracted. When I started to perform RCT, the mesial canal under microscope was vital. I saw pulp and the bleeding pulp. And when I asked the patient, when was the treatment date of this tooth, he told me like 3 years ago. So this is a Kakehashi study, it's the same. Okay, so the canal was vital. Yes, vital pulp therapy procedures have traditionally including direct, indirect, pulpotomy, partial pulpotomy, regeneration. All of these we call vital pulp therapy. I will jump here because this is very noisy. This is a case, immature permanent tooth, 6, referred to my clinic. Here when you are asking the parents, we are not asking the patient, but the parents, what are the chief complaints? The complaint that the patients are describing the same as irreversible pulpitis. And regarding terminology now, maybe you are familiar with that now, ESE, European Society of Endodontics, they will change some of terms. So reversible, irreversible, that will be not anymore presenting in the terminology. So when you ask the patient, it's like irreversible pulpitis. So in this case, if you have adult with a fully formed root canal, you will do conventional RCT. But we give the patient here chance. Why? Because we have very good vascularization. We started the procedure with proper isolation. But before that, I have a question. why sometimes we are performing vital pulp therapy or conventional RCT in very high-level clinics under microscope, under rubber dam, under maybe observation of other doctors and guidelines. We're following everything, but cases are fail. Why? Shannon Patel, 2021 and 22, published 2 articles talking about our protocol and treatment. And what he's saying the following. You are doing RCT. You are anesthetizing the patient, okay? Maybe you are retracting the cheek with your finger. Sometimes we are retracting with our fingers, not with mirror. Okay. Then you are giving the anesthesia. Then you put the anesthesia aside. And you are taking the examination kit, checking something. And then you are putting rubber dam. So you have saliva on your fingers and on your gloves. And then you are grasping the contra angle or the turbine and starting to work. So you are contaminating the field. So you allow the saliva to come inside easily. خلاص قلنا للسلايفا تفضلي فوتي بكل سهولة. ليش؟ Because we did not follow the strict disinfection protocol. What he's saying that you have to change gloves between each step. So you are giving anesthesia, changing gloves. You are putting rubber dam, changing gloves. So if you are following his protocol, you will change your gloves 5 times. And this is a lot, to be honest. I will not do it in my clinic. Okay, this is money consuming, financially not profitable at all to change my gloves 5 times for each patient. So what I'm doing that I'm sterilizing my gloves. So I'm doing anesthesia, I'm sterilizing my gloves. Putting rubber dam, sterilizing my so the last thing to be done before accessing the tooth is to have everything somehow sterile. So I have to wipe the rubber dam from inside with 1% sodium hypochlorite. You can wipe it with alcohol. You can wipe it with chlorhexidine. So you have to have this tooth disinfected from outside before starting. Because of that, success rate is higher in someone clinic more than other. Why? Because of the disinfection protocol. So, and this is very important. This is a game changer thing. Do it in your clinic in every single case that you are performing, and you will get a very high success rate in your clinic if you are following up your cases. The frequent changing of gloves, but we will not change gloves. He's charging like 500 KD for each RCT. He can't afford that. Okay, so the axis must be done coronal apical. And here I'm stressing the technique. We have to be more aware how we are performing the procedure. So here I'm talking about the technique maybe more than to talk about vital pulp therapy itself, vascularization, histology. I'm stressing the technique itself. So we have to do the axis coronal apical. So I'm removing the caries from the periphery, and I am descending, going down, down, down to reach the pulp, to reach the floor, and then to expose the pulp and performing vital pulp therapy or pulpotomy. And here another thing, you have to change the bear. So do not do do not perform the pulpotomy with the same bear you performed with it caries excavation. So you have to change the bear, or at least what I'm doing sometimes, that I have 2 bears, one for excavating, the other for pulpotomy. If, let's say, I have only this bear, I have to use it. After removing the caries, and now I'm ready to expose, I'm disinfecting the field, then I'm taking this bear, dipping it in sodium hypochlorite, removing all debris, and then I'm performing pulpotomy. So this way you are reducing the bacteria to be penetrated inside the system and maybe followed by failure. So this is a very good, very important thing to be followed in your clinic and daily practice. The material that we are using in adults to gain hemostasis is sodium hypochlorite now, and it's recommended by a lot of studies. Rikuchi, for example, he's recommending between 1% and 2.5. Taha et al., Dr. Nisreen Taha from Jordan, she's a leader and pioneer in vital pulp therapy. She has published a lot of articles, RCTs, randomized clinical trials, on 1%, 2.5, and full concentration. In my clinic, usually I'm following this. I'm using full concentration sodium hypochlorite. I'm wiping the field with it, and then I'm placing a cotton pellet with sodium hypochlorite with 1% or 5%. Now with 5%, here we have some cases with 1% only, and gaining hemostasis with it. The function of sodium hypochlorite not always to gain hemostasis in adults, and disinfection, okay, because we are disinfecting the field, right? In pediatric dentistry, it's different when you are doing E's, D's, because you are doing this tooth to be served like 2-3 years more, and then you will extract it. So I don't mind if you are doing ferric sulfate, cotton pellet only, sodium hypochlorite only. I don't mind. Use anything you want. This is a kid. I want this D or E to be served for like 2-3 years, and then I will extract it. I go back. You see this picture, the crystals. These crystals, after using the sodium hypochlorite, you will see them usually in healthy pulp. So this is one of signs that you have healthy pulp. And we will talk about the criteria of the healthy pulp and how to know that this pulp is good or not. How I can know that the infection penetrated inside the canals? How can I know? I can't. I have to make histology. So I will take biopsy and send it to lab. Please test what is the situation there. Of course, no. So we have some criteria to evaluate the health of the pulp. So here I place MTA, conventional MTA, and vital pulp therapy. In my clinic, I'm performing them in single visit. So I don't do 2 visits vital pulp therapy. First visit, I do everything with composite. So after I put the material, I cover it with glass ionomer, or maybe sometimes with Light-Cure resin-based MTA like Theracal or any other material. And then I place my composite at the same visit. If I am having some doubts about the outcome, I'm not sure, the patient is living around, not traveling, and I have some doubts, I do 2 visits. So I bring the patient back, and I'm checking the material, the setting of the material, asking the patient about the pain, feelings, etc. And almost 100% of vital pulp therapies must come out with no pain on the second day. So when you are performing vital pulp therapy and you are seeing the patient next day or calling the patient on the phone, what you are feeling, he must say or she must say, everything is okay, I slept, everything is okay. But pain for 1-2 days is acceptable, but exaggerating pain is not acceptable, and somehow it's a sign of failure. So you have to perform full RCT. But usually with vital pulp therapy, we are not hearing from patients like signs and symptoms of after RCT, the conventional RCT. For example, when I'm doing conventional RCT, pulpectomy, with a perch, everything, the same, the first thing I'm telling patient after performing the procedure that you will have pain at least 10 days. So the patient will not call me, and the next day I have pain. Okay? So as I told you, arguing about what is the most important thing in RCT, corona restoration, material selection, doctor experience, we can argue till morning, but no one will win. Here's a video using pre-mixed MTA. So I have two videos back to back, one with pre-mixed material and the other one with conventional MTA mixing powder and liquid. Do we have voice? No, guys? إيش حدا؟ So here I'm exposing the pulp. And you can see that the axis was small. And here I'm injecting the material. And I can adapt the material after. You see here what I have done. What is the gray color thing here? It's conventional MTA. I dipped my brush in the conventional MTA and adapted the material with it for two reasons. The first one, to have the brush clean and not stick the material on it. The other thing, to enhance and accelerate the setting time. Glass ionomer, then I cleaned the glass ionomer from the periphery, then I placed my restoration. Everything was performed in single visit. So if you are following me on Instagram, and I will post my account later, again, you can see, after I finished everything, I realized that I have caries distally, so I have to do it, because this thing can lead to failure afterward. The other video here, the same thing, but using powder liquid material. I have nice music, but unfortunately we don't have here. Here's the criteria. Here I'm checking the attachment of the pulp. So Domenico Ricucci came out with this conclusion, that if you want to check the status of the pulp, you have to check the attachment. And he's claiming that if you have the attached part, you have to remove it and go deeper. And if you are checking more deeper and still non-attached, you have to remove more. And then if you still have non-attached pulp, you have to do full RCT. Here I have like 2 millimeters was non-attached, were not attached. So I performed deep pulpotomy. So we have partial pulpotomy, full pulpotomy, and we have deep pulpotomy, what we are calling it deep pulpotomy. And this case, one of the deep pulpotomy cases. Sodium hypochlorite, waiting for like 5 minutes, 10 minutes. Yes, please. But it's too late already. Okay, thank you. And here's the material. I'm not using any fancy instruments like map system, MTA carriers, anything. I'm carrying my material with plugger, or sometimes with micro brush. But the trick here is how to mix the material. I love to use microbrush a lot, but we have to be aware about the hair or the tissue of the fibers of the material. You can see that I have 2 or 3 pieces sticking there, and that thing might bring failure to your cases. What is the thickness of the material? The recommended thickness is 2 to 3 millimeters. So you can't put like 1 millimeter MTA. That's not enough. Okay, the material will not work. At least 2 to 3 millimeters. Here's another trick. When I have a messy field and I want to clean it, if I will grasp my cotton pallet and cleaning there, here, there, maybe I will wash out the material. So what I'm doing here, I'm holding the material with my micro brush and then blowing air and water and cleaning everything up. So I have my material secured and I can continue with my adhesive protocol. Here's some conclusions from different studies talking about the vital pulp therapy and how vital pulp therapy can replace the conventional root canal treatment. And to be honest, I'm believing in that. And now in my clinic, I'm performing a lot of regenerative dentistry cases. Maybe 2, 3, 4 years ago, I wasn't interested about regenerative dentistry. Now, I'm performing regenerative dentistry, and to be honest, outcome is very good. I have cases with lesions, and I have healing with no obturation. So we will go back to our case. Material, after 3 months, we can see the bridge here, formation, and this one of the success, let's say, signs of vital pulp therapy. If you were attending vital pulp therapy lectures, let's say 15 years ago, they will say after full formation of the root, you have to perform root canal treatment. That was the guidelines. Now, no, we say no. If you have no signs, no symptoms, good corona restoration, you can keep the tooth as is. So we have here from first visit to 1 year, and we can see a very good outcome. Another case, 10 years old patient, injectable material. You can see the thickness of the material. It's at least 2 to 3 millimeters. Otherwise, the material will not work. So please, one more time, I'm stressing the technique. One year, 17 months later, and here the full case. The outcome is satisfying. And we can see the layers of the material. Calcium silicate material, glass ionomer, then composite. A recently published article by Nisreen Taha and one of her students, Dr. Shruq Bakri, comparing the partial pulpotomy to full pulpotomy. And of course, the full pulpotomy success rate was higher than partial pulpotomy. But one more time, sometimes you have to open, and I don't know if I showed already the article or not of Domenico Ricucci talking that sometimes we have to expand the examination to open the tooth and checking the pulp itself under magnification. Another case of partial pulpotomy performed, this is after 3 months, 7 months, 18 months, and you can see the development. With distal part of the tooth, nothing was done. Only the mesial part of the tooth. We have to be aware about this caries, this kind of caries. Sometimes I'm performing the RCT and sending the patient back to his doctor to perform the final restoration sometimes, or if has some caries in periphery or something, because patient, if he or she want to make in my clinic, they have to pay extra for that. They say, we are fine. Sometimes I'm placing a glass ionomer, then on the top I'm placing temporary filling and sending the patient to his doctor. So first thing, I'm economizing my time in my clinic, and the patient will go back and the referral doctor will charge for this filling. And sometimes they are coming on follow-up and the care is still there. So care was there in the first visit, second visit, third visit was done. So this is bad thing, because one more time, we don't know the failure will come from where. It's a very old case, partial pulpotomy. I will go back one more time. 17, 18, sorry. And 21. So we have bridge, we have fully formed tooth is still there, everything is okay. Here's the article for the Domenico Ricucci in 2019 telling us that expanding examination procedure to include direct visualization under dental operative microscope might help us in our diagnosis. So you have to use proper magnification. For me, I'm using microscope, but sometimes you can use loupes because microscope is not in every single clinic. Here's the case of, and the video was for this case. This is a deep pulpotomy case. You can see the bridge and the case from here to there. Okay, another interesting thing, this case was treated as a combined treatment. So part of the tooth was treated with gutta percha, the other part was left with pulpotomy. So when I opened the tooth, that was what I have observed under the microscope. So I have necrotic part and vital part. So I told myself, why not to go for combined treatment? And as you can see, this is a lesion. I'm not considering this to be like eruption cyst or thing. No, this is a lesion. So that's what I have done. The patient is living around my clinic, so I can bring the patient anytime I want. So that was after 4 months. So on combined treatment itself, you can't find articles about combined treatment itself. You can find only case reports. So this is the first visit, and after 4 months, everything is okay, patient is fine, and then the patient disappeared. 2 years. I don't know anything about the patient. We are calling the father of the patient. He's a driver traveling in the area. So we can't bring the patient for follow-up. But what do you think happened after 2 years? Resorption, but no lesion, no signs or symptoms, nothing. I asked a lot of doctors about this case, including Dr. Nassim Taha in Jordan. She told me, keep it under observation, and we can see if the resorption will continue, we have to perform a conventional RCT to stop the resorption. In this case, I will show in the same patient 2 techniques, with one with vital pulp therapy or indirect pulp capping. I think it was direct pulp capping or indirect pulp capping, and the other one was with apexification and apical stop. So here we have the signs and symptoms and clinical findings regarding these teeth, trauma. Yes, the whole treatment was carried out in 1 visit only. So I turned the patient from left to right at the same visit. Direct pulp capping on the left, apical plug and gutta percha on the right side. This is the procedure. This is the procedure, and I have a follow-up X-ray was before I'm coming to Kuwait. I will check if I have it here, but this is just to show how even if you observe some of the articles I showed here in my presentation, that the outcome of apixogenesis and apixification, it's the same. But why we are so keen, let's say, interested in keeping the pulp? Because when you are keeping the pulp, you're keeping the tooth vital. The pulp is eating, drinking, healthy, living, not like a dead piece of bone in your mouth. So vital pulp therapy is a good thing, is the future. Regeneration is coming, and a lot of studies are performing now on regeneration using induction of bleeding, using other materials, using platelet-rich plasmas and other materials. Thank you so much. This is my accounts. You can follow me up on Instagram. As I told you that I'm performing a lot of cases live, sharing tips and tricks in endodontics and adhesive dentistry. I'll be happy to have like 20, 30 new followers from Kuwait. Thank you very much, and I'm open for questions. We have 5 minutes left. If anyone have a question, please. Can we give the mic here? Easy question, please.
Thank you for the lecture, Doctor. I just have one question regarding while performing vital pulp therapy. After finishing, like let's say we did partial pulpotomy, now you're applying your material. Everything is clean, homeostasis is achieved. Sometimes that happens with me. After I apply the MTA,
blood coming
yes,
around.
Exactly. How do we manage this problem? What's the problem in that case specifically? Even though before applying the MTA, everything was clean, there was no bleeding, homeostasis was achieved. So how to deal with this case?
This is normal, and this is what is happening usually. When you are placing the material, when you are pushing your material, you already have like a moisture under the material will come over the MTA that you have placed. So this is normal, this is nothing, and you don't have to care about that. If you are not having active bleeding, heavy bleeding, washing out your materials, this oozing, let's say, it's nothing and it's normal. It's like eating medium well steak or rare steak. Okay, so this moisture is nothing and we don't have to care about that. It's coming out, you have to perform again your hemostasis protocol. So if the material is a lot and the bleeding is active, so you have to perform hemostasis again. So you have to remove your material, maybe performing deeper pulpotomy and putting sodium hypochlorite for like 10 minutes, waiting for these crystals, and then applying MTA again. Any questions? Combined treatment. No. Success. So it's about case selection. For example, for me, I have performed 3 cases till now. One of them is this case. Yeah. But if I do not recommend to take this and apply it tomorrow in your clinic. No, we have to wait still. We have to still wait and see what the science will talk about that. So this is very tricky. You must have strict protocol, magnification, good patient selection. You can't perform this for any patient. So this is, for example,
good credibility.
Yes, we have good outcome. I have 3 cases done only in my clinic, and all 3 cases are good, and I'm observing them. Everything is okay.
I mean, papers have cited that it can be applied in a wide range or not.
I can't sure that we can tell dentists, please start tomorrow to do combined treatment. No, no. We still have to wait. Any question? Thank you very much.
Thank you very much, Dr. Muhannad, for the very informative lecture.
شكرا شكرا.
السلام عليكم. إذا جاهز بلغنا عشان
Hello?
Our next speaker, Dr. Abdullah Abul, he graduated from Misr University for Science and Technology. He then completed his MFDs from Royal College of Surgeons in Ireland, 2011. He completed his master degree in endodontics from University of Manchester, 2016, followed by the membership of endodontics from Royal College of Surgeons from Edinburgh in the same year. Dr. Abdullah worked in multiple centers in Kuwait, and he's working in the private sector as well. He participated in many lectures in Kuwait and abroad. He is currently working at the Kuwaiti Board of Advanced General Dentistry as a lecturer and clinical supervisor. His title will be Trauma, Be a Hero. So please welcome with me, Dr. Abdullah.
Thank you. Thank you. Good morning, everyone. Thank you all for coming today. Your presence at this time of the day is highly appreciated, being so early. So I hope today's lecture is worth your time of coming today. So our topic today is about dental trauma. However, we will not discuss the different treatment scenarios of different traumatic dental injuries. Instead, what we will talk about today is these situations where root canal treatment is indicated as an emergency visit. And we will discuss some of the complications that happens after dental trauma, and which of those complications requires root canal treatment, and which of these complications doesn't require root canal treatment. So without any further delay, let's begin. Now, it's estimated that 5% of all body trauma is directed to the orofacial region, of which 1 to 3% is directed to the dental hard and soft tissue. Now, this percentage increases up to 17% during the childhood age. And it's estimated that 30% of dental trauma is directed toward the permanent dentition, and 20% is directed to the primary dentition. The maxillary central incisor is the most affected tooth when dental trauma happens. Again, it's estimated that about 1 billion people had experienced dental trauma during their life. Now, not only that, dental trauma is considered to be the 5th most prevalent disease or condition. It's the 2nd most common disease after dental caries, and a condition that is very common, a condition that is very popular, is very confusing when managing. Now, and the reason of that, according to Andreessen classification of dental trauma, he classified dental trauma into 4 main categories. And those categories can be divided further into subcategories. What we have is injuries to the hard dental tissue and the pulp. And those can be categorized into enamel fracture, uncomplicated crown fracture, and so on. Also, we have the classification for injuries to the periodontal tissue, and they will be classified into luxation injuries and avulsion and so on. Now, which gives us about 9 fracture types. It gives us about 6 types of luxation injuries. This will add up to 54 treatment scenarios. If you add the primary and permanent dentition, mature teeth, immature teeth, this will give you more than 100 treatment scenarios. Now, I'm not gonna lie, every time I face a dental trauma condition, I get confused. I try to remember the treatment guideline. So, this is a questionnaire that was done in Brazil, and they wanted to test the knowledge of their dentist. So the questionnaire was sent to about 14,000 dentists. The questionnaire was about 12 different trauma scenarios, and they wanted to test their knowledge of how to manage these scenarios. And they found that the average answer, they got about 6 trauma scenarios correct, and the other were answered wrong. So they found that female dentists, of course, answered better, they had better answers than the male dentist. They found that clinical experience, years of qualification, and the postgrad degree had a significant effect on the way how they answer those scenarios. Now, this is why I'm here today. I'm trying to tell you that you don't need to have more clinical experience. You don't need to have a postgrad degree. You don't need to have an experience of dealing with trauma, because basically all the guidelines are there on an open source. What you can do is you can go online and you find the guideline of how to deal with dental trauma. And I highly encourage you all guys, whenever you face a dental trauma in your clinic, is to go and review all the guidelines before dealing with your patient. This way you will ensure the best treatment for your patient based on evidence that will ensure the best prognosis. So going back to our subject, whenever trauma happens, what we have is a predictable response and unpredictable response. So By predictable, what I mean is something that we expect to happen after this type of injury. For example, avulsion, a mature tooth that have avulsed, we expect this tooth to have a pulp necrosis in the future. So this is what we mean by predictable. And then we can also call a favorable and unfavorable responses. And by favorable, I mean, for example, a tooth that has faced some type of trauma and then regain its vitality after a few months. And this is a favorable response. And by unfavorable, I mean, for example, root resorption or replacement resorption. So this is basically when root canal treatment is indicated. Whenever there is an unfavorable response that is predictable, root canal treatment is indicated. And this is how we deal with trauma cases. And this is how we should provide the treatment for all our patients. And I'm going to show you some of the cases where we did root canal treatment and some of the cases where we did not do root canal treatment and we just waited. So these are the responses of the pulp after trauma, and these are the common responses of the pulp after trauma. So what we have is pulp necrosis, we have color changes, canal calcification, root resorption, ankylosis, replacement resorption. Some of these responses are favorable, some of them are unfavorable, some of them requires root canal treatment, some of them doesn't require root canal treatment. And I want to emphasize on those complications that doesn't require root canal treatment. And I've seen a lot of mistakes, a lot of iatrogenic errors that happens because we tried to provide a treatment for a tooth that doesn't require root canal treatment, that doesn't require any management. The only thing you should have done is to wait and to follow up that patient instead of doing any root canal treatment. So these are, the green ones are the favorable responses. So, for example, recovery and return to normal. What I mean by recovery and return to normal is the pulp response is considered to be a favorable response. Pulp fibrosis is a favorable response. Pulp canal calcification is a favorable response, and we will have more slides about this subject in this lecture. So these are the favorable responses when it comes to dental pulp response. Some of the unfavorable responses is pulp necrosis, and I want to add up pulp necrosis and infection of the pulp space, because pulp necrosis alone is not an indication for root canal treatment. Pulp necrosis alone is not an indication for root canal treatment, and I'm going to show you why. And finally, internal root resorption. So these are the responses of the pulp. We have responses of the periradicular responses. So recovery and return to normal is a favorable response. Transition to apical breakdown is a favorable response. Cessation of the root development is a not favorable response and requires a management. Bone resorption is unfavorable response. Root resorption and ankylosis. So how are these responses, how do they happen? What are the factors that we can predict these responses in the future? So this is a very nice study that was done in the 1965 at the Department of Oral and Maxillofacial Surgery at the University of Copenhagen, and it lasted for about 50 years. So it's a very nice, valid study. And it had a lot of patient pool. And they found that there are some factors that can impact those responses of the pulp, and we can expect what will happen based on these factors. So they found that type of injury and stage of root development have a significant effect on the effect or the predictability of tissue responses in the future. They found that the larger the diameter size of the apical foramen, the better healing chances for the pulp. The shorter the pulp length is the higher chances for revascularization. I'm going to explain why. There is an increase. So this is why when dealing with trauma and dealing with patients that have mature teeth and increased age, they had less chances of healing in the future. Now, as I said, not all trauma types requires root canal treatment. Again, if you look at pulp necrosis after luxation injuries, it can range between 7 to 45%. But if you look at the first table, you will find that they didn't specify the type of injury. So they didn't mention whether if it was a luxation injury, whether if it was avulsion, intrusion, lateral luxation. So then what they did is they specified, they categorized those injuries. So if you look at the second table, you will find that concussion, and this is the number of the teeth in that study. Concussion, 67 tooth, 0% of those teeth had pulp necrosis. Again, subluxation, which is movement of the tooth in the periodontal ligaments. So 155 tooth was in that study, and 0% of those teeth had pulp necrosis. And then if you go to extrusive and lateral luxation, of course, intrusive luxation, you will have an increased pulp necrosis percentage. So what they found is the greatest frequency of pulp necrosis was noted in intrusive luxation injuries, followed by lateral luxation injuries, and of course, avulsion for mature teeth. And the least frequency of pulp necrosis was seen after subluxation. So this is an indication that not all type of injuries requires root canal treatment based on studies, based on evidence. And this diagram shows which type of injury have the best prognosis and which has the least prognosis. So if you look at the diagram, you will find that the concussion subluxation have the best prognosis in the future. So whenever a patient comes to your clinic and this patient have suffered from concussion or subluxation, you just follow up that patient, even if he was in pain. And by pain, it's very subjective, but you need to follow that patient. Don't do root canal treatment just because the patient have suffered from trauma, because not all trauma requires root canal treatment. Again, another factor that affects the prognosis of tissue responses is the pulp width and pulp length. And of course, by that, the reason why it affects because we need vascular supply to the pulp, and this vascular supply will help the pulp to regain its health after trauma. So of course, the bigger the diameter of the apical foramen, the better the chances for healing. The shorter the pulp length was, for example, a patient with an upper central incisor, aged 6, had a trauma, the better chances he will have healing because the diameter is wide and the pulp length is short and he have plenty of blood supply to that tooth. So now going to the main lecture. So as I said, not all complications requires root canal treatment. So pulp necrosis and negative response to sensibility test. And I want to emphasize on the term sensibility. I know a lot of you guys call it vitality test. But what I want to tell you in this lecture is we don't have a test that actually can tell us whether the pulp is vital or not. We don't have a test that can tell us that there is blood supply going inside the pulp. What we only have is those tests that can sense the responses of the pulp to the test that we are applying, and that's why we call it sensibility test. So, negative response, a patient comes to your clinic with a negative response to your sensibility test, and you think that the pulp is necrosis without any symptoms. Is this an indication for root canal treatment? We're going to answer this question in the coming slides. So, just as a general rule, guys, now, pulp diagnosis of traumatized teeth is very challenging. It's challenging to any experienced dentist, whether if you were a specialist or a general dentist. It's very challenging. Now, pulp and traumatized teeth can go under transition paresthesia. So it can give you a negative response when the patient comes to you in the emergency clinic. he can give you a negative response, and then it can respond normally to your test after months. So pulp traumatized teeth may undergo transition paresthesia. It may take up to 2 to 67 months to give positive response to your sensibility test, which means that don't do root canal treatment just because you had a negative response to your sensibility test. Now, what we learned from all studies and all clinical data, that all those tests that we have in the clinic are not accurate. And this is what I always try to teach my students in the Kuwaiti board. We don't have a test that can tell us what is the condition of the pulp. And now, as my colleague just tried to explain during the vital pulp therapy lecture, it's a case selection because they don't know the status of the pulp. We don't have a test that can tell us whether the pulp is necrotic. We don't have a test that can tell us whether the pulp is irreversibly damaged. We don't have a test that can tell us whether the pulp is infected. So all these tests, they are all subjective. They are not objective. We don't have a test that can actually tell us what's going on inside there. So what we're doing is, basically, we're trying to predict whether the pulp needs root canal treatment or not. Always consider that whenever trying to test your teeth in the clinic. Always consider that these tests are not accurate. Always be suspicious before doing your treatment. So don't rely on the electric pulp test. Don't rely on your cold test or heat test because they are unreliable. They are unreliable. The only reliable test we have is laser doplometry and pulse oximetry, and they are not applicable in the clinic. So what we're trying to do, again, negative response to your test is not an indication that the pulp is dead. I'm going to show you that. Now, this is a very nice study that was done on monkeys and on teeth that have been traumatized. Now, this study tested the permanent teeth of monkeys, and all the subjects that were included in the test, they responded negatively to the tests. So basically, they traumatized those teeth. Those teeth responded negatively to the cold and electric pulp test, and then they accessed those teeth. And the only indication that can tell us whether the pulp is vital or not is bleeding. So if there is bleeding, it means that the pulp is vital. If there is no bleeding, it means that the pulp is necrotic. Imagine the surprise when all those teeth bled when they accessed them. So negative response to cold test, negative response to electric pulp test. Okay, so the pulp is necrotic. They accessed those teeth, and all of them, they bled, which means that the pulp was vital. Now, the clinical implication, and I want to emphasize the clinical implication of that, is that the pulp tests are not accurate. Okay? So, it's not always associated with infected root canal treatment, negative response, or pulp necrosis, and it could be a result of severing the apical blood supply, for example, in cases of luxation or avulsion. It's considered an instant necrosis, and the tooth should be regularly reviewed. So negative response, don't do root canal treatment. If there is a concussion or subluxation, just review the tooth. Keep reviewing the tooth. The tooth came after 1 year, negative response. So what? Review the tooth. 3 years, 4 years, 5 years, 10 years. Just review the tooth. Don't do root canal treatment just because there is a negative response. And what we learned from Kakehashi, and those who are not familiar with this study, is that you need microorganism to go inside the pulp space to give you an infection or to give you an inflammation of the pulp. So, for example, some will argue that, okay, what if the pulp was necrotic and I didn't do root canal treatment? So what? Imagine that the pulp is necrotic and there is no bacteria inside the pulp. So there is no bacteria, there is no inflammation. Unless there is sign and symptoms, you don't do root canal treatment, even if the pulp is necrotic. And there is no way you can be sure whether the pulp is necrotic or not all you have is your subjective test. So it's sensibility test. So if you think that the pulp is necrotic without signs and symptoms, you don't need to do root canal treatment, because for the pulp to get infected, you need microorganisms to go inside, for example, bacteria, and to cause you an infection. Now, this is a case for a patient that showed to my clinic. He was 8 years old. He traumatized his upper right central. It was an uncomplicated con fracture with concussion. And when I tested the patient, he gave me a negative response. And I'm not sure whether if it's, and this is not a periodic radiolucency, by the way. These are the nasal opening. So the patient responded negatively to the tests. And we restored only the fractured part. And then he showed after a few years, you can see that there is a very nice root development. We didn't do root canal treatment. We didn't do any intervention, just a filling. And the tooth survived. Imagine doing root canal treatment for this, ruining this patient's life for forever, because you think that negative response requires root canal treatment. So again, we discussed these. You do root canal treatment only when there are signs and symptoms of infection. Signs and symptoms of infection include swelling, pain, sinus tract, root cessation, and periodic radiolucency. I'm going to show you another case. Now, this is a very nice case that I had in my residency for a patient that she was 20 years old. Now, this patient showed to the clinic complaining of discomfort and pain, but she wasn't in severe pain, actually. Her main chief complaint was discoloration of the crown of the upper left central. So when we took a PA, and this is very important for you guys whenever treating your patient, what you can notice is there is a cessation of root development. Now this is upper left central. The upper left central incisor have root completion after 2 years of eruption. So that will be at 8 years of the patient life. And this patient was about 20 years old. So does this tooth require root canal treatment? Yes, it does. It needs root canal treatment because the patient is in pain, she's in discomfort, and there is root cessation. Now, if you don't do any intervention in these cases, the patient may develop swelling and abscess. So we tried to do root canal treatment, and this is the CBCT for that patient. You can see clearly that the upper left central have root cessation. There is incomplete root development. Not only that, there is a apical fracture of the root. So what I did, I tried to, and back then I was just a postgrad student. My skills weren't that good. So I tried to do my MTA plug, couldn't get it over there because of all the granulation tissue and all that. So I did an apsectomy or endosurgery, and this is the follow-up for the case. So this is a case, an example for a case where there is an indication for root canal treatment. Another case for a patient that showed to my clinic, and I was doing an examination. She wasn't complaining of anything. So there is no pain, there is no chief complaint, and I was doing my routine examination, and I noticed there is a periapical radiolucency on the lower left lateral. I asked the patient, do you have any pain, any symptoms? I did my clinical test, percussion, sensibility test. Sensibility test gave me negative response, and my percussion test was all within normal limits. So now, I always take CBCTs. So this is the CBCT. And you can see clearly that there is a periapical radiolucency surrounding that tooth. Now, this patient is not in pain. You can see clearly that the tooth doesn't have any caries. She did mention a history of trauma, and she is my clinic. Now, this is a question that you need to ask yourself. Does this tooth require root canal treatment? There is no symptoms. There is periapical radiolucency, but the patient is not complaining of anything. So, okay, I know it's going to get confusing, but this doesn't require root canal treatment. Now, the reason why it doesn't require root canal treatment, because as we mentioned, you need signs and symptoms of infection. Periapical radiolucency is a sign and symptom of infection of the root canal space. Okay? Is- Do I need to elaborate on that? So periapical radiolucency is a sign of invasion of the microorganism inside the canal, unlike the negative response to sensibility test. So yes, this tooth requires root canal treatment, and that's what we did, root canal treatment, because there is a periapical radiolucency. Okay? All right, so some will argue, why did you do root canal treatment, or how did this happen for a patient? And I'm sure all of you guys have experienced this, being in the clinic, and you tell your patient that you have a tooth needs root canal treatment, and he say, I don't feel anything. I don't have any pain. What do you mean? So this is a study. This is a very nice study. It was a retrospective study. It reviewed all the patients that had root canal treatment, and 40% of those patients did not recall any symptoms. So that's a very nice study to back up your decision whenever treating patient and they are indicated for root canal treatment with no sign and symptoms. So they are not alone, actually. 40% of all patients requires root canal treatment, and they don't have any sign and symptoms. All right, so this is another study, this is another case, and a very nice case, and the reason why I put that case over here is because when you look at the PAs here, a patient had a uncomplicated crown fracture on the upper left central and concussion on the upper left lateral. All right, so you can see clearly there is a big periapical radiolucency. And when I did my sensibility test, and this is why it's very important that you do your tests to reach your diagnosis. So when I did my sensibility test, the upper left central responded negatively to the cold and electric pulp test. However, the upper left lateral responded positively. So normal response for the upper lateral and negative response for the upper left central. And there was a sinus tract. So when I traced it, it didn't give me much. It went in between both teeth. So I always, when I get confused, I do CBCT, and I highly encourage you guys to use this magnificent tool that can help you in your diagnosis. So when I did my CBCT, I found that the lesion was only surrounding the upper left central, and there is no lesion surrounding the upper left lateral. So adding that with my clinical tests, what we did is only root canal treatment for the upper left central. So this is how you should manage your cases. So clinical tests with radiograph, CBCT if you need, and then going to your treatment conclusion. So now, when it comes to sensibility tests and when it comes to pulp necrosis, it's essential. I mean, I know it's not reliable. Those tests are not reliable, but it's very essential that you have a baseline test. It's very essential that you put in your record that this patient on this day responded negatively to the pulp test, whether it was cold test or electric pulp test. Or this patient, he responded to the electric pulp test at 60 or 40 or 30. It's very nice to put that in a record. And then when you follow up that patient and going back to those records, you will find, if you find any improvement or not, it's all there in your notes. So now again, back to the pulp test. So it's essential to perform a different sensibility test at the time of emergency. These tests include both, should be cold and electric pulp test. Often will have no response at the emergency visit. However, that doesn't indicate pulp necrosis, as the pulp may recover. Sometimes it may take months or years to have a positive response. It's important to have a baseline to show the progress or regress. The best predictor for subsequent pulp necrosis as positive pulp response indicate reduced risk of pulp necrosis on the future. So on that, here what I mean is if you have a positive response at the day of emergency, this is a very good predictor for your pulp. Root canal treatment should only perform when there are clear signs and symptoms of infection. So pulp necrosis, periapical radiolucency, and so on. Again, another complication of dental trauma, and this is very interesting, is canal calcification and color change. And I've seen a lot of cases with errors and mistakes, and we had to extract teeth just because there was a discoloration on the tooth. I'm going to show you that. So is pulp canal obliteration or calcification is an indication for root canal treatment? So a patient comes to your clinic with a yellowish discoloration of the upper left central, and you ask him, did you have trauma before? He said, yeah, I did. I had a car accident 5 years back. So is this an indication for root canal treatment with the discoloration? Let me tell you this. It's a trap. Treating those teeth, you should be very, very careful and extra careful. And I'm going to show you why. So basically, canal calcification is not, again, so sensibility, negative response to pulp test is not an indication for root canal treatment. Also, canal calcification is not an indication for root canal treatment. You have a discolored crown, normal apical tissue. You took an X-ray, and there is a canal calcification. This is not an indication for root canal treatment. And this is what we're going to show you with those studies. So this is a very nice study. It was a retrospective study. PAs for 881 tooth that have suffered from trauma. Out of these 881 tooth, 41 showed canal calcification, which gives us a 3.8% of the sample. Only three teeth developed pulp necrosis. So, which means out of the 881 tooth, only 3 requires root canal treatment. Can you see that percent? It's huge. We're talking about 881 tooth, and only 3 requires root canal treatment. These are the teeth that had pulp canal obliteration. Not only that, most studies have showed that. Another study showed that only 7% of the canal calcification had pulp necrosis. Other studies showed only 1% of the canal calcification had pulp necrosis, which requires root canal treatment. So pulp canal obliteration, pulp canal calcification is not an indication for root canal treatment. More studies have showed the same, and it's thought that pulp canal obliteration happens more in immature teeth. So a patient with immature tooth that suffers from trauma will have more chances of having pulp canal obliteration or pulp canal calcification. And it means that the pulp is healing, actually. It doesn't mean that the pulp requires root canal treatment. And from the studies, we showed that only 7% of canal calcification requires root canal treatment. So is this a predictable, unfavorable outcome? Of course not. So pulp canal calcification is not an indication for root canal treatment unless there is signs and symptoms for root canal treatment. So this is a case he showed to my clinic. Patient came. He's complaining of the upper right central. My tooth is discolored, and I want to improve the aesthetic of that tooth. So, and when some dentist, he proposed to do root canal treatment, and I know a lot of you guys here will think of the same, to do root canal treatment and then internal breaching. Now again, as I said before, this is a trap. Whenever you see a tooth like this, consider a trap. So why am I saying this? Now the patient, these are the clinical examinations. So the age is 40, no symptoms, tooth discoloration, there is no periapical radiolucency. Again, I always take CBCT because I couldn't find any canal space here. Can you see on the PA? There is no canal space, only apically. So it's obviously that the reason of discoloration is tertiary dentine. Now, taking a CBCT, you can see that the pulp starts midway of the root. Now, accessing such tooth is a nightmare. There are a lot of things that can go wrong. Perforating that tooth is one of them. And then it will end up with extraction. So basically, is this case an indication for root canal treatment? No. Is this case an indication for internal breaching? Maybe, without doing root canal treatment. There is more studies are to be published regarding this subject. But this is not a case that is indicated for root canal treatment. So what do? Send it to a prosthodontist. He will deal with it. Maybe external bleaching or office bleach, maybe doing crowns, veneers, whatever. Don't do root canal treatment. Don't try to access that tooth. because you will end up with more headache that you can bear with. So again, this is a patient. He was sent to my clinic by a colleague. So basically, the chief complaint was that the patient had discoloration. I didn't have the photograph for the COM, but this patient had a discoloration, and his dentist tried to do root canal treatment and then internal bleaching, because this is the proposed treatment, and he didn't look that there is no canal space here. So he ended up perforating that tooth. Now, this is why you shouldn't do root canal treatment for calcified teeth. Anyway, if you're concerned about the patient, we managed that patient. This is the perforation. Clearly, he perforated the crown. Anyway, we managed that case, and alhamdulillah, the case survived, and there is no lesion and all that. But just try to avoid this. Whenever you see a discolored tooth, a yellow discoloration, canal calcification, don't try to do root canal treatment, and don't try to do internal bleaching. So this is another case. So the patient came to the clinic, again, yellow discoloration. He was complaining of pain, swelling, and pain. And if you see the periapical radiograph, clearly there is a radiolucency surrounding that root. But, and this is why I put these cases here, is just to show you the importance of doing a pre-radiograph before doing your treatment. There is no canal over here. You can't see anything. There is no canal. So what are you trying to treat when accessing that tooth? So we took a CBCT, and it was confirmed that there is no canal in the tooth. So what do? Send it to an endodontist. In this case, the reason why we did surgery, so we only did apical surgery, and the case healed beautifully because there is no canal lumen. So in this case, we did root canal treatment because there was a sign and symptoms of a lesion, as you can see, the periapical radiolucency. The ones before didn't have any signs and symptoms. The yellow discoloration. Sorry. So, pulp canal obliteration is an indication that the pulp have survived the trauma, and there is an evidence of revascularization. Clinically, there is a yellow discoloration that may appear due to the position of, in the statement they said secondary dentine. I think it was supposed to be tertiary dentine. Anyway, avoid doing prophylactic root canal treatment unless there are two signs and symptoms of pulp necrosis, periapical radiolucency or pain. This is the statement by the American Association of Endodontics. So pulp canal obliteration, pulp canal calcification, yellow discoloration, negative response to pulp test, all these are not an indication for root canal treatment after trauma. Again, the color change after trauma is an indication for root canal treatment. So this is the guideline for diagnosis of pulp necrosis. So the diagnosis of pulp necrosis should be based primarily on two or more of the following signs: color change, negative response, and periapical radiolucency. Again, they emphasize on the importance of making sure that there is a need for root canal treatment. So going to another type of trauma, and the reason why I chose this type of trauma, because it happens a lot to children. It happens a lot to developing child. And I want to emphasize the importance of trying not to do root canal treatment for a growing child. The reason why is to give it the chance to have a completely formed tooth. Now, when immature teeth, the aim is always to preserve the pulp. And the larger, as we said before, the larger the apical diameter, the better the chances for healing. And in cases of complicated crown fracture, always bear in mind that it's better to do pulpotomy or vital pulp therapy, even if the patient comes to you after a week of trauma, because the pulp have survived, and this have been showed by too many studies. For example, the classic study by Schweck in 1982, he showed that there is only about 2 millimeters of pulp necrosis and granulation after 2 weeks of complicated crown fracture. So a patient comes to you, comes to your clinic with a complicated crown fracture, exposed pulp, and he tells you that I had a fracture that was 1 week before. You can still do vital pulp therapy, and I highly encourage you guys to do vital pulp therapy whenever it's possible in order to preserve the pulp. So, and this is what you're trying to do. So in cases of trauma, and as we said at the beginning of today's lecture, that it happens a lot to growing children. So you will be seeing this a lot in your clinic for a growing child. You should have done vital pulp therapy in order to allow for root completion, as you can see in this case. Now, going to some of the cases that we have, this is a slide to show you the difference between epixification and repair and apical plug, but we don't have time to go through all that. Now, this is a case that was done by one of my colleagues, very excellent pediatric dentist. He had a child with a complicated crown fracture, exposed pulp. He did vital pulp therapy, which was full pulpotomy, and then restored it with a composite. And you can see the beautiful result, how the pulp have developed, and it works, guys. It really works, and I highly encourage you again to do that. And this is a very nice case by my colleague, Dr. Mohammed Ashkanani. Congratulations on your winning on that competition. So this is a case where he have managed, very well management for a complicated crown fracture, very well documented. So the patient came after 1 day of trauma with an exposed pulp, and the patient, fortunately for the patient, he had the fragment with him. And then what he did, Dr. Mohammed Ashkanani, is he did a shfek pulpotomy, and then he created some grooves over the enamel and dentine to restore that tooth with the same fragment. And it's a very viable treatment, very amazing treatment that can give you very nice results. This is the tooth after being restored with the fragment, as you can see here. Very nice result, Dr. Mohammed. And
Dr. Abdullah, 1 minute.
I have 1 minute? Anyway, so okay. Since I have 1 minute, I'm going to show you a very nice case. I'm not going to go through all that. Okay, this is a very nice case, and a very good case that can show you when a root canal treatment is indicated during the emergency visit. So this is a case where there is a tooth avulsion, and this is a case where there is a uncomplicated crown fracture for both central. So this is Dr. Abdullah Al-Saimi. He was one of our residents. Now he's our colleague in Al-Jahra Hospital. So basically what happened is the patient had tooth avulsion on the upper right central, and his mom was very educated mom, and what she did is she replaced that tooth back in the socket, and the patient came to our clinic where Dr. Al-Saimi stabilized that tooth, and then we saw the patient after 2 weeks. This is, by the way, we got the fracture segments from the patient lip. That's why there is sutures. Anyway, what I want to show you is, so this is the avulsed tooth after 2 weeks. And this is the tooth that has suffered from concussion. So Dr. Al-Saimi wanted to do root canal treatment for the upper right central because for aesthetic reasons. So they want to place a crown and so on. But can you see this? This is a tooth after 2 weeks. So the root was completely formed. The tooth has avulsed. They replaced it immediately. So this is an indication, and this is why we do root canal treatment during the emergency visit for teeth that have avulsed. As you can see, the pulp is necrotic, and the upper right central has a vital pulp. And it's a very nice demonstration that shows you why we do root canal treatment after 2 weeks for avulsed teeth with complete root formation. And this is why we do also root canal treatment for cases where there is an intrusion and lateral luxation. I wish I had more time to show you more cases, unfortunately. It's only 45 minutes. But thank you all for coming today. It's nice seeing you again. And I hope this lecture have showed you some insights of dental trauma and when to do root canal treatment. Thank you.
Thank you, Dr. Abdullah,
Thank you.
for your outstanding presentation as usual, mashallah.
Thank you.
Unfortunately, there is no time for questions, so please accept our letter of appreciation.
No worries. حبيبي دكتور أشكرك. ها؟ حبيبي أشكرك. لا لا عادي حبيبي. Thank you.
Should I start now? Start now? Hello, good morning, everybody. Are you ready? the ugly. Dr. Abdullah Abdus is a registered endodontic specialist currently working at Bnadel Dental Specialty Center. He started his academic journey at the University of Western Ontario in Canada and went on to achieve his bachelor degree in dental surgery from University of Jordan for Science and Technology. He completed his Master's of Science degree in endodontics through the University of Manchester with a special interest in root resorption and regenerative endodontic procedure, the latter which was the topic of his dissertation. He holds a membership in endodontics from both the Royal College of Surgeons of Edinburgh and the Royal College of Surgeons of England. He is the current head department of endodontics in the primary health care centers. As a head, he evaluates, diagnose, and supervise overall patient care, and maintain standards, practice, protocol, response to, and investigate the complaints. Also, he developed connections with dental providers and supports the learning of newly graduate dentists. Please welcome with us Dr. Abdullah Abdus.
Good morning, ladies and gentlemen. Thank you, Dr. Sharifa, for the very kind introduction. And thank you all for your time. It is such a privilege to be able to speak today in front of such a wonderful crowd. For those who don't know me, my name is Abdullah. As Dr. Sharifa said, I qualified as an endodontist from the University of Manchester and hold memberships in endodontics from both the Royal College of Surgeons of Edinburgh and England. For those who do know me, hello again. As you can see on the screen, our topic today is about root resorption. And this topic is particularly relevant to all dental practitioners across the board, from our heroes in primary care to my specialist colleagues. So, my aim with this presentation is to get you to become familiar with dental resorption. Over the next hour, I'm going to discuss the pathological processes involved in resorption, discuss the classification of different resorptive lesions, highlight common factors implicated in the pathogenesis of resorption, provide an overview of the clinical manifestations of root resorption, and then finally discuss the diagnosis and management of said resorptive defects. So, what is root resorption? Well, it is the progressive loss of dentin and cementum through the continued action of osteoclastic cells. Resorption can occur both internally and externally, and is known to be initiated and maintained by many factors. The most commonly described stimulants include pulp necrosis, trauma, periodontal therapy, orthodontic treatment, and tooth whitening agents. The process of resorption is largely inflammatory in origin, and without intervention, premature loss of the affected tooth may occur. So, to understand the pathophysiology of resorption, we first have to find out who the main culprit is. Unanimously, the jury has spoken, and they have linked the resorptive defect to osteoclasts. So what are osteoclasts? Osteoclasts are large multinucleate cells found within the crypts of heart tissues. They are the main drivers of resorption and can break down bone, cartilage, and dentin. They are highly motile, and the surface that is contact with bone and dentin has a highly ruffled border. Well, why is that important? Because within those borders, hydrogen ions and proteolytic enzymes are released into heart tissues, creating highly acidic environments that lead to the dissolution of the calcified heart tissues. There are also chemical signals such as osteoclast differentiation factors, osteoprotegrin ligands, and rankle that are known to control the formation of osteoclasts. Rankle receptors are found on the surface of macrophages and monocytes, and their release stimulates these macrophages and mononuclear cells to fuse and become osteoclasts. So in order to keep osteoclastic activity in check, we have osteoprotegerin, which is a chemical signal secreted by osteoblasts. And they act by inhibiting rankle and as a result, halting bone resorption. It should be stated that in addition to these chemical signals, a significant stimulus to the resorptive process is the presence of bacteria. In the presence of bacterial lipopolysaccharides, leukocytes differentiate into osteoclasts. It should be noted that unless the stimulation from the bacteria is continuous, the resorptive lesion will cease and repair will follow. Right, so clinically, resorptive lesions are very rare because we have biological protection mechanisms that exist to prevent resorption of teeth. These barriers include vital periodontal ligaments, healthy cementum, and the presence of the predentin layer. It has been shown that teeth with vital periodontal membranes undergo less resorption than those that have the membranes damaged and necrosed. Furthermore, the presence of intact cementum offers resistance to resorption, as cementum has been postulated to contain inhibitory factors for osteoclastic processes. Additionally, cementum is also thought to prevent the spread of bacteria and toxins from dentin to the periodontal ligament. Internally, the odontoblastic layer and the surrounding predentin have also been theorized to confer internal resistance to resorption. So, moving on now to classification of resorptive lesions. Resorptive lesions are classified as either, as I said, external or internal. In the former, the lesions occur on the external aspect of the root. In the latter, the lesion occurs within the root canal system. This classification that we're going to use is put forth by Andresen. And as you can see, external resorption is subdivided into 4 categories. Internal resorption is further subdivided into 3 categories. So, what is external surface resorption? External surface resorption is a small superficial resorption in cementum and the outermost layer of dentin. This process is a consequence of localized and limited injury to the root surface. It is self-limiting and therefore will heal uneventfully. External inflammatory resorption is also a continuation of the surface resorption that I just talked about, and is a result of a prolonged stimuli to areas of damaged root surface. Etiological factors that have been implicated in the inflammatory resorptive defect include trauma, infected and necrotic pulps, and the application of pressure. This process is significant in that it can completely resorb roots in months if left unchecked. Another subtype of external resorption is external cervical resorption, and it is a localized resorptive lesion of the cervical aspect of the root, below the epithelial attachment. Unless the lesion is extensive, there is rarely pulpal involvement. Expansion of the cervical lesion can extend both coronally and apically, encircling the pulp. The pulp, however, remains protected by the predentin. As the lesion progresses, there may be significant tooth structure loss. While the etiology of external cervical resorption is poorly understood, predisposing factors to the process include trauma, periodontal therapy, and whitening agents. In contrast to the other subtypes that we just talked about, external replacement resorption is the process of replacement of root with bone, otherwise known as ankylosis. The resorptive process can be transient or can be progressive. If it is progressive, then the tooth may be lost in 3 to 7 years in patients aged 7 to 16. In adults, the tooth may survive up to 20 years. Now moving on to internal resorption, the process of internal root resorption takes place, as I said, within the root canal system. There is an association between internal resorption and traumatized and replanted teeth, or those that have been undergone pulpotomy and crown preparations. In internal resorption, there must be vital pulp tissue apical to the osteoclasts to provide blood supply. And you also have necrotic tissue coronal to the osteoclasts to maintain the stimulation. Internal resorption can be either transient or can be progressive. An example of transient internal resorption is internal surface resorption. It is analogous with external surface resorption, and it is self-limiting without further stimulation. On the other hand, internal inflammatory resorption is a progressive process characterized by ovoid enlargement of the pulp chamber or the root canal. The enlargement extends in an apical and lateral direction, and there may be chronic inflammation present. Internal replacement resorptive defects are rare and are characterized by diffuse areas of mixed radiolucencies and radiopacities. The presence of cancellous-like bone within the root canal system leads to the obliteration of the canal space. As stated before, resorption is a multifactorial disease, and there are many factors implicated in the pathogenesis of resorption. These factors include pulpal disease and periapical pathosis, periodontal disease, trauma, and orthodontics. Furthermore, impacted teeth, expanding pathological lesions, viral challenges, and systemic diseases also play a role in the initiation of the aforementioned resorptive lesions. With regards to pulpal and apical disease, it is widely known that caries elicits an inflammatory process within the pulpal tissues. This results in the production of nonspecific inflammatory mediators. If the protective predentin layer is damaged, then osteoclasts may bind to dentin, and osteoclastic activity may be stimulated, resulting in internal resorption. A blood supply, as I stated, is required to maintain the inflammatory process. Therefore, there must be vital pulp tissue, apical to all sites of resorption, and coronally, as I said, pulp tissue must either be partially or completely necrotic. Once the pulp becomes completely necrotic, the internal resorptive process will cease, and apical resorption commences. This apical resorptive defect may also be further stimulated by the presence of periapical granulomas. The mechanism by which periodontal disease contributes to resorption initiation is a bit poorly understood. In the process of gingivitis, low-grade continuous inflammatory processes in response to persistent challenges of bacterial plaque leads to apical migration of the epithelial attachment. This apical migration exposes root surfaces and make them more susceptible to resorptive processes. So traumatic injuries to teeth may result in resorption, as Dr. Abdullah before me said. For this to occur, there must be damage to the protective barriers that I mentioned, which are cementum and the PDL. The likelihood and extent of resorption is related to the extent of damage. Larger areas of cellular damage heal with osteogenesis, and thus external replacement resorption may follow. Most damage, as Dr. Abdullah said, follows apical intrusion due to crushing of the cemental cells as root surface and bone collide. Intrusion is the greatest cause of unfavorable healing post-trauma, followed by avulsion. The duration of time between avulsion and replantation, and the choice of storage media are both critical for the survival of cementum and periodontal membranes. Resorption has also been reported in 19 to 31% of all patients undergoing orthodontic treatment, with its prevalence being highest in mandibulary and maxillary central incisors. This may be because incisors tend to be moved the furthest. One meta-analysis has indicated that the apical distance moved and the duration of treatment is correlated to the mean apical resorption. When occurring in adults, resorption may be more extreme. In well-planned orthodontic treatment, the forces applied to the teeth should be relatively evenly spread over the root surface. There are, however, some instances in which the forces can be focal and greater around certain regions. Such forces compress the periodontal ligament, initiating an inflammatory process and stimulating the development of osteoclastic cells that attack cementum. It should be noted that until all necrotic tissue is removed, resorption continues irrespective of the halting of orthodontic treatment. Similar to orthodontic treatment, ectopic teeth and expanding infrabony lesions, such as cysts, giant cell granulomas, and ameloblastomas, have been observed to induce pressure-related root resorption. Impacted teeth may stimulate root resorption if the follicular space encroaches upon the periodontal ligament of adjacent teeth. With slowly expanding lesions, the resorptive defect is often focal and well-defined. If the lesions are expanding quickly, then the resorptive defect appears much more limited. Therefore, the presence of intact roots within an expanding bony lesion is indicative of a rapidly expanding pathological lesion. There are also certain disorders that may be associated with resorptive lesions. Hyperparathyroidism is a rare condition characterized by overproduction of the parathyroid hormone. Excess parathyroid hormone results in increased dental tissue resorption. Viruses have also been implicated in the pathogenesis of root resorption. Von Arx suggested that a potential link exists between multiple cervical resorptive lesions and the feline herpes virus, so in cats. Other authors have also described a link between herpes zoster and resorption. Caution should be exercised during operative procedures as well. Ultrasonic devices and warm obturation techniques are capable of generating very high temperatures within dental tissues. Temperature increases above 47 degrees have been shown to elicit inflammatory tissue responses and, as a result, resorption. Similarly, care should be taken when using internal whitening agents, as the byproducts of said agents have been demonstrated to pass through dentinal tubules into the cervical periodontal membranes. Hydrogen peroxide denatures dentin and lowers the pH to a point where it can activate osteoclastic cells. Finally, there have been several reports of resorptive defects with no evident etiological factors. Several theories have been put forth, but it is thought that genetics could play a role. So, diagnosis of root resorption is based on proper history taking, on proper clinical examination, and on radiographic findings. So, diagnosis of root resorption should be based on, as I said, sound clinical history. Teeth affected by root resorption are often asymptomatic and present as incidental findings upon radiographic examination. Therefore, it is essential to pay attention to the aspects of history that may play a role in the development of resorption. As I said, these include the history of trauma, crown preps, pulpotomies, and orthodontic treatment. Use of intrapulpal whitening agents should also be noted. In addition, to history of removal of impacted teeth, surgical procedures in proximity to the affected roots, and periodontal disease. In cases where multiple teeth are involved, it is worth investigating whether the patient has pet cats, because as I said, the feline herpes virus is implicated. A full extraoral and intraoral clinical examination of the relevant tooth should be carried out. The color of the tooth should be noted with specific reference to the site of the discoloration. Pinkish discoloration in the cervical portion of teeth is indicative of resorption. The use of percussion is also of relevance, since any metallic sounds may be indicative of external replacement resorption or ankylosis. Assessment of mobility is also diagnostic, since complete loss of physiological mobility may again indicate ankylosis. If resorption is suspected, then one or more periapical radiographs should be taken using the parallax technique. This is of importance as it can help us distinguish external defects from internal defects, with internal defects remaining in a similar position relative to the root canal when the position of the beam is shifted. As widely known, routine dental radiographs have their own inherent limitations. These include superimposition of anatomical structures, distortion, and them being two-dimensional. Therefore, cone beam or CBCT can enhance the diagnosis of resorptive defects because it enables the precise determination of the site, the type, and the extent of the lesion. So how do we diagnose external surface resorption? External surface resorption is usually subclinical. Radiographically, it presents as just cavitation or cratering in the cementum and dentin with alteration of the root contour. There is no corresponding inflammatory response in the periodontal ligament, and there is no destruction of bone. This type of resorption, as discussed previously, is self-limiting and requires no treatment. External root resorption or external inflammatory root resorption is also subclinical unless there is acute inflammatory process. The lesion is often an incidental radiographic finding. So we have two types of inflammatory lesions, as Dr. Abdallah said. We have the sterile and we have infective. Sterile inflammatory resorption is associated with pressure, including orthodontics, impacted teeth, and expanding pathological lesions. Sterile inflammatory resorption presents as shortening and blunting of the root apices and usually give a positive response to pulp testing. If there is history of trauma, the extent of resorption may be more extensive and there may be loss of vitality. Infective inflammatory resorption, on the other hand, is associated with trauma and or pulpal disease. When the process is endodontically driven, the resorptive area is associated primarily with the apex. In the mildest form, there simply might be some loss of bony architecture. In the more severe forms, extensive loss of hard tissue can be seen, and the pulp responds negatively when tested. Now moving on to external cervical resorption, it is a resorption lesion on the external cervical aspect of the tooth. It is often asymptomatic, though there might be some mild discomfort and irritation from the adjacent gingival tissues. Initially, there is no pulpal involvement, but the lesion may communicate with the pulp if it becomes significantly advanced. Clinically, the cervical enamel may appear pink due to the presence of vascular granulation tissue within the cavity. Probing of the lesion elicits profuse bleeding, with the cavity edges feeling sharp, thinned, and rough. Unless the lesion is very extensive, the tooth will respond positively to pulp testing. Diagnosis of ECR can, however, be problematic if the cavity cannot be visualized. External cervical resorption is difficult to distinguish from internal resorptive defects, as both present as pink teeth. Therefore, differentiation between the two is based on radiographic examination, as I said, using the parallax technique and CBCT. Radiographically, external cervical resorption defects present as irregular radiolucency in the cervical region of the root, with possible corresponding loss of alveolar bone. The periphery of the lesion appears to be superimposed upon the outline of the pulp cavity. Interproximal lesions are more readily detected, but care should be taken to not mistake these lesions from burnout on radiographs. In advanced cases, the lesion may appear multilocular with loss of root canal radiographic continuity. Conventional radiography does not allow for three-dimensional imaging and assessment of ECR. As such, CBCT is a valuable diagnostic aid. External cervical resorption can be further subclassified based on radiographic imaging. Based on periapical radiographic imaging, Hethersay subdivided cervical lesions into 4 classes. In class 1, lesions penetrate the root dentin at the cervical region. Class 2 lesions are a bit deeper, and they become more close to the pulp, but they remain within coronal dentin. Class 3 lesions are more extensive, and they involve the coronal third of the root. And class 4 lesions are lesions that extend into the coronal half of the root dentin. In class 4 lesions, the pulp may become completely enveloped and may become involved in advanced cases. In contrast to Hethersay's classification, the Patel classification describes the nature of ECR in 3 dimensions based on CBCT assessment. This new classification takes into account the height of the resorptive lesion, measured in the coronal aspect of a CBCT image. A class 1 lesion is found at the cemento-enamel junction or coronal to the alveolar crest. A class 2 lesion extends into the coronal third of the root and is subcrestal. A class 3 lesion extends into the mid-third of the root, while a class 4 lesion extends into the apical third of the root. In addition to the height of the lesion is also classified based on its circumferential spread, as seen in the axial plane of a CBCT image. A classification A is when the lesion spreads less than or equal to 90 degrees. A classification B is when the spread is between 90 and 180 degrees. C is when it's 180 and 270. And the classification D is when the spread is greater than 270 degrees. The defect is furthermore classified based on its proximity to the root canal. A D classification indicates that the lesion is confined to dentin, whereas a P classification indicates that there is probable pulpal involvement. So in any case that we can see, we have to classify them in these 3 categories. Moving on now to internal defects. In teeth with internal inflammatory resorptive defects, there might be, as I said, history of trauma, vital pulp therapy, or crown prep. Internal resorption may present as a pink tooth, and this is due to osteoclastic activity thinning the dentin to the point at which granulation tissue underneath the enamel shows through. The tooth is often partially vital, as I said, and there may be some signs of pulpitis. It should be noted that pulp testing may be inconclusive because, as I said, we have vital tissue apical to the osteoclast, and we have partial or complete necrosis coronal to the osteoclasts. Radiographically, the defect appears as an oval-shaped radiolucent lesion that often spreads symmetrically within the root canal system. Internal replacement resorption results in asymmetric and irregular enlargement of the root canal, but with a bit of distortion of the root canal anatomy. The canal may appear obliterated or replaced with radio-opaque areas with loss of root canal walls. The defect may appear as a pinkish area in the crown of the tooth, and when pulp testing the tooth, will usually respond normally unless there is a crown root perforation. So, how do we manage these resorptive lesions? The fundamental principle related to the management of any resorptive lesion is to halt the activity of the osteoclasts. This may be done by removing the source of stimulation, reducing osteoclastic activity, and stimulating repair. In cases of resorption due to pressure, it may be possible to remove the stimulus by, for example, extracting an impacted tooth or halting active orthodontic treatment. In cases of resorption due to pulp necrosis, root canal treatment is the key to success. The decision as whether to treat or not depends on the degree of resorption, the activity of the lesion, and the etiology. So mild resorption related to ortho treatment, for example, will not require intervention other than reduction or cessation of the forces. Whereas internal resorption of any kind most certainly will require direct intervention. Heather divided the management options for resorptive defects into 4 categories. 1, conditions that will respond to conservative endo treatment. 2, conditions that will require surgical endo. 3, conditions that will require multidisciplinary treatment. And 4, conditions that will not respond or do not require treatment. Therefore, treatment should only be initiated if it will improve the prognosis of the tooth. So, how do we manage external inflammatory resorption? Prevention is essential. So, patients at risk of dental trauma should be provided with custom gum shields. Furthermore, patients with a class 2 Div1 incisor relationship should be advised about the benefits of ortho treatment. Judicious management of traumatized teeth should also be carried out in order to reduce the possibility of resorption. Ideally, avulsed teeth should be immediately and gently manipulated back into their sockets. If replantation is not possible, then the tooth should be stored in suitable storage media, such as saline, milk, or even under the tongue. It is important that the extraoral period be reduced to under 90 minutes. Exceeding that time significantly lowers healing. Once the tooth has been replanted, a functional splint must be placed and kept up for up to 2 weeks. Patient is then kept under regular maintenance, and if resorption does occur, then treatment must be considered. Management is largely based on the etiology and whether the process is sterile or infective. If the stimulus is sterile due to ortho movement, then management, as I said, is by reducing the forces. If resorption is due to stimulation from an infective process, such as pulp necrosis, then orthograde endo treatment is the treatment of choice. It is wise to favor a multiple visit approach, since the intracanal medicament that we use, which is calcium hydroxide, can eradicate bacteria, can necrotize osteoclasts, can neutralize the acidic environment that the osteoclasts produce, and can stimulate repair. Surgical endo may be required when orthograde treatment is not possible, such as when an impediment to the canal exists. Where impacted teeth are involved, several factors should be considered. If the impacted tooth is valuable, then efforts should be taken to expose and align that tooth. If not, then removal of the impacted tooth is carried out. Now moving on to external cervical resorption, several factors have been implicated in the stimulation of cervical resorption, and thus prevention, again, is of the utmost importance. Concerning whitening, or internal whitening, the guttapercha and the floor of the cavity should be sealed with either glass ionomer or composite to prevent passage of bleeding agents through the dentin, of bleaching agent through the dentin. The restorative material to be placed should be at the level of cemento enamel junction and should be at least 2 millimeters thick. In cases of periodontal therapy, clinicians should avoid damage to the root cementum and the periodontal ligament where possible. Finally, regarding ortho treatment, excessive tipping forces should be minimized to reduce the risk of cervical resorption. The focus of treatment in external cervical resorption is always to access the resorptive lesion, remove the resorptive tissue, and restore the cavity. The site, extent, and the pulpal involvement dictates the treatment protocol. Heathersay suggests that class 1, class 2, and class 3 lesions are restorable, whereas class 4 lesions are rarely so. If the lesion is readily accessible and appears radiographically less advanced, then direct non-surgical access is possible. For lesions that cannot be accessed non-surgically, a simple direct surgical approach is the most sensible treatment of choice. If there is pulpal involvement, then root canal treatment should be initiated, but not completed until the defect has been managed. This is carried out by raising a full thickness flap to allow maximum visualization, and then accessing and curetting the lesion until no bleeding is present and the cavity walls are sound. The cavity may then be conditioned with 90% trichloroacetic acid to improve the removal of the osteoclastic cells. A range of materials may be used to restore the cavity. However, MTA is the most appropriate as it is extremely biocompatible, has excellent sealing abilities, and is able to regenerate periodontium and bone. It should be noted that management of multiple idiopathic cervical lesions is challenging due to their progressive and recurring nature. As such, the only definitive solution is extraction. Moving on now to external replacement resorption, it should be noted that once replacement resorption is established, there is no effective treatment. Progression will result in the complete resorption of the root and eventually crown fracture. In older patients, the progression is slow, whereas in younger patients, the progression is more rapid. For management of external replacement resorption, the following options may be considered. 1, accept the position and restore the incisor level with composite, and then monitor the tooth. 2, extraction of the affected tooth, and then auto-transplant with a premolar as a donor tooth. 3, surgical repositioning through extraction of the affected tooth and then replanting it again. Theoretically, that is thought to promote healing by breaking the bony contact with the root. 4, in adults, extraction and replacement should only be considered if pathological crown fracture has occurred, since the disease process is slow. In children, extraction should be timed with the start of the adolescent growth spurt, which is around 13 years of age in girls and 15 years of age in boys. After extraction, the space may be filled with a removable or fixed prosthesis, an implant, or the space could be orthodontically closed. If the root is not expected to resorb within a year, then decoronation may be regarded as a suitable alternative to extraction. In adults, this may be considered 2 years before implant placement. Decoronation is carried out to prevent extensive bone loss associated with extraction and to preserve the alveolar ridge height and width. The aim of treatment in internal root resorption is to remove any stimulus and vital tissues that are perpetuating the resorptive defect. A multi-visit root canal treatment is thus the treatment modality of choice. In the first stage, access should be minimal to preserve maximum tooth structure. Chemical disinfection is essential, with sodium hypochlorite being the irrigant of choice. Passive ultrasonic irrigation is also crucial to ensure that the irrigant reaches all the undercuts and crevices within the resorptive defect. It is impossible to totally eliminate the bacteria from the irregular crypts, and thus, intracanal medication with calcium hydroxide is used to further decontaminate the root canal system. In the second visit, obturation is completed with the apical portion of the root canal being obturated using continuous wave compaction. The resorptive defect is then filled with flowable guttapercha to ensure optimum three-dimensional fill. If the lesion has perforated, however, then MTA is the material of choice. Finally, management of internal replacement resorption follows that for internal inflammatory resorption. Clinicians should be aware of the additional level of complexity owing to the presence of calcific tissues. The use of endosonics may aid removal of mixed calcific tissue, obstructing access to the root canal system. Now, why did I call my presentation the good, the bad, and the ugly? Well, I'm going to show you some cases of the good, some cases of the bad, and some cases of the ugly. This case was actually the son of Dr. Abdullah Al-Ibrahim. He's the head of Ahmadi Dental Services. And what happened is, he went out bowling with his friends, and he knocked his tooth. And there was a complex crown fracture. It's a good thing to have a dentist as a father, because right away, he got him into the clinic. He sealed the pulp with setting calcium hydroxide, and then he cemented the tooth fragment. However, a year later, the patient began having symptoms. And therefore, we decided to do root canal treatment. There was some tenderness to percussion, and the pulp was not vital. It was a good thing that we caught it early, because as you can see at the apex in the third picture, there was just a slight resorption, so just the beginning of resorption. This is another case where we have internal root resorption. Sorry about the x-rays, I know it's not that clear. But it's also one of the relatives of a colleague of mine. Why did I say it was good? Because the internal defect did not perforate the root canal walls. So we just did it over a 2-visit approach. We got in, irrigated, activated the irrigant, and then the second visit, we compacted MTA. What I like to do with MTA is, once I'm compacting it, put an ultrasonic unit to the plugger so it can just disperse the MTA. Now, the bad. So we have this case, and it came to the clinic for a retreat of the lateral. You can see how much of the root structure that was lost. So if I'm going to guess, that's around 3-4 millimeters of root that was lost. So again, 2-visit approach. The old filling was removed. It was cleaned, shaped, intracanal medicament was placed, and then in the second visit, it was obturated. These are also other examples of bad resorptions. So as you can see in the upper left 5 and the upper left 2, a significant amount of root structure has been lost. Now, the ugly. So this is a case of an external cervical resorption of the upper left 3. As you can see on the PA, the patient didn't even complain of that tooth. He came for another tooth, as you can see with the sinus tract tracing. Upon CBCT imaging, we can just see how extensive that lesion is. And this is also another case of an ugly. That's also an external cervical resorption. And this patient was AC technician. And when I asked about the history, it was around like 3 months ago. He was repairing an air conditioning unit, and he fell from the ladder, and he knocked himself. So as you can see, just how progressive that lesion becomes. You have 2 entries. You have a palatal entry on the axial view, and you also have a mesial entry. And then finally, this is just a bit of miscellaneous cases, where you can see the lower right 6, external inflammatory resorption. You have significant loss of the distal root. With the upper left 2, you can see a very big internal resorptive defect that is perforating the canal wall. The upper right 2, also suffering from internal root resorption. The lower left 6, you can see just how significant and how rapid external replacement resorption is. With the lower left 1, this patient was referred by my orthodontic colleague, and you can just see how much root she lost. So in that case, Again, multi-visit approach, and the canal was filled with MTA. So, in closing, there are two things that I'd like you to remember from today's presentation. First, resorption presents with a range of etiologies and prognoses, and thus, practitioners must be aware of when to intervene and have to have the confidence to do so. Delays in treatment due to late or erroneous diagnoses may be catastrophic. And second, the outcome of treatments provided may be uncertain. Therefore, patients should always be informed of this. Thank you all for your time. And if anything was unclear, I'd be happy to open the floor to questions.
Thank you very much, Dr. Abdullah Abdussamad. Unfortunately, we will not be able to take any questions due to time. Thank you again.
Thanks.
And
The first point is that he did a lot of research in pulp biology and microcirculation back when he was at Columbia University, which was revolutionary. It shaped our understanding of pulp biology today. The second, he introduced the dental microscope to endodontics, and that was in 1992, and he trained so many dentists, thousands of them, to use the dental microscope. So today, if you are using a dental microscope, I think the credit should go back to Dr. Kim. Third is microsurgery. Dr. Kim developed special instruments for microsurgery, which was revolutionary. And he also authored the textbook of microsurgery. So please welcome Dr. Kim.
Can you hear me? Can you hear me, huh? Okay, good. Thank you very much for a kind introduction. This is the first time in this country. I just arrived 2 o'clock this morning, so I haven't seen your country yet. But I heard a lot of wonderful things. And the topic I'm going to talk today is a not well known in endodontic circle in America. Yes, we know. How many people are practicing another issue? But I'll describe to you what it is, why this technique is so important for us. Not just like a show-off, that's not what it is. And I think we have been teaching this for 32 years in our department. And so I would like to share my experience, history, and all the things with you this coming 2 hours. And I'm very happy to see 3 of you have been trained at Penn. And he's one of them. And I see 2 ladies I saw, and it was so nice to see a former graduate. The topic is endodontic microsurgery. Most of the dentists think that microsurgery, what is that? That's a fancy stuff. I'll tell you what, and you will hear, it's completely different stories. I'm not here to advertise microsurgery. I'm here for you to learn it and practice it. I'll tell you why it's so important for us. Implant is not important. Natural teeth is important. You gotta know fairly. I'm the first one in America learn implant 1978, because Ingemar Bremark was my PhD teacher. So I'm the first one to learn implants. And I did many implants, lots of problems. And I'll show you what it is. And saving teeth are our responsibility. So, first of all, I'd like to introduce to you my department and my university. In 1947, this is the first endodontic program in the United States. And I'm very proud of all these frontal leaders. Of course, they all passed away. And I think that is. And this is our clinic, main clinic for dental students, the most modern clinic in the world, period. You cannot compare with anything. My job now is Dean of Global Affairs. I travel all around the world and visiting schools and making a relationship. So I know all the dental school. I haven't seen your school yet. Of course, I saw Saudi, I saw Jeddah, I saw Riyadh. I saw all of them. No comparison to what we have in our department. Absolutely modern to the best extent. This is our endo department. Of course, it is most modern and clinic, and facilities are superb. I would like to all you visit us, and we have a monthly training course of subject matter going on for 32 years. This is probably longest a continuing education course in the world. I don't know any places any more than that. This is our team. I call Dream Team because American basketball team was a dream team, an Olympic many years ago. We got the award, and we have a fantastic professors. They are all around the world giving the lectures, and I'm sure some of them will come here in the future. We organize many of the symposiums, big one. Usually in China, we have 3,000 people attending it. So we pull Penn Global Symposium. Why? Because in our student body, we have 14 different countries of students coming in. We have many Saudi Arabian students. Of course, we have 3 of you here. And symposium has been going around. We went around 22 different countries. And next year, January, we'll have a Bali, Indonesia, for a huge symposium over there. That means we have all the professors go there, spend 3 days giving hands-on courses and lectures, so on and so forth. So it's a wonderful place, so you're welcome to come these meetings. What we did historically is 1992, I came to University of Pennsylvania as chair of department. I was already chair of Columbia University School of Dentistry for 10 years. And I came to Penn, we put microscope into teaching elements. First one in the world. Other people use the microscope, France, Germany, other place, but putting in using microscope in our clinical practice as a teaching is the first one in 1992. We also call microsurgery. So we already done 32 years. For us, it's just the normal, everyday stuff. For some of you, like, wow, what is this? Well, that's the way it is. Things go. We train so many people from Europe all around the world. And then we have 2017, things change. We have developed a different kind of conventional root canal therapy. It's no longer gutta-percha based. Gutta-percha is just a carrier. Sealer is the name of the game. And I have no time to discuss in length with this, but we'll talk about it a little bit. And then microsurgery has been changed. Why? Because of CBCT. Without that, we are before and now. So things changing. Things are changing all the time. I think if you're looking at the field of endodontics, it's not just the file going into the canal. That's no longer. We incorporate high technology more than any other field in dentistry. And you'll see, what we're doing is a completely different than one-hour student in many, many years ago. So endodontics is completely different. It is a very precision and a lot of high technologies, CBCT, microscope will give you totally different way of looking at this kind of discipline. And I think we're very, very proud to be part of it. We are proud to be teaching other people in this area. This is our philosophy. We call Pen Endo. Philosophy is very simple. Everything has to be under the microscope, period. Our eyes is no good. When you're doing a dentistry, especially endo, you're dealing with a very, very small stuff. Your eye is good for nothing. So we have to use microscope every single case. There's no exception. When he came to Penn, first day, they learned microscope, not the root canal. So it's a different emphasis. And second, a endodontic apical preparation, anything done in a file system is three-dimensional file system. We're no longer using a other kind of fancy. We use a three-dimensional file system. It's a completely different and cleaning it. What importance about our philosophy is non-surgical, surgical endodontic, which I'm going to talk about today, are the equal importance. Now, this is probably, I would say, only department in the world, not just the United States, we emphasizing this point. Because in order to save the teeth, you have to have a surgical component. Conventional root canal therapy, no matter how good you are, what you use, 10-15% fail. I'll give you a reason. What you fail, then what? Nowadays, all yank it out, put an implant. That's totally wrong, totally unethical. It happens, I don't know about your country, everywhere around the world. So anyway, this is what it is. In a microsurgery, you will have to use a piezo ultrasonic tips and a new material called bioceramic. We no longer use MTA. Bioceramic is the one which replaced MTA. They're the same family. We'll talk about a little bit more about detail. And then we do intentional replantation. We do vital pulp therapy. We do revascularization, all these things. Endodontic is not just doing a root canal therapy anymore. If anybody come to our department, clinic, you will see one is doing intentional replantation, one is doing a surgery, one is in a root canal therapy. All varieties going on to save the teeth. So anyway, we could do all those things because technology, material changed drastically. We're using stem cell. When root canal started, that was not even. They have a stainless file and a Hestrom file, and that was it. Now it's a completely different ballgame. So we have to look at the endodontic in a completely different perspective. Of course, these are not just because we're just saying it. It's all justified literature. If looking at root canal therapy as a whole, 1940, before Second World War, 1/2 of population in America, when they reach 60, has a denture over denture, complete denture over denture. Wife and husband go to bed, took out in a water pot. In the morning, you took it back. That was perfectly acceptable. Well, 2020, less than 0.001% has a denture over denture. Oral cancer was a high, almost doesn't exist. I have to send an oral surgery resident to Shanghai, China to get trained oral surgery, oral cancer. things changed drastically. Now, question is that how come that half the population need denture, they could save the teeth? Because of fluoride? Because of good oral hygiene? No, because root canal therapy was starting in 1940. Therefore, we were able to save the teeth root canal therapy. And if you can believe it, I just heard that your population of 1 million, American population 350 million, and we do 40 million root canals per year. 5,000 endodontic specialists are doing root canal therapy, 40 million. That's only in insurance data, could be more than that. So because of root canal therapy, we're able to change completely reduction of oral cancer, and then we have people are keeping their teeth. Now we're losing the teeth because of an implant, and that's another big problem we will face sooner or later. It's already facing it. We have a huge CBS article showing up that we are abusing an implant just about last month. So things are changing drastically. Ultimate objective of what endodontic therapy is very simple. First, you have to find all the canals. If a root canal has a 4 canal, only find the 3, what good is it? You're missing another one. That's what happened in the past. If I find, when I was a student, if I find a 4 canal and a molar, I can parade around the clinic. Oh, everybody, wow, Kim, you're very good. Nowadays, when students give you a clinical cases with a molar, they're only showing 3 canal, they ask, where is the 4th? Okay, what happened? Anatomy didn't change anything past that 50, 60 years. Technology changed it. Microscope identify more canal. CBCT give even more fun canal. Now we can find 4 or 5 canals, no problem. We have 6 canal molars coming every month in our clinic. They never heard of it in the past. So this is how technology is. Instrumentation is completely different. All 3-dimensional instrumentation. And your sterilization canal is all we're talking about biofilm. It's not like taking infection out. We're worrying about hitting the wall of a dentin, get rid of all the biofilm out so that we can make a canal as sterilized as we possibly can. And also, sealing is done. Bioceramic, which is, well, I'll explain to you a little bit later. We did a lot of research done, and the bioceramic is the material in the endodontic field. And of course, when this fails, microsurgery comes in. What? That's basically saving teeth in the mouth. That is our goal. Implant? Having your own natural teeth. We have to train that way. We all forgot about that because of money. Okay? Look at the Egyptian mummies. They have a teeth there. We have a 100-year-old patient coming into my office. They have a 15, 20 teeth that has been in that mouth for 92, 93 years. Eating, chewing, biting, grinding, whatever it may be. What lasts that long? We are the one who really making things much less. In old days, when denture, this is a tooth, yank it out. It was a perfectly normal process. Nowadays, no way. If a tooth is firm, no perio pocket, you can save 98% of the teeth by doing things what I'm describing to you. It's already proven, fact. So anyway, these are some of the things. So if you have a think about a little different, just open your brain and think about it. Okay? This is what it is. You're a dentist. You're going to make a living rest of your life taking care of a patient's mouth. And you must know these things as clearly as we possibly can. And I think that is something I'll be emphasizing as much as we can. What do you do with a case like that? You go office Monday, they showed up. Very simple, isn't it? Root canal. Well, what do you do case like that? Can you criticize root canal therapy? Very good. but periapical lesion persists. What do? You take a tooth out? You gotta be crazy. But this is where our problem. This is not just the one case out of a million. Happen every day, every office. You have to know how to manage these things. So keep the patient's mouth as long as we possibly can. And this is what basically whole purpose of this lecture coming, sharing with you our experience, our teaching, our knowledge, our research we done in our institution. This complexity of a root canal system. You only see the x-ray. Therefore, canal is a straight canal. We are all worried about, oh, curvature, wow. Oh. It's much more complicated than that. Because of this, success rate is not 100%. All the apical area ramifications, if this canal is contaminated, of course bacteria are everywhere. Can you clean all of them at the end? You can't. Only you clean the major canals. Then what happened, apical area? It depends. Outside of the tooth, your body always try to heal. So your battle going on apex all the time. Bacteria want to go out, your body want to heal. Body win sometimes. Bacteria win sometimes. That's the where periapical lesion changes. All the root canals are terrible, but apical area healing because your body is winning the game. On the other hand, root canals are perfect, but periapical lesion is expanding. That means bacteria may be very toxic bacteria eating outside. Your body cannot handle it. So these are battles going on all the time. So I think there's no any 100% solution. This is what you're doing on root canal therapy. So if you look at that, what happened to all this red area? They'll be full of bacteria. So that's the reason. That is the reason we need a surgery how to manage these things. This call, you say apicoectomy. We don't want to call it apicoectomy. It's done by oral surgeon totally wrong way. Because oral surgeon does not know what complex root canal anatomy. I'm not saying it, they are ignorant because they're not learned. They are never taught that way. Therefore, I think it is very, very important for a endodontist taking advantage of this. That's what this is the most important slide you have to remember in your head. Canal is not the straight line. Canal is not curved. Canal is the bifurcated. It will be all kind of apical ramification is there. That's the way bacteria are sitting there. And how we eliminate that, that's the key. Laser, we're not going to do that. Any suction, we're not going to do that. So you have to be different way of looking at things. In the past, we call apicoectomy. This is, you have no choice. We have to accept that. Oral surgeon go there, making big hole there, cut the root out, take granulation tissue out, heals. Of course, because you got rid of a granulation tissue out, initial reaction will be healed. 6 months, a year later, bing. So that's apicoectomy is our dental field think about a temporary measure, not a permanent fixture. And we have to make this permanent fixture. So all the method done by endodontists. Look at that. What they're doing is this, using amalgam, using straight handpiece, your naked eye, no microscope. That's what they did. Just emergency measure to make things stabilize. Success rate is 59%. We studied in our department, went to this is literature based. All the literature gone. That means the failures are 41%. You cannot institute anything has a 41% failure rate. But that's the way they did. That's the only way we had. Now, we had a survey in Philadelphia, not any other country, in the Philadelphia area. People are deadly afraid of a periapical lesion. Some dentists, little periapical lesion, oh, take a tooth out. We try to see what it is. So we get this too. and I'm going to share only one on the right side. Periapical lesion. Root canal was not done. On an anterior teeth, one canal. And we ask dentists, dental specialists, what are you going to do with this tooth? Are you going to take a tooth out, or you're going to do a root canal salvageable tooth? We sent a survey all around Philadelphia area about 10 years ago. The result coming out is totally stunning. I'll share with you. I hope you'll do the same thing here. We'll see what it is. Hypothetically, we made a 40-year-old male, broken tooth at 9, right at the gingival margin, in ideal condition, meaning no mobility, no pocket. We made periapical lesion. We used the Photoshop. We made periapical lesion 1 millimeter, but made a 15 millimeter length of the root standard, 3 millimeter, 5 millimeter, 7 millimeter, 10 millimeter, and then send out this to dentist. And what would you like to do? Would you like extract implant or salvageable tooth? The result coming out was totally stunning. Perfectly fine tooth, no mobility, no pocket, root canal not even done. Periapical lesion is 1 millimeter, but 14% dentists want to take this tooth out. I was totally shocked. If you go up to 7 millimeter, 30% dentists want to take this tooth out. So we go to now many specialties. Fortunately, our endodontist was 100%, 100%, 100%, 100%. They want to save all 100% save. So evidently, education is correct. For endodontist, periapical lesion, this size doesn't matter. But look at that. Periodontist, even a 1 millimeter periapical lesion, close to 30% periodontists want to take a tooth out. They're specialists. They went to 4-year college, dental school, and 2-year specialty training. If a periopros in our school has a 2 specialty combined together, if you periapical lesion become a 7 millimeter, about half of the dentists want to take this tooth out. What is the difference between 1 millimeter periapical and 7 millimeter periapical lesion? Go to orthopedic surgeon. They cost 7,000 millimeter take a bone out. No problem. Why we have a problem? So these are totally stunning. General dentists, restorative dentists, give you 7 millimeter, 45.9% want to save the tooth, meaning more than 50% want to take a tooth out. That means size of periapical lesion become so important to making their diagnosis or recommendation. What are you going to do? This is non-issue because you're called doctor, not a plumber. But that's the way it is. I don't know about here. Supposed to be America, good dentists. Oh, American dentists are baloney. They're good for nothing. They're idiots. Okay? Very simple. I can call you idiots. Anybody says you're idiots. You go to dental school? Are you kidding? So, why are we so far apart? Endodontists don't care periapical lesion. Means the other specialties are going crazy with the size of a periapical lesion. Well, is a periapical size matter? That is a gross ignorance on human tissue biology. They completely forgot what they learned in a dental school. Okay? So anyway, go there. Let me give you an example. I was a resident. This patient came. I was a Columbia University graduate in New York City, upstate New York. She has a perfect oral hygiene. All teeth are vital. Only she has a little bit of bump on the front area. X-ray shows this. Big, large lesion. This is not a 10 millimeter periapical lesion. There's probably 1,000 millimeter periapical lesion. Look at this. But teeth are all vital. That means a cyst. What are you going to do? She already have some clinical problem. We have to surgically going in. So, first of all, you have to do root canal therapy first because you got to go in there. Quickly, we did. Look at this. These are, once you scooped out all the tissues, that is not a 10 millimeter. That's probably about 1,000 millimeter. I can put my fist into it. So, if I show this thing, probably 100% of the peri department will yank it out, right? So you have a small pathology with the tooth spot there, took it out, soft tissue healed quite nicely. At that time, there's no bone grafting. It's late 70s. At that time, there's no membrane. That's before that period. We did cleaning up completely, irrigate completely, close it. Look at that. 12 months later, perfectly bone healed. Okay? This cystic lesion. Now, cystic lesion is a little different than granuloma. I'll explain to you a little bit later. This is what our body does. So 3 millimeter, it doesn't mean anything. I show you. Then you may say, oh, this is a cyst. How about granuloma infection? Good. Here comes. Root canal was done. Still periapical lesion persists. Look at how big the size is. So we did surgically going in to clean it out. It's just about fenestrating. It's not complete. After everything is come, look at this size. Less than, but quite a big size. Still, you can put the couple of fingers into it. It's not a 10 millimeter. It's a huge number. Okay? We did that. At the time, we had a membrane. So we put the membrane on it, suturing it. This is what it was. We do the CAT scan. This is 2-year recall. And if you examine this, just look at that. This was before the operation. You can see small buccal plate. Palatal is a little bit funny. Look at it over there. 2 years later. Complete fill with the bones. This is the way our body works. Very simple. But why you take it out? This patient kept his teeth, no problem. I saw 15 years ago. No problem. Okay? They want to take a tooth out, implant. This is absolutely crazy idea. Implant is wonderful when indicated. I learned implant. I know. I did implant. Okay? So I know exactly what is involved. But we try to save our natural dentition first. That's our goal. But anyway, this is what I'll give you an example. So it doesn't matter. But if you're looking at the periapical infection, it's like this. Granulation tissue, bone, remodeling bone is just outside. Once this granulation tissue was removed somehow, then bone regenerate, try to heal. That's what apical area heal. Periapical abscess is a pus. It's a little bit more difficult to heal, whereas radicular cyst is a cyst membrane there. Sometimes root canal therapy, no matter what you do, you're not going to heal. That requires surgical approach. That constitutes anywhere from 10 to 15%. That means you cannot tell what it is by looking at the X-ray or CBCT. You got to histologically examine to see what a cyst or what. But we could guess it. By having this kind of a lining here, will give you a possibly cystic lesion. Sometimes you do root canal therapy nice, twice root canal therapy still persists. That may be cystic lesion, and usually radicular cyst. That requires surgical approach. It's already 10%. Any case periapical lesion, 10% requires surgical approach to cure the problems. So no matter how good the root canal therapy is. So we have to understand all this data and information, then you can do the good things, right things to the patients. Patient, listen to you. Our population, I'm sure Koi same thing, are brainwashed. This is so, take it out to the garbage can. No, this is too can be fixed. Okay? That is a very, very difficult concept for the patient, for the dentist. You have to train the patients. You can keep the teeth. I'm not talking about fractured tooth or mobility 3. That's not. I'm talking about no mobile, perfect tooth, no pockets. So this is what a recap, and I'm not going to align this. So you go back to this. Then what? Of course, on the left side, you have to do root canal therapy first. But you have to warn the patient. You may need a surgery 6 months later. Why? If this cystic lesion, periapical lesion, we're not going to heal. Then what? Surgically clean it up. These two are no choice. In America, those endodontists who doesn't want to know how to surgical, but they want to retreat. They're going to retreat. They're going to retreat. They say, oh, there's a bubble there. Oh, there's stupid idiots. See? Bite the bullet. If you know how to surgery, yes, we make a mistake. But this kind of thing is without even thinking has to go surgical procedure. Of course, this has to go to CAT scan. Without a one canal was missing. Okay, that's where CBCT become very, very important. Okay, so without any additional canals, and these has to be surgically, and these are successful case over 90%. This is what I give you a diagram of all this advancement made. Microscope came 32 years ago, ultrasonic tip came, MTA came, CAT scan came, and we have a bioceramic things came. It's all here. Why is this showing up? Okay. Next step, I would like to see instrument, material, and approach. Because the reason I put things, I would like to have now what. So far, I discussed why, and now what. It is important to discuss this first before we do anything, because otherwise it'll be difficult to understand. CBCT, I'll give you more a second part, a part of the bone window technique. But this CBCT become a very, very, I call iPhone is my GPS. Without, I cannot drive anywhere. And CBCT is my GPS for surgery. They'll give you everything. Give you 3 views, and how much you go, what not. Very precision surgery we can do. Before, yes, I've done a lot. I know how to surgery, but I'm sure I made a mistake. Maybe I dig a little bit deeper into it, and so on and so forth. So this CBCT is the most important instrument. I'll tell you what, you're a rich country. I get very nervous when I go to lecture in poor country because they cannot have it. They cannot have a microscope. They cannot have a CBCT. Nothing. Meantime, I'm telling you all the things. Feel like, you know, poor people cannot have a food. I'm telling you, you know, beef steak is very delicious. Lobster is very, I get very nervous. But for you, it's not an issue, isn't it? I look at your capita income of your country is almost top in the world. For you, you can buy best, everything best. No problem, as far as I can see. You as dentists, don't buy cheap stuff. Buy the best. Because any instrument you use, you're going to use them many, many years. 10 years, 20 years. Okay? So I think this is very, very important. So I'll tell you what you have to buy. This Morita company, sagittal view is same as our X-ray. Axial view is very important. They give you what thickness of buccal plate. And a coronal view is exactly what it looks like from the side. Having these 3 views will give you a total idea about what exactly lesion is like. And I think that's very important. We just finished the external resorption. Something external resorption is a lingual area. Looking at X-ray, it's like there. No, it's buccal you can approach. Lingual, what are you going to do? You see? So this CBCT become very important. Look at that. This, you don't know what it is. Well, vertical fracture. No treatment. Got to take it out. Patient is complaining. Here, what is that? You cannot see anything. But patient complaint, look at that, is a horizontal fracture. See? Without those things. Can you see anything with this by looking at the X-ray? Totally asymptomatic. Anything is wrong with this? You may think, oh, maybe parietal ligament, maybe a little thickening. Boom. That's what he got. Huge lesion apically. Not only that, you have a caries and resorption on the bicuspid. See? We detect more than 38% more of the pathology with a CBCT than regular X-ray. My prediction is that X-ray will be gone in the future. You people all young, when you are reach some age, it'll be all CBCT. X-ray will be gone. We don't use X-ray anymore in my office. It's useless. I don't know what it is. Okay, we'll talk about radiation a little bit later, okay? You don't have to worry about it. I flew from New York to here. I flew 10 hours to Istanbul, 4 hours here, 14 hours I flew yesterday. That means I get 1, 2, 3 CBCT. I'm going back another 15 hours. 1, 2, 3. I get a 6 CBCT just coming to you give a lectures. That's what it is. Radiation, we breathe the radiation all the time. Beautiful beach, you go there, you get a radiation all the time. What kind of radiation we are getting is a very, very small. The benefit is much greater. So I'm not saying that you don't have to worry about radiation. Yes, you don't abuse it, but you can use it very, very nicely. So this is what it's all about. That's the way we know exactly height, how deep you have to go, apical area. For instance, here, many times we go there and drill it go here without knowing it. Now we know exactly 6.95 millimeter. You can get a piezo tone, go 6.9 millimeter. Then you don't have to know damage of any other area. CBCT is a must instrument for endodontic microsurgery. It's a must instrument for diagnosis. It's important for surgery, but it's more important for diagnosis. What exactly pathology is. And without X-ray, forget it. X-ray is not important anymore. That's the reason we're all gonna have a CBCT sooner or later. Sooner the better, okay? Because you'll see, once you have a CBCT, you're never gonna go back, okay? Mark my word. Yeah. So I'm gonna talk about CBCT more, a second part, so I'll go there. Next come microscope. Microscope is really doing two things. Magnification and illumination, period. Nothing else. You have to know how to use it for your benefit. That is one of the key. That's why you need a training. When you first get a microscope, it's like learning how to riding a bicycle. You fall, you go everywhere, you cannot do it. That's what exactly, I make an analogy with learning how to ride a bicycle using a microscope. Then, after a while, you can ride a bicycle without touching a handle. That's what microscope comes in. You keep on using it all the time. Sooner or later, no problem. And they become a habit, and you can see a lot more than whatever you dreamed of. It's not just once or twice, no. So I think it's very, very important. Medicine changed to macro to micro. 1950 ENT, 1960 neurosurgery, 1960 vascular surgery, 1970 ophthalmology. Now, they don't do surgery without microscope. Then why us? Why we don't use a microscope? Answer me. Are the medicine guys stupid? Are the medicine guy a extravagant show off? They cannot do anything without microscope when you do a surgical procedure. That give you precision, illumination, magnification. So, we did it 1992, 20 years later. Do you know what I heard when we instituted microscope teaching in our institution? They all say, oh, Kim, you get a lot of money from Zeiss. What is the fancy stuff? What do you need a microscope for? Well, that's history. Then, 1998, it became institutionalized. American Dental Association, of course, we had a lot of work saying that, okay, as an endodontic graduate education, you got to have learning a microscope. Simple. That's it. landscape changed completely. Now, in America, if you don't have a microscope, you're not an endodontist, which I'm very, very happy, okay? So this is what new standard advanced specialty endodontic program in the United States. And I think this is not only in America, we see all around the world that have a microscope is essential thing. Difference between loops is 4 times magnified. This is 24 times magnified. You can find another canals, no problem. Here, what you see is that, okay, 3 canals, perfect. What you see is the difference between color of this and this will determine whether you didn't clean up completely. You'll see the structure, color, and this will give you, if you see the things over again, 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 again. So, since we're using microscope all the time, to give you what it is, we had a clinical analysis. We look at 1,530 maxillary first molar done our graduate students. Found out that 41.2% have full canals. That means if you go there doing a work, if you 10 molar root canal therapy, upper maxillary first molar, and you don't have any full canal, you have a problem. These patient pools are coming all around the world. In Philadelphia, we have a Muslim, Chinese, a black, white, everywhere. See? So it's not like a one particular ethnic groups. So you have a 41%, 2%. Second molar has a 28%. Mandibular first molar, 1,832, 46% had full canal, and second molar is a 24% had full canal. Now you put the CBCT together, that number even higher up. So if you have only 3 canal molar, you have a problem. Okay? So summarize, maxillary first molar is a 41%, second molar is a 28%, mandibular first molar, mesial especially is a 46%, 9, and 20%. Now, as I said, more coming in with the CBCT combined. So what we do is that in my clinic, I microscope, I do the work, I full canal, then we have the CBCT routinely, and then see whether or not. If you have only one mesial buccal, we have to get a CBCT. Then you see long mesial buccal way out there. So I think this is what this is what it's not my work, it's all our graduate student work. Beautiful work, absolutely stunning. You have a 6 canal. This one has 1, 2, 3, 4, 5, 6 canals. See? So it's not the number is not 3 canal molars anymore. It's a different kind of system we have. In surgery, you use a small micro mirror. What are you going to have a micro mirror for? Huh? I'll tell you. We have to see resected root surface. That's the where essence of microsurgery coming in. That's the where I tell oral surgeon, don't do apical surgery. You don't know anything about complexity root canal anatomy. You cut the root and looking at it, you see all different kind of shape. It's not like a one dot in the middle. No, not at all. We have a small is smooth, large is smooth, you name it, everywhere. So we have to make sure that these are all taken care of. Another one, look at this. There's one missing, longer is smooth. This is a fracture, gotta take it out. Long is smooth, a little bit longer, missing completely. We see them all the time. That requires staining a micro mirror underneath it to reflecting it. So you know exactly what it is. If you hit the one area, one leaking, forget about it. It's gonna fail sooner or later. So what's the point then? That's the reason longevity of a microsurgery is because of you see the detail taking care of all the detail. I'm keep on doing it. This is a huge, a mesial buccal canal going in MB1 and MB2. So sometimes it's stunning. I mean, complexity of a root canal system is so complicated, and I think it's very important. Well, as far as the microscope is concerned, I would like to show you two things. We use a Zeiss microscope all the time. It's the best microscope, no question about it. is historically, technologically. But Chinese caught up. This Zoom X3200 Chinese, half a price, but it's better than Pro-Orgo. If I have money, I'll go there. Why? It gives you autofocus. That means if certain level, it automatically focus. Lens is the same. Now, unless Zeiss cut down the price, which they will not, because German company, Japanese company, they're gonna all go down the drain because they are so rigid. There ain't no flexibility. You see? That's it. I'm not saying that you have to buy, you have to kick the tire. I just introduced to you, if you want to buy a microscope, there's two kinds, either Pro-Orgo or Zoom X OM3200. Try it, and you choose whatever you want to. Don't buy any other things. Don't buy a cheap microscope, okay? Please. Charge a patient another $20 each patient. In 2 years, you'll pay off everything. These are magnetic clutch. You push button, everything moves, so that everything is very easy. Other one, cheap microscope, like, forget about it. What the hell are you talking about? You're tired of using it. It's just a few bucks, then you'll be able to take care of this thing very nicely. So I would like to see that. Microsurgical kits, I have to work with a German company to design all surgical microsurgical kits. So these are really fantastic German manufacturer, and I think you should get this kind of things to get them. Root and filling material. This I'm going to spend some time with it because we use MTA. Amalgam, forget about that. In 1995, already how many years ago? 30 years ago, we did a lot of research MTA. We found was very good. So everything was great. We use MTA all the time. Then there's some problem came. So we're looking at other kind of stuff, and that's the way I would like to share with you. See, 1995, 1998, all these are resident. Many of them are chairman of the department, dean of the dental school, and now, so because of all the clinical, our research, clinical application become root and filling, perforation repair, pulp capping, epic fusion. You all use MTA for this purpose. You're not going to use ZOE, you're not going to zinc phosphate, or you're not going to use resin. They use all MTA because of this research data, which show this is very, very good. Look at this. One of the key factor is hydrophilic in nature. Do you know what it means? It works in the presence of a moisture. None of the material in a dentistry is hydrophilic. They're all hydrophobic, meaning it doesn't work in a presence of moisture. That's why you gotta dry, and put them on there. Well, look at the dentin. What do? Fluid coming on dental tube all the time. It may be dry for a few seconds, but then you put it in there, fluid coming in. So you gotta have a material called hydrophilic in nature. So you get a tight seal. None has that, except MTA, except the bioceramic. That's the where I think of hydrophilic in nature become extremely important. Think about it. Is there any dry area in the mouth? No, you don't, inside. It's always moisturized, and you have to use that. This is a good example. In an animal experiment, we perforate a furker, and we put the amalgam on it. Look at that, all the infected area, abscess there. On the other hand, you put an MTA, overfill. Look at that, beautiful bone filling in right next to it, indicating that they are very, very good. And later we'll talk about it. And with the stem cell research, there's all different kind. I'll share with you all the things. This is a good example of MTA. This MTA studies. And you see that all the cementum is going underneath it, covering a whole area. This picture, like this. That means it's a biological seal completely underneath it, because these MTA bioceramics are so friendly with the pulp stem cell, periodontal stem cell, and bone stem cell. So any of the leakage coming apical, you don't have to worry about it. I mean, all the cells, I love it. Whereas a ZOE, forget about it. Cell dies. So I think these are some kind of basic science and research is very important for application. This we published 2006. Find out that if you put amalgam at root and filling material, we measure in distance. How much this is going to come back, heal completely. With amalgam, we get a 1.29 centimeter, and a millimeter. Super EVA, that I used a lot before MTA. well, half of the value, 0.756. If you MTA, that cut down to 0.397. What 0.397 means? A normal average paraligament is 0.386. That means it come back exactly where it was. You needed this kind of basic science data in order to justify using in our clinical situations. But problem of MTA came. It was okay, fine. It's too expensive. It's basically concrete cement. When you build this building, what do you do? Concrete. You put the concrete. The next day you spray water. Correct? That's exactly what it is. A bag of concrete costs $40. Meantime, little 100-gram costs $200. It doesn't make any sense. But that's the way dental industry, they're thieves. They charge you so much, not even funny. I mean, but everybody feel difficult to MTA because it's like a sand. It's not a cement. And second, it's too expensive, and the key factor is discoloration. If you put, apex is okay. If you put any of the neocoronal area, color changes. So we started looking, after almost a decade of using it, we started looking at, is there any better material? So that's the where bioceramic came. Bioceramic MTAs are coming from same family, silicate family. They're a little different here and there. So they're all great materials, and I'm not going to talk about detail. The key fact is that bioceramic has a microparticle and nanoparticle. Particles are small, nanoparticle make a sealer. Microparticle are making putty. So bioceramic sealer has a sealer and putty. MTA, you can. MTA particles are big. MTA cannot make a sealer. So if you buy any MTA sealer, fake, Korean company selling it, they have an MTA sealer, completely fake. They put MTA, maybe 5% remain, is all other garbage, put it in there. See? So you have to know this. They'll never buy MTA written sealer. Bioceramic sealer is the only sealer has a 2 micro and nanoparticles in such a way they can make a both kind. We call ERM is the bioceramic in America. I don't know what the hell they're coming from. So, this one. Pulp capping, pulpotomy, apex fixation, perforation repair, apical surgery, resorption. They are pre-mixed, easy to handle, no waste, and all the things. So right now, we change completely to bioceramic sealer, bioceramic. And as a result, we did this kind of study. Then we changed it. 10 years ago, Ian Chen was our student from Taiwan. He could speak Chinese. We called him Bulldog. He stayed voluntarily 1 more year to finish this research. Okay? He's practicing in Taiwan now. And Karapuche was assistant professor when I was chair. So I sent those two to China because we cannot do animal experiment anymore. America, you cannot do animal experiment. We have to, my Chinese colleague prepared 6 dogs, so we have sent them back and forth to China to get this research done. And I'll share with you. And of course, we don't, no support from other companies. Our department is the only department in the world. No country can come in. Many professors, people coming here give lectures, are all money coming company in a pocket. They talk about those things. I know who they are. I know how much they get paid. Okay? No, we don't. Our professors never. Okay, if you invite it, they'll pay you airfare and honorarium. That's it. They never have a condition so that a consultant or anything of that sort. Here, we have to pay $150,000 our own money, our department money, to provide that did. So first of all, animal experiment, you see all the things done. And you have an animal experiment, you have the pulp exposed, put all the material in it. 6 months later, periapical lesion form, call me, then we're gonna fly in there, and we did exactly same thing as what you're doing on a patient in animal 2. And put 2 things. 1, MTA, 1 is bioceramic, because MTA data we have. So we are comparing those things, and this is what it looked like. Right after surgery, 6 months later, you see C is a bioceramic, M is MTA. You can see all healing is exactly the same. Beautifully healed. So radiographic healing-wise, MTA or bioceramic is about the same. Doesn't make any difference. And if you histologically, you can see beautiful. This iRoot is a Chinese way of name for MTA, biceramic. And you can see bone formation, paraligament, you can see all the cementum is going around blocking the whole thing. Beautiful, perfect. So histologically, we're very, very happy as far as this is concerned. Of course, we didn't know this is going to be the results. And we are sort of stunned how good the results is. And we did a cell culture experiment, all the things. I'm not going to cover you. This is going to be a whole 3-hour lecture itself. And I'm just giving you a very highlight. We pick up the parallel ligament stem cell. We picked it up, human bone marrow mesenchymal stem cell, and we have a dental pulp stem cell. That's where all the material is in contact and incubated and to see how it works. And I found out that it has these are a stem cell glass without anything. And if you see MTA, bioceramic, it's doing very, very well by stretching it. If it's no good, you're around the ball, all dying and cells. So we are very happy to see, and these are parallel ligament stem cell, the dental pulp stem cell, glass is control, MTA, beautiful, a bioceramic, beautiful. So histologically, looking at this with a stem cell incubation give you a very good result. That give you histologically, radiographic healing well, this cell, and 2 requirements are all met. This is what it is, a sealer, regular sealer. This is a very expensive sealer, looks perfect, but if you look histological, they all shrinks. That gutta-percha is no good as a filling material. Sealer is the one. Gutta-percha carries a sealer into the canal to spread it. When I was a student, all gutta-percha. But we heated gutta-percha, packing it. After packing is done, cooling it, they all shrinks like this. That's what it is, okay? Looks good radiographically, yeah. But histologically, it was horrible, you know? But this is what it is. And bioceramic is all an adaptation and microscopic adaptations. And furthermore, this bioceramic expanding it as setting around 0.2 to 5%. Only material which can expanding after setting it. So you give a hydrophilic, it's okay with a little moisture, and at the setting, it's a perfect seal. That's the reason we're able to really support this thing. See, antibacterial effect, pH 12.5, sealability, adhesion, expansion, biocompatibility, moisture impervious. These are all very important qualities that the material has to have in order for us to use in many endodontic procedures. So with this, we are all sealer-based endodontic. And we started 10 years ago. Now I think a lot of people are taking advantage of this thing. Now we can use a root and filling material. These are surgery done at post-op. 8 months later, everything healed very, very nicely. And same thing applies too. 8 months later, all big isthmus, everything done. So we change completely bioceramic. We no longer, we can use MTA for root and filling because discoloration is not there. But we use all in bioceramic past 10 years. And root canal is done all sealer-based root canal therapy. So traditional surgical procedure, amalgam, looks okay, but that's what it looked like and nowadays completely covering that up. I'm not going to cover detailed comparison of old and new. Basically, all macroscopic, compare microscopic, everything is small, 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 and see the details in such a way that we're able to take care of all the things what to do with it. And this is because we have a tremendous improvement in terms of there are many, many detailed instruments and materials. So endodontic microsurgery, we did done success rates 93.5%. And traditional root and surgery, I told you, around 59%. Absolutely no comparison in terms of success rate is concerned. I'm going to give you at least a little video tape of what surgery looked like. Root canal was done like this, and then a year later, I had a problem. So patient came, and we did a surgical procedure. Number 19, lower left first molar. Oh, I'm sorry. Video clip showing how the surgery is done. flap design and posterior areas are pretty straightforward. You can flap, aesthetic is not important, so you can flap usually mesial of first bicuspid because you have to worry about ventral foramen somewhere around apex of a second bicuspid or mesial buccal of a first molar. So, but other than that, you can use a blade, cut completely, and flap elevated. You have to make sure the bone underneath is flat. That bone can be very, very tricky. So you have to be a little careful in terms of elevation is concerned. In this case, was not a big problem. Then you have to make sure, lower molar surgery case, always identify ventral foramen. It's not there, no problem. Once you found the ventral foramen, you have to have a groove placed above it, retract anchoring it so you never damage that area at all. In old days, I use a burr going over. Nowadays, you as a micro saw, put it in there. It's much more precise. And you can see buccal plate is completely intact. At this, we have to change it, retract it completely. You have to very narrow, serrate it, and I think this is very important. This is for elephant, not human being, but that's the way you use it all the time. See, you can do apical surgery with this kind of retractor. So you have a lot of very fine, thin like this, and serrated, and with a grooving above it, you can retract it. You don't have to worry about any of the ventral foramen damage. This is a new, this is what, saw, special piezotome, go over ventral foramen. This is not the same case, it's a new case. I just put it together. You can see retractor is anchoring it here. This is very important, called grooving technique. Anchoring it in such a way that you don't move. So there's no more damage of the nerve, as well as the tissue swelling is also minimized, and you can go up there and taking care of the pathology. See, this is what grooving technique is. That's it. Then game is over as far as the bottom is concerned. Other than that, your assistants keep on hitting it all the time, 1 hour, and you have a patient swelling and paresthesia. That's what basically what it is. A little grooving technique. It's very easy, and I think, and going back to old one, you can identify buccal plate is intact. You don't know how deep it is. See, it could be 7 millimeter deep or 3 millimeter deep. Now, axial view of a CBCT shows everything. That's the way bone window technique came about. Fortunately, it came out very quickly. Usually, go deep there, you can find it. Ultrasonic tip. You can now prepare it. Now put the cotton pallet into hemostasis. Hemostasis is very easy. You have to take advantage of human beings' blood clotting time. Everybody, if you cut it, leave it there, 10 minutes later it's all coagulated, okay? If you keep on rinsing it, you're gonna keep on bleeding it. That's what your dentists do. You go there and rinsing it, no time to coagulate. Put the cotton pallet and go have a cup of coffee or go make a phone call. Come back, it's all coagulate. Hemostasis. Make sure, that's very important, have a cotton pallet in it and pressuring it, you take it and then you all hemostasis. That's very, very easy way of doing a hemostasis. Anybody doing a surgery, I think that is a very important trick. Sometimes you use a ferric sulfate, hemostatic agent, to put it in there for about a minute there, then also that make everything bleeding stops. Perfect, no bleeding at all. You can see mesiobuccal, mesiolingual, ferrite ligament is stained, and it's not good enough. So we can staining it with a micro mirror and inspecting it. There's a very large magnification, around 16 times magnified field. And that's called root and inspection. That's a very important part of a surgical procedure, where methylene blue staining it, and then micro mirror underneath it. No bleeding. Beautiful. Mesiolingual, already transporting it. Isthmus going around there, mesiobuccal in the front. You see everything there. Now, with the proper ultrasonic tip, go there cleaning up completely and put the best material. That's basically what it is. And you don't know another canal, no fracture, nothing. And you can see everything very clearly so that you can plan things correctly. It's already transporting in an apical area. So root end preparation is, now you have to align this correctly. Sometimes roots are not straight, sometimes like this. Sometimes you have to go this way. Well, it depends on where. That requires a lot of good observation. That's no good. So you have to look at the high magnification, not always good. In this case, that's no good. You're going to go perforate to the side. No good. You have to aligning it correctly. That's good. You see? Now, large magnification and go down to low magnification and see the where the crown is. Let's say go. That's it. That's it. Then you can aligning with this in such a way that you're going straight line. A little bit details, but requires that kind of care. Now go in and out, and that's it. This is a root canal preparation is done from bottom up, 3 millimeters. Tip. Then go in and out, and then go through the isthmus, go to mesiolingual as well. This is essence of microsurgery. And unfortunately, many oral surgeons do not know that kind of thing exists. Their training is all macro, see? Here we go. That's mesiolingual and connecting those two. That's the reason you need a different kind of tips. Some are very thin, some are certain angle in order to take care of these things quite nicely. We already look at that beautifully, 3 millimeter deep inside, coronal area, looking at under the micro mirror. That's it. You fill this place with a bioceramic putty, and game is over. Okay? You put the cotton pellet on the back and expose the wear. Well, sometimes using wet ones to manipulate this cotton pellet nicely. You can just put it in. And these are MTA at the time. MTA, it's difficult to manipulate, so dump it in a carry-in and fill the space. Whereas now, bioceramic is when you can do exactly what you have to do. And you cannot end up fill that area nicely, and that's it. Then you can, and cleaning up as best you can. And that's it. Nice. It looks like a little bit of not a clean, but that's the way it is. That's where MTA is. This is a new one, and bioceramic putties. You can see it just like a putties. You can put it in there. Same procedure, and you can plug it in. Don't try to too hard. You just make sure everything is nicely done, but make sure the bottom, a grooving, so that it retracts is always protecting the ventral nerve, so you don't have to worry about it. And then after that, you can micro mirror inspecting it. See? You put one more. That's it. Now, you close it, and that's the whole procedure is. What is the indication for surgical procedure? First, root canal was done nicely. And of course, you got to do CBCT, but still periapical lesion persists. Could it be cystic lesion? Could it be complicated apical ramification? And that requires surgical approach to correct the problem. So doing a retreatment, this kind is a total waste of time. That's what many American endodontists who do not know how to surgery, they do retreat cases. I see so many cases, retreat 2 times, 3 times. Patients spending money, and the surgery 30 minutes, cut the apic area, solve the whole problem, see? So I think having this training is not difficult. So I just want you to know, I don't want to make this surgical procedure so difficult only I can do it. No, not at all. You all can do it. It's a jaw. It's such an easy area to heal. Lower jaw. What do you have? Mental foramen. That's you have to worry about it. Tooth and bone. You can drill anything you want to. See? So you protect that. Upper maxillary sinus. So big deal. Maxillary sinus heals very nicely. So doing a surgical procedure is not difficult at all. Because I train all our students all the time. So I know a student who doesn't know anything about surgical procedure. Once they cut the gum, bleeding, they faint like that. And then after a couple of cases, they're doing very, very well. And after 2 years, they do no problem at all. All our students graduated. And he's very good. He's trained well. You have other, you too, you're older. We have 3 students who train here. No problem. Surgery is not a big deal at all. No skip a heartbeat, okay? So I don't want to make things so difficult, only I can do it. No, not at all, okay? Next one, after retreatment. This is bad. So you have a retreat 6 months later, still periapical lesion persists, then it could be a cystic lesion. Then surgical procedures are needed. And this, of course, it was a radicular cyst. Next one, another retreatment. See, this kind of case is a transported. It looks like you forgot the hip hook. You cannot go to the hook, so you gotta go cut off apical area, and that's basically what it is. And this is a good example. That guy knows how to do it. Root canal is done well, but this is transported on the side, and that has to be taken care of. And that is an apical hook cannot be taken care of, and you cannot go back to take care of apical hook. So that has to be surgically managed. And separate instrument. Well, there is a instrument retrievable business. I call business. If you can take care of apical half tip without damaging coronal tooth structure, yes. No, they get rid of all the coronal structure to get straight line access. Why are you damaging all other things to get rid of the small tips? Coronal area, no problem. You can access to that. Apical half area, that's the way problem is. And I think if any company who are producing, it can retrieve apical half of curvature without damaging coronal area, that's very good. I didn't see it yet. They get rid of all the tooth structure of the coronal in order to get the tips out. So I think that surgical approach may be much easier. Long post, I don't understand prosthodontists. Why making posts so long? You know what I mean? So you don't have to do that long, but once you have that, then taking post out and doing a retreatment will be much more costly. Surgically going there, clean out is much easier way of doing it. This amalgam is not sealing, it's there. And if I go there ultrasonically, touch the amalgam pops out right away, indicating that these are not doing anything. So amalgam should not be used at all. Anything you have to do retreated cases. I did in 1992, 32 years later, not too bad. Still there, no problem, okay? I have many cases. In fact, I was in Germany. One of the German dentists, he organized big symposiums. I was there, Lake Garda, a very nice area. And I was there last year, and I was giving a course, and he came. And now he's an old guy, and so he told me, Dr. Kim, when you came here 40 years ago, first time, you did on my root canal and surgery. I said, do you still have it? Yes, I have it. And he gave me an x-ray. That was the best gift. 40 years recall of root canal on the guy. So which was, I think, is very nice. Now, let's go to steps. You have, surgical step is soft tissue management, osteotomy, bleeding control, bevel angle root resection, root surface inspection, isthmus management, retropreparation, retrofilling. It itself is a very long. It took many hours, but I didn't condense it. So that highlight I'll share with you. Soft tissue management is very simple, like this. Anterior aesthetic is important. What you have to worry about, blood stream like this, and you have to cut like this. This is a purely aesthetic. I'll show it to you. But on the left side is too kinky, so you go around, attach gingiva, cut it in half. And then you go round up, going straight, not going around wide area. When you go wide area, you're against the blood line, and you get a scar formation. Let me give you an example. You use a 15C, that's the main one, sometimes 12. I don't use a microblade. Some people talk about microblade all the time. Totally useless, okay? 15C, 12C, that's good enough. You can do that, no problem at all. This case, exactly what I told you, suture removal. 2 weeks later, looks good, looks good, looks good, looks good. Look at that, compared to front. Exactly same, no problem. You cannot even know when surgery was done. This is called aesthetic surgery, okay? So cutting attaching jaw in half, even thin is okay. Doesn't have to be a thick one. And then you go vertically, go straight up. I think once you do that, it shouldn't be no problem. As far as the back is concerned, you do flap. Aesthetic is not important, but you gotta cut that 90-degree angle and follow the where. If you follow the where the tissue retraction going on. 9 months later, you'll see nothing. So these are pretty much good way of doing it. Osteotomy, and right now, next session, we don't do osteotomy anymore because it depends on cases. If you have a thin, then you got to do osteotomy. Is it already fissurated? You do osteotomy. If your bone is thick, 2 millimeter on, then I cannot drill a hole. We can keep the bone, and that's what I'm going to talk about. And also, it's very important that a management of grooving. This is totally out of whack. It's old apicoectomy surgical procedure. We don't do that anymore like this, you know what I mean? And they use a 45-degree micro handpiece, and now you can do X-ray. We don't know what it is. CBC different. If you drill a hole, it's no good. You don't see anything. A little bit more, that's it. Then you're okay. This is all guessing. We don't know because you don't know how the depth is. And now CBCT shows up, so we don't do things like it anymore. And this is a good example of making a hole through it. And then blood clot and bone formation. Sometimes don't do bone formation either. So if your buccal plate is intact, we could take it out and put it back in. That's what bone window technique is. I'll talk about this afternoon. But it worked. And so body heals very nicely. Even big hole, blood clots make a bone formation. And I think it's good, but we try to do it. You don't do things like that. It's a mental foramen issue. And you do the groove, and then you can have a retractor anchoring it in such a way that you can protect that area very nice. Exactly, that's very, very important. Very simple process, but no damage. How many years I did? How many thousands of cases I did lower molar surgery? Not even a one paresthesia yet, okay? And I hope not. So I think that's not the really issue at all, really. People say, oh, you don't do lower molar surgery because of possible paresthesia. Are you kidding? You know what I mean? So that's not what it is. Bleeding control, I don't have to tell you. You do a lot of cotton pallet and pack it, let assistant press it, go have a cup of coffee and come back. Or make a phone call, come back. Meaning you need 1 minute, 2 minutes, 3 minutes time to press it. So you're taking advantage of your human blood clotting time. No problem, okay? And a couple of things you have to worry about it, because anesthesia, hemostasis together. I know you don't use a 50,000 epinephrine. We use in America. 80,000, 100,000, okay. That's not a problem. And surgically, sometimes you have to use ferric sulfate, a solution which can get hemostasis. And I think it's good. This is important. After giving anesthesia, you have to wait. People jump into surgery too quickly. Maxillary bone is thin and porous, so you can go a little bit early, like 15 minutes later. But lower, you gotta wait, because if you go anesthesia has to go through a buccal plate getting into medullary space. That takes time. So wait, 30 minutes to wait, 15 minutes, then you can do. But when you're going into big lesion granulation tissue is a very, very bloody tissue. So much blood, so you scoop out all the bleeding coming out. What you could see is that only anatomy you have to worry about is a mental foramen lower. You can scoop it out as aggressively you can get. Irrigate, scoop it out. See, beginners usually do like this, do like this. Bleeding occurs, do like this, do like this. No, you just close your eyes, clean it up as aggressively as you can. Because mental firmness are out there. Sinus may be a little different, okay? But these are get rid of this tissue as quickly as you can get. And sometimes you have a ferric sulfate solution as you need it. And these are cotton pellet technique. And this one. And this is what ferric sulfate is. Very yellowish, very toxic. You've got to clean up, irrigate very quickly. If you're bleeding coming like this, you can have a cotton pellet, tap it around, and like that. This is the far right. This is the where you have to close it, doing a work. Absolutely no bleeding at all, okay? Bleeding is not an issue at all. I already showed it to you. Bevel angle. Bevel angle was used in the past because you cannot use it. So you end up cutting the root 45-degree angle, 60-degree angle, basically hemisectioning it. And we don't do that. You only cut 3 millimeter straight, vertical to the long axis root. So you maintain all the structure. This is what they do, bevel. And I think this is totally waste. This is exactly 16 times magnified. This is 6 times. And you can see straight. So that roots are, let's say, 15 millimeter. 3 millimeter cut, 12 millimeters is the deal. So there's an anchorage and no changing in mobility. And I think that's a very good thing to do. But this is what they did. 45-degree, 60-degree bevel, and use small burr mark on it, and burr mark all these perforated on the lingual area and things like that. This totally doesn't exist anymore with us. Give an example. If you do 45-degree bevel, let's say yellow, you can see you're cutting it, but you leave a lot of canals there, a lot of canal ramification. But whereas you about 0, 10 degree, you cut it apical straight. So you have to do 0 degree more or maybe less than 10 degree cut in such a way that all apical 3 millimeter is completely removed, completely out. This is a good example. You did a bevel and you left it there, so you have a problem, contingent problem. Happens all the time. Yeah, all the time. So this is something you have to be very careful. This picture shows that on the left side is the bevel and amalgamar. This on the right side, exactly cutting it, and you have a very, very clean apical area without any problems. And so this is a root end. The question is how much you have to cut? 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter. What is the total length of the root? About 12 millimeter. So here, you have to know exactly. In old apical activity book, there's nothing around this area at all. We have to exactly know. So we did study done. If you cut apical 1 millimeter vertical to the long axis root, then you eliminating 52% apical ramification, 40% lateral canal. If you cut it 1 millimeter above, you can increase the value 78 to 86%. If you increase 1 more, 3 millimeter, then you're basically eliminating most of all the apical ramification, 98% and 93%. 4 millimeter, number doesn't change. So that's where 3 millimeter coming in. So you're cutting it, you don't have to measure it. You approximately, with the burr is about 1 millimeter, the ultrasonic tip is 1 millimeter, and you go approximately cutting it exactly vertical to long as well. Then you are eliminating, that's called, we made a 3 millimeter rule. Resect root surface, I show you high magnification with this, all different kind of things. And these are very important part. These are microscopic examination of a resected root surface to see the complexity of root canal anatomy. There you select the particular tips to cleaning up completely. And that's where the precision coming in. That's the way the beauty of a microsurgery comes in. Isthmus. Isthmus is connecting those two. One canal, the other one is missed. And connecting these tissues are isthmus. Everywhere. Anybody, any canal has 2 canals. Isthmus exists. When I came to Penn 32 years ago, I hired 9 translators, translate 9 apical surgery books in all different languages. There's not even one word, isthmus, in the book. Can you imagine? There is an isthmus everywhere, but not even a one word isthmus in a 9 textbook of all. German, Russian, Japanese, Chinese, you name it. That means, what the heck are they doing it? See? They're completely wrong. So here is isthmus become very important. So we try to find 1995 to select it. Mesial buccal of first molar. And examine it, we found 89% has isthmus. 89%. Because mesial buccal, mesial lingual, that's connecting it. First bicuspid, you're together, yes, there's isthmus there. Sometimes anterior, it's everywhere. So managing isthmus become a very, very important thing. So this is what it is. Instead of one around, you have another one connecting. This will be thicker isthmus, and this one, thinner isthmus. That's isthmus, longer. This shorter isthmus, everywhere. So you have to really taking advantage of this isthmus, long isthmus, and these are thicker one, obvious one, thinner ones, and you can see many places. The cause of surgical failure is exactly this. If you don't take care of this, and most of the oral surgeon apicoectomy was done, he just go there, zoom in the middle. That was it. You don't see any complexity of root canal. Sometimes S shapes. So you got to ultrasonically go follow that. With a burr, you cannot do it. So I think these are some of the very important parts. Look at this. Look at this. Well, this upper may be okay to do burr, but very few. And these are second molar root canal anatomy on that. So the complexity of the canal system, you have to appreciate it in order to do a good job. These are very beautiful historical study done at Ricucci in Italy, a good friend of mine and wonderful, wonderful histologist. And he saw that, and they published 2012. In the small magnification, these are main canal, these are small isthmus, 500 micron. The 100 micron, you can see the isthmus coming out. What's in the isthmus is this, pure garbage. Even if a very, very small isthmus, you can hardly see your naked eye. You see incredible amount of cells are there. So you got to clean up completely, the goal is, and seal it, and filling done completely. That's called management isthmus become very important. This is a case Helmut Volch is our endodontist graduate pen practicing in Munich, Germany. He got this case. Amalgam, root and filling done, no problem. Looked like root canal was tried. So instead of jumping the surgery, he thought that maybe 2 canals going down like this. So he tried a root canal therapy done, fine. 6 months later, 1 year later, didn't change anything. Periapical lesion still persists. So finally he did the surgery, open up, you can see the isthmus coming out there. He filled MTA, 2 years later, everything healed completely. So this is a very, very good lesson showing that importance of isthmus, how you manage these things are very important. Can management isthmus be important for success of endodontic therapy? Yeah, this case, nice case, in all definition is good, well done apicoectomy with amalgam, no spillage amalgam, anything of this sort. But for us, it's totally failure, okay? So only need is connecting those isthmus. Then you can, 1 year later, everything is healed completely. So I think we have to really understand this area very clearly for us having a very good result. And results are very good. I mean, it's incredible. The success rate is incredibly good in doing that. In root end preparation, these are tips. Tips are length of 3 millimeter. So actually 3 millimeter rule is you cut 3 millimeter, preps 3 millimeter. Why 3 millimeter? Well, we did animal studies. You put 1 millimeter and then lots of bacterial canal leaks. 2 millimeter, leaking is much smaller, but still leaks. 3 millimeter, nothing leaks. Therefore, it's 3 millimeter prep. That's the reason ultrasonic tip is a 3 millimeter height, okay? So osteotomy has a 4 millimeter. Why? Because we want to make sure 3 millimeter tips can travel to mesolingually, okay? On the other hand, roots are buccally tilted. You don't have to do that. Osteotomy can be 2 millimeter. You can see right away, you see? All depends on what is given. Once you do surgery, you can do a lot of things out of textbook to get the things. What you're giving is exactly what it has to be done in a normal condition. But as you do more and more surgery, you can be very creative. You can see more different kind of angle, because it's not only one here, on the side here, there. Some thin, some are thick, and all those things. But make sure that you are on aligning correctly, done correct thing. That's very important. I still make a mistake sometimes. You can go exactly the same way. Maybe off angle a little bit, but that's okay. But make much less mistake than beginners, like around there, you know. That's when you have to be very careful how to do things like that. And the root and filling is done. I don't have to tell you, this is a material, BC sealer. All the things I already talked about it. I don't think you don't need anything. And I'll show it to you. This is a putty put together. And this is a Guillaume who is practicing Paris. All hemostasis, nice, boom. That's very nice to get done. You can see everything is completely bleeding free. You cannot do the work when it's bleeding occurs. So this is, I think, can be done very nice. Trying to get conclusions, frequently asked questions. First, apical curettage without root canal and resection, will it work? I don't think so. You have to cut the apical 3 millimeter out. That's the where all cause a problem. And the curettage will be a lot easier in this case. Second question, apicectomy without retrograde filling, will it work? You hear sometimes, oh, you did root canal done and cut the apical area done. That's good. Well, not at all. Because, as I showed to you, canal is not just the one hole. If you one hole, it will be easy. Whereas all second hole is smooth. All leaks around there. So that's completely unacceptable. Once you cut the apical area, you have to do the root and filling. And that is become a must. Who should perform this procedure? Oral surgeon or endodontist? If your oral surgeon knows complexity of a root canal anatomy, fine. But they don't know. They don't train that way. So I think apicectomy is completely done by endodontists. Well, in our school, University of Pennsylvania, no oral surgeon can do apicectomy surgery. Only endodontists can do that. I'll tell you, you hear the story. Former dean was one of the famous, Ray Fonseca. He's one of the famous oral surgeons who was our dean. I came in as a new chair coming in. I'll tell dean, I'll do this, I'll do, okay, good. You. So we're doing it. And then after a few years later, his wife needed a number 19 apical surgical procedure. Good. So I told, oh, he's my friend too. Ray, you assist me, then I'll do the surgery. He said, no, my wife never want me to assist. Forget about it. No, I'll convince your wife. So I called my Melanie. Like, in this situation, he will assist me. No, I don't want him to assist. No, that's okay. So finally, I did surgery on number 19. He assists me. And of course, one of our graduate students are helping me, blah, blah, blah. Surgery is done. Fine. A week later, he invited me for dinner. Great. And he told me, he's an oral surgeon. He said, Kim, from now on, University of Pennsylvania, apicectomy is done only by endodontists, not oral surgeon. He called, they are butchers. That's his own word from his oral surgeon. He said, the way you do the way we do surgery is a completely different. It's a barbaric. We cannot do that. So that's the way at Penn. All this surgery is done microscopically, microsurgical procedure in endodontics. It's just a very interesting story, but that's basically what it is. This is the problem. They don't know this. They don't know this. Oral surgeon does not know this kind of stuff. If you do that, then surgery will not going to be successful at all. Okay? So that's what it is. Which case can be referred to confidence of well, tooth has a no mobility, no pocket. That's two most important criteria to the surgery save the teeth. Don't worry about size of a periapical lesion. No matter how big it is, I showed to you. It's all healed correctly if you done correctly. So no mobility, no pocket. That's the key. Okay? And then I think you'll be able to do very well. Yeah. Well, I've sent a patient for apicoectomy before. They rarely seems to work. Well, if you do oral surgeon, but if you look at that, look for the lobe of the short probing depth. That's what key factor is. Not everybody, I cannot say tooth is mobility 3 or perio pocket bone fracture. You gotta come out, that's nothing. So I think you have to be very careful. I'll finish with some clinical cases. I'm sure you are interested to seeing clinical cases. Big area, right? Root canal is done okay. Bone window technique to the BC putty, bone grafting, bone window placed on it, suture back. Right after surgical procedure, you can see bone window. 6 months later, not bad at all, good. 1 year later, much better. 3 years later, this Chinese guy, I never knew, he's not trained. I go China 3-4 times a year. So I went to China maybe 40 times past year. Each time I went to China, give a lecture, he followed me all the time. I didn't know that. One time I go there, he gave me a portfolio. Oh, Professor Kim, I would like to show you something. I have too many, okay. Next time, next time, next time, next time. Finally, in the corner, I have no choice. He showed me case. I said, whoa, did you do that? Yes, I did. Who taught you? You taught me. I didn't taught you. You know what he did? He listened my lecture 7 times. He memorized my book, and he does all the surgeries better than anybody. I'm giving you this to those of you who are hesitant, oh, that's very difficult, I couldn't learn it. No, get rid of it. Bite the bullet. First of all, patient never die. That's the one thing. If you drill a hole a little bit big, only you know. Don't touch mandible foramen, sinus, okay? Don't do wrong tooth. Other than that, I'll be okay. In the beginning, yes, heart beats. Do more, it's okay. After a while, you become confident. So I think you could, that's the reason I'm giving this picture, show it to you. I'm sure some of you never done it, probably first time you're listening it. It's not a difficult procedures. You can do done very well. These are sinus infringement. Look at the sinus, huge sinus. These are all things, a mucus formation because of these infections. Surgery done? Of course, sinus perforated. I can put the finger into it, to the sinus. But Schneider membrane forms very nicely. So you make sure during your surgery you don't put anything into the sinus. That's what you have to worry about. Look at this, 1 year recall, beautifully healed. One beauty is that sinus mucus disappear. I have to charge you more for ENT. You know what I mean? I usually joke around. I think, always I show this thing to the patients. My patient comes, recalls that 6 months all the time. And we'll tell them, okay, heal. Now I have to charge you more because now you don't have to go to ENT guy. I was joking around, you know what I mean? So this is what it is. Happens all the time. They say, oh, I cannot do surgery because of sinus. Come on, what are you talking about? I cannot do surgery lower molar because of the paresthesia. Come on, what are you talking about? Are you living a different planet? Well, are you a doctor or what? See, it's no big deal, really. This is a good case. This is done by Mohammed in Jeddah, Saudi Arabia. That's his case. Here, this case, X-ray wise, looks okay. But patients say, I have a feeling here, I have a feeling here. Okay, so he took a CBCT, found out that lesion in the distal and second molar had a problem. Okay, so CAT scan, you look at it. Here, surgery can be done through the buccally. There, if your surgery has to be done from here to here, it's a long distance. So, well, furthermore, it's a second molar. So he decided to, on the basis of CBCT, this is regular microsurgery. The other one was intentional implantation. Pull the tooth, take it out, put it back in. Okay? We do it all the time. So that's what he did. He did apicoectomy done on the tooth, fine. 12 months later, beautifully healed. And then second molar, and he intentional replantation. He took out, put it in, 4 months later, already healed very nicely. So I'm giving you an example of depends on what it shows. We could do many, many different ways of approach can solve the problem. This patient kept his teeth, no problem at all, okay? So I think this is really doing a service. This is one of the students from San Diego, showed me, he's already 25 years ago, wonderful student, that he had a problem. He was fighting with another guys who want to take out the implant. So he found out, finally he was able to convince the patient, get the surgery done. He found 3 canal mesial, 2 canal distal, 5 apical area, root and filling done, complete done. And this is right after surgical procedure. This is 2.5 years, and this is 3 years later. Tooth is perfectly fine, and kept him already, his patients kept him for many, many years to come. I'm a professor, but I have my office in New York City. I practice 2 days a week. A lot of surgery. In fact, my office, anybody who come to join Christmas, let me know. My office, 18th floor, overlooking, I see Christmas trees. So it's very beautiful here. I've been there for over 40 years. Here you go. Patient came, small fish track. So his dentist sent to periodontist. Periodontist not even touching it, looking at X-ray, oh, it's a fracture. Take all out, sinus lift implant. But patient's no pain. So patient went to another dentist. Same thing, different price. So finally, she was ready to go to get extracted implant done. And she was in country club where her friend having lunch together, but friend happened to be my patient. He said, oh, I gotta go, this implant has to be done, blah, blah, blah. And her friend said, no. You go to New York, Dr. Kim. He's the best in the world and all kind of stuff. So she showed up. I look in it. I try to probing, gutta percha, so I give a little anesthesia. I put a gutta percha. Gutta percha doesn't go in. Stay right in the middle. But you can't, gutta percha is like this. It doesn't go into two surface. If it's two surface, then you know it is possible fracture. But if you go like this, then it's not a fracture. So I said, it's not a fracture. But I told him, okay, but patient, that tooth has a periapical lesion. So I thought there was a periapical lesion leaking around there. Well, it's different. So, but anyway, I did surgery, found out it's a lateral canal, okay? So this is it. This is gutta percha goes in, this bone is the one cause that, and I filled the lateral canal completely, and then I went to apical area because it has this is what it looked like, a larger picture. Apex filled, lateral canal filled, and this is what it looked like. See? It's nothing to do with a fracture. No fracture. Patient has gone through all the teeth out, put a sinus lift, and all the things. It's just probably she had to go to hell. Here, perfectly fine, no problem at all. See? So this is a good picture of apex is taken care of, lateral canal full, with the foundation placed in resorbable collagen, and suture back. That's for the post-op. Lateral canal, fine. Okay, let's do it. She came back 8 months later. Of course, fistula disappeared. This was before, this was 8 months later. So this is what beauty of a microsurgery is. Okay? Fine thing, detail, right to the point, where source is eliminated with the least damage. And that's, I think, is a very beauty. Another interesting case. This lady is a billionaire daughter. She's from Kazakhstan, living in New Jersey. I don't know why living in New Jersey, I have no idea. This root canal was done in Kazakhstan. And of course, something is wrong on a bicuspid. The molar is okay, but periapical lesion and mental foramen is right underneath it. And same story. She went to 12 dentists around New York area, the most famous one. They all extraction implant because paresthesia, because mental foramen, mental nerve is very close by. It is close by, but you don't have to worry about it. If you microscope, it's like from here, it's like from here to Kuwait to New York distance, you know what I mean? I can do whatever I want to, you know. So let's look at that. Number 20, periapical lesion here. Okay, I told him, sure, no problem, we'll do surgery. She was shocked. How come you say so simply, whereas other dentists are talking about so complicated, you know? So, I don't know. Anyway, that's what it is. Yeah, of course. Apex is here, mental foramen is there. I understand that. So she went to 12 dentists, spending over $20,000 only for consultation. Can you imagine? Okay, her father's a billionaire, so she can afford it. But nonetheless, this is the what corruption of American dentistry is. They want to make money. Total corruption. Okay? You never become billionaire doing dentistry. You can. What are you competing with somebody? You can do the decent, good work. Still, you can make a wonderful living out of that. You know, I don't understand these people. You know what I mean? But anyway, make a long story short, that's that. And I went to first bicuspid. Okay, mental foramen is very close by. I made a groove, retract anchoring it, like this, and did all the work. No problem. Take 15 minutes, and then molar. I did a bone window technique, cut it out, boom, 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 no problem. This is what it looked like. Mental foramen is here, there. She came back next week. I said, are you numb? No, I'm fine. Of course. No problem, okay? So she's asking, why other dentists selling those things? I was kind of embarrassed. This is pre-op, that's a post-op, that's post-op. This is already, healing takes place. And then this is 3 years later. You don't even trace any surgeries done. That's what I mean. Flap design, if you done correctly, suturing, well, no problem, like this, you see it. And 3 year recall, no problem at all, okay? So this is the kind of case where microsurgery can do wonderful things in addition to routine things. These cases are kind of a crazy case. Look at this. Boom, 10-year recall. Boom, 10-year recall. Boom, 10-year recall. This one I'll show it to you tomorrow. Boom, 1-year recall. Boom, 15-year recall. Boom, 10-year recall. Okay? Tons of them. This is not any myth or magic. We have all the tools we have. You can buy all the tools you have, fortunately. You're not living in Guatemala or Nicaragua where people, it's a different world. You can learn it, you can do it. It's actually a professional pleasure. I cannot imagine me doing root canal 5 days a week. That's all I do the rest of my life. Having variety of the surgeries, saving, I think this is a wonderful, wonderful way of living professional life in addition to doing a service to the patient, keeping the tooth. So this basically will come down to everybody did all the surgical procedure, find out that success rate of microsurgery is about 90% done correctly. My former dean was oral surgeon, a periodontist, Scottish. I travel all the time. And he listened to my lecture many times. He told me, Kim, on the basis of what you're saying, let's say your conventional root canal therapy is 80% success rate. Good. So 20% failure. You say 15%. Let's make it 20%. Good, okay. Then those 20% going to surgery. Surgery, they say 9%. So 20 times 9 is 18. 18 plus 80 is a 98. So what you're telling me is that you can save the teeth 98% of time. If your tooth is rigid, no pockets. You said it. That's a number. Okay? So I think we're able to salvage many, many, many teeth because of using this kind of techniques. So location canal can be done. Biofilm is eliminated. Three-dimensional preparation can be done. Perfect canal, microsurgery, perfect endo is here. It's mission accomplished. And this is the what we are here for treating patients, saving teeth in a patient's mouth. So, future microsurgery after lunch. Wow. Right on the money. Good.
Thank you so much, Dr. Kim. And the next session will be 2:30 after lunch.
Yep.
And all the questions will be postponed after the second presentation.
Good.
I'm sorry? The second presentation? Luncheon in, okay. Luncheon Masila 2, okay. Anything else? Thank you.
Okay, we'll start because we have a tight schedule. We're going to finish just a little bit early so we can entertain a question and answer period. This session is designed for introduce CBCT a little bit more seriously, and then I'm going to describe some of the new techniques coming from as a result of the CBCT. And I think we have these: microscope, CBCT, biosensor material, microsurgical instrument, and piezo unit. And now, when you do the microsurgery, we don't use a burr anymore. We use a piezo unit. When I was involved in this surgery before, I thought it was piezo only for perio purpose, so we didn't pay attention at all. Whereas, once I started doing a bone window, I need a micro saw, and then looking at the piezo company, looking at a catalog, found out that they have everything what you need in microsurgery. So that's the reason we switched it. Now it's pretty much piezo-driven microsurgery, and I'll describe you a little bit later. CBCT, as I said, has changed our approach to surgery completely, because we know exactly three-dimensionally what is it like. As I said, jokingly, it's my GPS in surgery, whereas the other one is for the car. Well, CBCT came a long time ago, 1967, 1973, 1982, 1998, and finally 2001, finally FDA approved CBCT for a dental usage. That means it's already 23 years ago, CBCT. And of course, in the beginning, dentistry did not really accept it that easily. And it took about 15 years that we started using pretty aggressively. And as I said before, it will be all CBCT in the future, mark my words, okay? X-ray will be totally useless. Now, CBCT is very interesting in that before, we really do not know only one view of the X-ray, try to make something out of it. And I'll show you a lot of X-rays showing that sometimes wrong, sometimes totally cannot make something any out of that. So a lot of guessing games. When you do the X-ray with the only sagittal view, regular X-ray, you're guessing a lot of things. Whereas with the CBCT, you can tell you exactly where it is. That makes things very nice. So guesswork is gone. And we can make a much more a correct diagnosis and then correct execution of any surgical procedure because of the CBCT. The field of view is different. For endodontics, we only need a 5 centimeter localized view. As a result, radiation is smaller. Whereas implant or other kind of thing need a much bigger maxillofacial, whole jaw, things of that nature. They need that. But you cannot make an endodontic a usage out of a big interarch maxillary facial bigger view. When you buy a Carestream, things like that, you have a big one, and you have a small area, one small area, you look for this one. You don't have any definition, or nor you don't have any good thing. You have a more radiation, and you have a much better view. That's the reason I want you to have a CBCT strictly dedicate a endodontic purpose. Only need a little couple of teeth. That's all you need. And I'll show you which one is the best. As I said it before, this one, your vertical fracture, gotta take a tooth out. This is a horizontal fracture, whereas this is I already showed it to you, and you know exactly what the problem is, which we didn't know before. And if you're looking at this, what do you do? If you're looking at is anything is wrong with the X-ray, you cannot tell anything is wrong. Whereas you can see right away you have a lot of problem on the distal root of that first molar. And only you can see just faintly, a little bit, excuse me, radiolucent. This is interesting in that if you're number 15, you know it's a periapical lesion. But you didn't know whether it extended to a number 14. If you're looking at sagittal view, you can see right away. And you can see through the axial view, the extension of these lesions are very, very clear. So as I said before, 38% more of periapical lesion can be detected by using this kind of a procedure. These are some of the things. This came from San Diego. This tooth, well, young, beautiful lady, central incisor. This has to be, want to be extracted, put an implant on it. And finally, Garrett Guess, our graduate, convinced her. They find out that they have a lesions was not a buccal or lingual of the maxillary first central incisor, and he found 1, 2, 3, 4, 5 apices coming in. So see, with this kind of microsurgery, you can see how detailed you could do that. You know what I mean? You cannot imagine small tooth has a 5 apex area, and we can manage all those things. That's the beauty of things, right? And then you took care of it. 10 months later, everything is completely healed. So I think these are some of the beauty of using CBCT, finding what it is. Is again, this maxillary sinus area, and of course, this healed beautifully well, no problem. So sinus is not an issue at all, even if periapical lesions are extended in such a way that sinus infection is there. To make a diagnosis, if you see this one, looks okay, regular X-ray, but then you have a problem occurs after root canal is completed. You have a gut aperture going in there, that means infection is someplace. But you can, with this X-ray, you cannot find anything. On the other hand, if you see CBCT, you can see another canal running it right here. Only you could not get over there. So that kind of thing is a beauty of that. And whenever you see these things like, oh my gosh, I wish it was there many, many years ago. And now you have. So I think you or young generations should get a best instrument again and again, I'm telling you, so that you can enjoy what you're doing. This is another good case showing a tooth canal, fine, and you have another problem of that. Tooth canal, everything looks fine. With this kind of x-ray, you have never complained anything, but it has a clinical problem. So by CBT, you have another canal was missing on a bicuspid. And by the time when you're doing it, it become 3 canals like this. So without this kind of people, this probably would have failed. Eventually, tooth has to be, lost or whatever it may be. So you have a lot of beauty is coming. This is a huge area. A root canal has to be done, but you don't know the extent of a periapical lesion in this case. Little shade, yes, it's kind of, but you never. But if you're looking at CBC, look at that, how big it is. It's pure dark area, there's nothing underneath it. So as a result of this, this has to be, give you, after everything is completed, I think you have to open up. The lesions are quite large, and you take care of these things correctly, and then everything is find out there's a radicular cyst. So again and again, I'm repeating a lot of similar things that you can make a very, very correct diagnosis, and execution of the procedure can be very precise because you know exactly where to go, how to go, how deep to go. And without this kind of tools, you are guessing a lot of things. And I think that's the one important. Resorption. Well, we have a lot of resorptions. With the CBCT, we're finding internal, external resorptions a lot more than we ever did before. The people before me spoke about external. I watched a little bit at the end, but it is a big issue, and you can see right away. You don't know what it is, this x-ray, but on this view, you know exactly where it's from buccally going in, and this can be taken care of. And it's like this, and we have to take care of these things correctly, and you can see, put the jury store on it 12 months later, still good. It doesn't mean everything is okay. These resorption area become a much more advancing, so we gotta, you have to recall check every year to get a CAT scan done in such a way that see the progression of what it is. Sometimes you may go back again, clean up completely, do that again. This is what the resorption is. So it's not an easy thing. And sinus, again, I'm repeating a lot of things. The sinus effect like this in the CAT scan is almost impossible to take care of this. Not at all. You just take care of it. Then you can see on the right side, 18 months, everything is healed perfectly, including sinus and mucous membrane. So I don't want people say, oh, maxillary big sinus like this, then you cannot treat because of that. Let's take a tooth out. Not at all. Take care of etiology. You'll see that kind of result again and again and again. So anybody who had idea of, well, this kind of cases, you got to take a tooth out because of sinus effect, forget it. Change your mind. Look at this. Okay? So I think it's we're seeing it all the time. Taking tooth out, anything is totally, in our mind, out of it. You can take care of it because we see so many fantastic results than any failures. We take care of it. We do them all the time. Well, this is again with another one. Are you going to bone window technique? Going to do that? Yes, this is good. Why? Axial view have a bone has a nice buccal plate. Bone window is basically try to maintain buccal plate. Buccal plate is the hard bone, very difficult to heal. There is a little bit unhealing completely. So when you're taking X-ray, a CAT scan, you find out there's indentation with a little bit of radiolucency. It's not an infection at all. It's just a matter of buccal plate is not formed. That's the reason having this kind of a procedure is very good. And before I introduce in bone window, it all depends on thickness of axial view, bone. Here, you have a close to 2 millimeter thickness of axial bone, completely separate from medullary bone, then bone window is perfect. If your bone buccal plate is extended in such as too deep, 6, 7 millimeter, then bone window technique has to be very careful. Sometimes there's all this separation between buccal plate and medullary bone. So basically, you cut the bone and break that buccal plate out. And you took care of it, put the buccal plate back on. That's basically what the procedure is. And on the other hand, if you're looking at this, you have a very thin buccal plate and bone window technique cannot be done. It depends on, it shows axial view of the particular case. That will determine whether you need a bone window technique or a different kind of technique. So these are summary of important CBCT. You can tell exactly where is a mental foramen, how long, how deep you have to go. If you have to epigoectomy, you can go exactly 6.9 millimeter in. You don't use a burr. You use a micro saw. Micro saw has 6 millimeter, 8 millimeter, exactly that go there and cut this out. So you don't really unnecessary damage totally avoid it. And you can do very, very precision surgical procedure. So important CBCT is you don't need a professor showing that, oh, can I do this? Or can I? No, it shows everything. Extraction to fracture, non-surgical retreatment, surgical can be done by looking at examination of CBCT. And I think that's a very good tool. As I said before, you should have it. How about radiation? As I said before, I already told you I probably had 6 CBCT done before I got home by flying in an airplane for 15, 30 hours. But this basically is. This is called banana stories, and this is good thing you have to know. One banana, that is about 0.1 micro SV. People ask, if banana give you radiation? I said, of course, everything what you do. You have a glass of water, you have a radiation, maybe 0.01 micro SV. So if you were living in a radiation, and see what radiation is when you're taking a CBCT. If you go background dose of 10 micro SV, that means you are having close to 100 banana using radiation, same as you walk on a beach, okay? So, to making this story, banana story is wonderful, patient accepted. I have never seen any patient refusing to have a CBCT once I told the banana stories, okay? Before that, oh, no, I don't want to do that, okay? Of course, pregnant ladies, different story, okay, that's exceptional. But with this, you fly from New York to Los Angeles, 5-hour flight will give you 40 micro SV. I flew in from Istanbul to here is 3.5 hours, maybe less than that, okay? So you're talking about close to 5-hour flight, airplane flight. You get about 40 micro SV. You have 100 meters is a cancer risk, and this fatal dose of Chernobyl and Russian reactor explosion 30 years ago, they give you 50,000 milli SV, dead, period. So it's that dangerous. If you take a 1 periapical lesion x-ray, you have a 1 micro SV, same as eating 10 bananas, okay? So with this kind of thing, if you have a 1 Panorax give you 10 micro SV, and a small FOB CBCT, what we are taking for our endo will give you 50 micro SV, similar to flying from New York to Los Angeles. That's the reason I'm telling you. I get a 6 CBCT coming here, going back. So, I mean, what I'm trying to tell you is that you have to be careful about radiation, but making proper diagnosis of this, radiation become almost insignificant in this case. And as the time goes by, these companies will give you even less radiation exposed in CBCT. Much different. 25 years ago was a lot higher radiation. Now is a much more. That's the reason I want you to take small FOB, all 2, 3 teeth, 5 centimeter, rather than whole area. And having those things will give you a tremendous advantage. And these are all different kind of story. Which SB is the best on the market now? I'm telling all this thing not because I'm getting money. I get penny, nothing. Since I know more than you do, because I'm exposed to that, I'm trying to share with you in such a way that you get a best deal, best quality of a product. That's the reason I told you, for Chinese microscope, okay? I don't get any from them at all, okay? But it's for you, because as me as a professor and knowing this, I'd rather share with you what I know so that you can get a best deal. Okay, look at this. It's done in 2010. Which give you best picture? Number 2? No. Number 3? It's the same tooth, same exposure, different machine. Number 5, 6, 7, 9, 12, 4, 10, 8. Which give you best picture? Which one? 4. That's it. Morita Simone is the best today. I have in my office, my department has office, all our Penn alumni office, all our faculty has office, okay? Because that's the best. There's nothing you can compare. And, but it is much more expensive than other kind of, unfortunately. But as far as the quality of product is concerned, that is the one which at the moment. So CBCT is the must instrument for endodontic microsurgery. I told you over again and again and again. Combining microscope CBCT gives you such a powerful tool to go places that we never even dreamed of going there. So I think this is, a very good thing. So now surgery has changed. Before microscope, apical was done by oral surgeon, amalgam, burr, handpiece, things of that nature. Okay? With like this is what surgery was like at the burr, and this is the old and totally unacceptable today. This is okay for temporary measure because you never address any of the detailed anatomical entities. That you get rid of the granulation tissue, then body try to heal a little bit, and the reinfection takes place. That's when the failure occurs all the time. Success rate is over close to 50%, which is unacceptable. This is totally unacceptable today. Now, after microscope, we have endodontic microsurgery was born, which I described to you all in the morning. Microscope, ultrasonic, MTA, bioceramic, etc., things like that, which is very, very good and give you very, very good results. And if this kind of filling, good material, good instrument, good observation, things of that nature. Then, after CBCT, that's where things changing again. That's what happened close to 10 years ago. And you can use a piezo, we can use a bone window, and later talk about experimental, a trephinated burr, and things of that nature. Okay, that's what I would like to discuss. And with this kind of a traditional osteotomy with a microscope, but we still do not know a lot of guessing games. We are determined on the basis of one plane and sagittal view of pictures. So that give us, made a lot of mistake, and that's the way new approach with the bone being done. So I did a first try 2014, exactly already 10 years ago. I was giving a course in Athens, Greece, and where I did a live demo surgery, and the picture was like this, and I was doing a bone window technique. We didn't have any microsaw. We only had this kind of a big, actually I'm using it as a groove of a retractor, but I made this kind of bone window, and this solution is the organ transplant agent, while bone window is in the organ transplant, so the cell doesn't die, exactly alive, You do all the work and put it back on. And like this, get rid of all the things. And you put exactly procedures like what I described to you, ultrasonic inspection, and a membrane placed on a suture back, and it was fine. 10 months later, everything is healed quite nicely. At that time, I placed 2 holes, bone window. I want to make sure that the bleeding isn't going through so that you don't have any cessation of blood, so bone window become necrosis. And it was not necessary. But, well, it's a beginning, was trying best techniques. So this is okay, acceptable technique. And then came down this kind of micro saw. It changed to going from here, going from micro saw. Very, very thin a saw, which can work on a piezo. That's the reason everything changed to piezo machine. So here is, you put the marker on it, that's where you can reposition area. You can see this kind of a huge lesion, because I don't want to destroy this bone window drilling a hole. So I'm making a window, take it out, put it back in. You can see 16 months later, absolutely beautiful healing. Compared to this one and this one, that's basically, see the healing takes place. And the buccal plate is intact, everything is very, very nice. But bone window technique is not a new. Many disciplines of surgery use them all the time. So let's go to history in medicine and dentistry. Well, this bone window used in neurosurgery. You took the calvarium out. What do? You go around there, take it out, and put it back in. That's a bone window technique, okay? You don't make a hole through the brain to get done, see? So you have a, cut it out, store it, do the work, and put the bone window back. It's just a very short term. That's a really great bone window technique. Sometimes you're a neurosurgery used it, and ophthalmic surgery, I don't know where you used, but they used it, or whatever it may be. And bone grafting, this is a good example of infralveolar nerve. Oral surgeons use that quite a bit in difficult cases. And this is a third molar extraction. Difficult, your bone window, take 2,000, put a bone window back. So it is not an unusual thing for a surgical. But when they did this, they are basically guessing it. Instead of looking exactly how deep you have to go. That's why CBCT become very, very important. They give you exactly how deep you have to go and where you have to cut. But they did it with pretty blindly. And this is a good way of looking at sagittal view, coronal view, and axial view. Axial view bone thickness is very important. Here, 11.52 millimeter between distal medial root, and depth of the bone buccal plate can be determined. To getting in all the way there at the end, it will be 11.34 millimeters, and from that, where you're going to bone window going to make coronal up, or mental foramen is distances. We know exactly what it is. So we're just measuring it and going there and take care of it. Everything will be just fine. Here, if you do the bone window, this technique, you can see the depth of a 3 area, number 2 area, number 1 area, usually about 3 millimeter length has to be cut out. And you can see the distance length of the depth can be very clearly determined in such a way that you can do a very, very precise work. If you summary of that, first you have to know the bone thickness, coronal border, and you can see the apical thickness border. You see distance between the very important anatomical entities, and also you can see the depth, how deep you have to go. You can make a window outline is there, and you have to see where all the distance. Top coronal is a 2.2 millimeter, apical area 3.36 millimeter, in order to get the things correctly done. And then you can use this kind of micro saw. The micro saw has a cutting end at 10 millimeter. Another one is cutting at 8 millimeter. So everything is all done there. If this depth become like from here to here, cutting at 8.65 millimeter, I'll probably use 8 millimeter micro saw. Dig it in all the 8 millimeter. Just a little bit more, then apical areas can come out. So I think that's the way you're able to cut it very, very nicely. The key instrument for bone window technique is, of course, a microscope. And microsurgical kit, show it to you. And then CBCT of axial view. That is the key. That'll give you thickness of the bone. And that's, you can manage with a piezotome, with a microsaw, and they have a fine burr, and I think you making window can be done. And then what you need is that you break the bone. You don't have any bone just cutting it and take it out. It doesn't, because there's a difference between buccal plate and a medullary bone. You go in between. You don't go a microsaw all the way down there. You go there and then break the buccal plate. To break the buccal plate, you need a micro elevator. I have to specially design this one using Kohler companies, and I'll show it to you what it looked like. This is a microsaw, 6 millimeter cutting, 10 millimeter, and you can do things, a lot of things nicely. They're very thin, about 0.35 millimeter a thickness, and which is pretty good. And this is where this has to go in. This 6 millimeter cutting end, 10 millimeter up. There's a dots there. You know exactly how far you can go in there. And this is done. And basically, I'll show you. That's a 6 millimeter depth. Going like this. You just go nicely. Go. This he's going almost a 6 millimeter depth going in there. You can see all the blade is 6 millimeter. So and then you can just cut off. I give hands-on courses a lot. I just finished one. That's why bone is coming out. And then you can go in there. It's a medullary bone afterwards, so you can dig it out without too much problems. So this is what it looked like. This is a thicker groove placement. That's where retractor will be anchoring it. The other one is the bone window making, so this is what it looked like when I showed you. These are two key instrument and piezotome to do the bone window technique. And piezotome has also ultrasonic tips, but they are too thick, so I have to redesign it to much more longer and thinner ones for endodontic purpose. So having set up all together, that's good. That's the reason I'm working with this a company called Chinese company Woodpecker, because their machine is about $3,000, working fine. Whereas in Italy and Austria ones cost $7,000, $8,000, $9,000, $10,000. And of course, these people are so rigid, they don't want to work with. Whereas the Chinese companies, I ask them, make this one that way. They make one and ship to me in 2 weeks later. I tried it, no good, change it. They does very cooperatively. So it's such a, for us to going into new field, I need a lot of changes, instrument. And they're willing to help me these things. So I am working with them so that there's a call endo set is there with a, then you don't have to buy a lot of other stuff. That's it. If you have that, then you can do all these procedures quite nicely. And that's one of the things. One of the comparison with Lindemann burr and piezotome osteotomy is very, very significant in a sense that you have a lot of soft tissue damage is very minimum using a piezotome midbrain. Whereas a burr, you have a lot of damage can take place. Piezo, you can bone window, whereas a non-piezo is you cannot really do that much because you're cutting much more thicker area. And another important part is that by using a burr, you are eliminating all the anatomical entities. By piezotome, you can keep the entity on bone self itself. Whether or not this will have any significant clinical effect, I do not know. But at least you can see by using this instrument, cutting it, but everything is not damaged or any of the things can happen. This again, microsaw, all the anatomical entities intact. Whereas a burr, you can really make things not that nice. The key factor is that it causes a heating problems. If you use a liniment board, you can see all the burn lesion if you're making there. Whereas a macro saw also give you bit, whereas a micro piezotomy give you no burn lesion, indicating that this is a really very, very good thing because of the micro vibrations. And I think this is something is important. I don't know, but it's nicer. You have thing and no damage can take place. And another thing, side effect I learned from literature is that it's antibacterial effect. I can't explain to you how that happened. However, it's a piezotome, medium power, give you at least the bacteria around this area. And I can't answer that, what is the cause, but this is literature I read about this area giving that, so I assume that is good. So you have advantage and disadvantage. Piezotome usage and surgery will minimize soft tissue damage, which is we know, and it gives you much better hemostasis. Visualization is important. When I do hundreds of cases, I do surgery on the right side. It's very difficult because everything is focused on, I cannot have a view. Sometimes I gotta cut this way. It's a different position. Whereas a piezotome, you can see visualization is very, very good. So that's a big advantage. Less bone injury, preservation of viable cell, antibacterial, you have less pain, but it takes a little bit longer time. So in my office, I have 2 piezotomes. My assistant know what to do. So if I'm doing it, I'll tell them, set up, then they put another one. So I can keep on doing it very easily. Whereas if you have one, then you can turn around, changing around, that takes time. So it's totally up to you. That if you want efficiency, maybe do whatever you do. That's what I do. I have 2 units, and my surgical assistants are well trained. One surgeon has worked for me for 26 years. We're celebrating our 27th anniversary next year. She knows surgery better than anybody. So what I do is that, it's kind of funny story. She sits there, I do work, boom, 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 work. Sometimes she kicked me from the bottom. I said, what's the matter? I said, you left the cotton there. I said, okay, I cannot see that. So it's very important to have a very good surgical assistant who knows, rather than just anybody retracting it, you know. So she traveled with me all around the world. She went to Russia, China, everywhere. And I think without her, I cannot do too much. So if you want to be really into this area, train one person seriously. And that person is really trust you. You don't have to worry about anything. That is, I think, is very, very important to do a good surgical procedure. So with this, she ultimately more precise surgical approach, precision, that's the name of the game, and you can have much complete healing. Post-operative work was much less painful than a regular. Okay, after surgery, patient swelling. Why? Mine, very little swelling. Because I'm a good surgeon? No. It's different technique. The reason patient swelling is assistants are banging on soft tissue all hours. Slipping it, boom, boom, boom. Sometimes you pour mental foramen, paresthesia. Oh, I didn't see any mental foramen. It was right underneath it. She was hitting it all the time. So that's when you see the mental foramen, grooving it, anchoring it with a retractor to do all the work. Swelling is a very minimum and very less pain. They're shocked. They do all the surgery. And my patient impression is that, all the machinists are using it and boom, 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 running all over. But they're shocked at, so did you have a good swelling pain? No, I did one ibuprofen, that was it. See? So I think if you follow this kind of rules, then you'll have a pretty much the same kind of result than what I have received. So this is what it is. And we want to change microsurgery, penendo completely, all piezotome driven. And I think we are very successful. At least in my office, I don't use any burr anymore. All piezotome units are using it. So it worked out very, very nicely. So this is what it is. And it's a large lesion. You have cortical plate, buccal plate. It has to be more than 1 millimeter thickness. And proximity of a vital structure, mental foramen, can be identified very easily. and lesion become buccolingual apices can be determined very nicely. And I think that's the way you're able to do things. So with the CBCT, you can get all the detail get done, and then you're able to go. I would suggest in the beginning you write down every detail. And if you've done many times, you just scan it, we can do that. And I think it's a very good idea to have that done correctly. And you can see all the detail of thickness, each area, coronal area, apical area. I think these are very important information you have to obtain before you do any procedure as well. What I like to do is that I want you to bone window with a microsaw with the jawbone. Don't do human being right away. You have a different feel for it. So you have either rabbit or some animals, cut the bone round, lift it up, microsaw. You have the feeling. Then you can apply that kind of feeling into human jaw. That's when I think doing hands-on course become important. And I do many hands-ons, many countries. And I think this is the old tool. Lindenberg, we no longer use that anymore. They used to be using all the time, all these years. And we changed that, now it's different. Now we're using this, piezotome, cutting it, instead of using a bone. Once the bone window is taken out, that's why you need a micro elevator, I'll explain to you. Then you can store this one in Hank balance solution, HBSS. This is organ transplant solution. Any tissues are inside a solution, cell is alive. So that you can put the bone back on, then you can German cola company I have to work with, and they design for me this kind of 4 millimeter, very thin, hot a micro elevator, in such a way that regular elevator will bend, because you see how tough that is. And this has a thin, very thin, at the same time, very good steel, so that we're able to get, I think you can get any place else. This is the only company you can get it. And you need a small one, a medium one, that's all you need. And I think you'll do fine. Cut it like this, and sometimes you have to put a resorbable collagen in between so that this window can be stabilized. Once you start moving it, then it's not gonna happen. So sometimes small, a piece of resorbable collagen can be jammed in between, and to cover them up membrane. I think it will be very nice. That shouldn't be too much problem. This is what it is, microscope, either Zeiss or Zoomax, CBCT, Morita, Piezo, Woodpecker, microsaw Woodpecker, and micro elevator Kohler company. This is where I get most of our instrument from our department in my office as well. So you take advantage of my experience with them. I think that will be very good. If you order a Woodpecker Piezo, you make sure a pen endo kit. That's it. They're like 9 tips. They used it, and don't just ask just anything. That'll be good. This is the Kohler company's microsurgical kit. It's a very hard steel, and you can see different retractor. That's the way I set up everything. And you can see these are epinephrine pellet cotton, regular pellet cotton, all the instrument. So this is the where you have to set up. Everything has to be exactly same. I can almost close my eyes, I can get a thing on. That's the way you can surgery done, rather than look around here. And of course, assistant know exactly what to do. It's a teamwork. Then surgery can be done. Do you know how long it takes for me to do one molar surgery? 30 minutes, okay? I counted central incisor apical from beginning, 14 minutes, I'll be able to finish that, okay? It's not that I'm good at it. You keep on disciplining yourself, because you don't want to have a patient sitting any longer than what he needed. So when you people are coming first year, our training, it took 2 hours doing a one central incisor, doing the. So once you know what it is, then you got a speed. Speed is not a cutting corner speeding, precision and speeding it. That's the very. So you have to train yourself that way. Then surgery become no problem at all. Well, I do sometimes 6 molar surgeries a day. 6, okay? Some people do 2, that's enough. No. Do you know how many cases I do most? I was in Poland to about 400 people, and all day I'm doing live edematous surgery, special courses. And patient coming in, one after another. I was 2 stations. I did a 14 teeth surgery in 8 hours, all day. So the question is that I can do it, you can do it, no problem at all. It's just a matter of a discipline of doing things, okay? So I think that is very important. Okay, this is case. Beautiful work. You're going to redo root canal therapy on this case? You're going to be crazy. Yeah? Perfect case. So we do a bone window technique. This case has a furca, where is a perio problem. It's right in the furca area. So that's good. We can. Now, this is done. Joe Leck, who used to be graduate 2021, he's doing it, not me. He learned, he trained, and he made the other area a little bit curved so he can put it back on. This is straight, and this is the bone window is made. Micro elevator, lift it up. Okay, that piece is a store and hanky balance solution, and the granulation tissue removed from furca to under all completely. Okay? And then you'll see the apical area. He used a micro saw, cutting the apical area, apicoectomy done. He's practicing Scranton, Pennsylvania. He does so many surgeries. And some cases he sent me is fantastic. You can use a gauze. Look at the apical area, distal root, rounded. Mesial root, isthmus. Doing a root end preparation. It's a very big area, so doing things are very easy. It's not like you're using a small hole, you know. Put it in filling, make sure no bleeding occurs. All the gauze pads are back there, pressuring it. Distal root, perfect. Bone grafting material into it, and the bone window back on, completely positioned. Resorbable collagen going, jamming it in between in such a way that it doesn't move at all. Membrane covering it, that's it, microsuture. It's pretty easy technique. This is bone window is out. All root and filling is done. And bone windows are back on, that one. You can see the small line over there. And the x-ray was a little different. This is bone window is out, did all the preparation. The other one is bone window back on. And that looked like x-ray. All right, what did it look like? This is post-op, pre-op, post-op, you can see bone window line. And then 1 year later, before his graduation, boom. So he did when he was first year. And this is before his graduation. He took a final 1 year recall check. Work out beautifully. So this is done. It's by him, Joe Leck. It's 2021. You can see our surgical suite. He was doing this work. So this can be done. And I think that nowadays, it's very difficult for me drilling a hole when buccal plate is intact, see? So I think that'll be a wonderful way of another technique. You could, sinus lesion, and this another one, bone window technique. Cut it out, bone window, put it, membrane, put it on, and then this is bone healed very nicely without any problem. So we have a very good success rate with this cut. This technique, and we are using more and more and more this technique. Another number 30 cases, I'm giving you example of, this is a picture of the microsaw. This is a micro elevator. This one is a little bit thicker micro elevator. You need all this special tools that in order to get this done correctly. This case, we did a bone window. Here, go up. Red line is going up. You can see picture changing in an axial view, like that. Yeah. This, and you can see this area. Big, large lesion. You can see clearly. Buccal plate is okay. So we decided to do a bone window technique, and 1 year later, it healed quite well. Still healing, but without any problem at all. Clinically fine. This is what picture look like, and this is a bone window, and then 1 year later, the bone window is completely gone. You can see the bone window like this, and 1 year later, it's all fused very nicely. They give you a view of what it look like after playing 1 year later. This is what you're going to see most of all the cases that without any problems. This, I say, 1 year recall check, everything is good. You can see the bone window here, right there, and taking care of it. Just sometimes it's okay to doing bigger bone window than smaller bone window. Healing is the same, but bigger the bone window, we are much easier to access to work much more faster and clearly, rather than doing small and struggle through it. And advantage of, healing is the same. So you can take it out, you put it in a bone window, and you do take care of all the things, clearly see it, and put the bone window back on. And I think everything is just perfectly fine without too much problem. And I think it's good. So here is, I'll show to you again, this, I already showed you this one. This is bone window case that took care of these things. And after 3 years, has almost all healed, but clinically no problem at all. Just the bone deposition become not a complete. Now, this is first time I'm giving this part. This is, I'm redesigning special tool called a piezo-driven trephinate round burr. I did about 20 cases. Nobody did. And it worked out like this. Give an example. You have trephinate burr. You can have a trephinate burr with a low speed. No water coming in, it burns the tissue. And the blades are too thick. So piezo is doing this, not a drilling it. So I didn't know whether or not we were able to do things. We did experimentally, it worked. It's a bone is less than 3 millimeter, you can do that. So you have this trephinated burr, water coming in underneath it, and you had this, it's experimental. And so I think it'll be very good because you can go there, apical area, boom, take it out, put it back on, rather than making a bone window. So practically this gonna be very, very popular, good one. And you could do that. You see where the apex is, and you just bzzz, go there, take it out, put it over there, put it back on. That's what my wish. And so far, on our 20 cases, it was very good. Everything is healing very well. Like a case like this, you have a very nice bone here. This look, only thing that you can go there, right here, bzzz. So this is what thickness is, okay? Rather than making a big bone window, things like that. So I did, flap elevated, easy. This is what buccal plate, probably around here is where it is. Zzz, take it out, put it back on. Can I do that? Okay, I did, perfect. Okay, this is what piezo-driven trephinate burr going in, position it, making a hole through it. Okay, you have to, it doesn't first time, go digging around there, go around there a couple of times, then you can see looseness coming in. I put really marker here and here so that I can reposition the correct area. And come there, this can be taken out, up there, and you could do exactly the same thing what it's supposed to do. Epigaectomy, and done. Put the fillings on it nicely, and put it back on, a membrane and covering it. So this is something that I would like that eventually this can be part of our routine and surgical procedure with the CBCT axial view of the bone is there. So anyway, what is next? Digitization. I'm not so sure yet. I think we are too hurried toward digitization. And my feeling is, wait, it's too expensive. I can do better with the way I'm doing it. Having digitization would not make any advantage at the moment. Still, I'm open. It'll be better than what I'm doing it. I'm not so sure yet. So any digitization, I'll rather wait rather than supporting it. So I'm very, very critical. It has to be practical, economically salvageable, everything, things like that. So far, whatever coming out, I don't see anything yet. So I think that's about it. Again, everything is done, and I think great. Using these advanced techniques that we described to you past 3 hours, we can save millions of teeth. I think that's what our purpose of being a good dentist. And I think that we should practice a correct way. For that, thank you very much, and I'm finished. Okay? I'm sorry, it's 3 whole hours. Yeah. Oh, pictures. Okay. I thought you were asking questions. I thought you were asking questions. Yeah, okay, yeah, all right. Oh, yeah. Oh, what do you say? You repeat?
So all the cases you showed, very large lesions. Why don't we do root canal treatment, conventional? Let's give it a chance and then do surgery.
Of course, that's the way it should be. I have nothing which root canal was not done. It's all root canal done. That comes first. If a periapical lesion, do the root canal first. And that fails, then you can go to surgical procedure. Yeah. You never seen anything not root canal done.
He has so many cases that he did root canal treatment and they hit 90%.
Oh, sure. Of course it is. I mean, don't misunderstand, I'm doing it. We give a root canal work enough time. There's no changes occurs. Then we go into surgical procedure. Yeah, you have a 400 case, I have 1,000 cases. The root canal done, successfully done. So.
Let's take a look at the photographer.
Who's a photographer?
Thank you so much.
Okay, good. Thanks. Give it to me.
Yep.
Yeah, he's a lecturer. Okay.
Hello, doctors. My name is Dr. Razan Al-Hajri, and I'm pleased to present Dr. Mohammed Al-Yaqub, who is a consultant in endodontics at Al-Farwaniya Dental Specialty Center. 28 years of experience in both government and private sectors. Pulp biology lecturer, Kuwait grad endo program, former clinical endo instructor and lecturer, Kuwait Board of General Dentistry. Dr. Mohammed obtained his Doctor of Dental Surgery at Medical College of Virginia in 1996, Master in Oral Biology and Certificate in Endodontics in 2002 in USA, a certified trainer by Dentsply Sirona Endodontics in Switzerland in 2016.
Microphone. Can you hear me? Okay. Good. Thank you. Good afternoon. Let's see. Okay. Thank you for the kind introduction. And I would like to thank the KDA for this amazing organization and the organizing committee for allowing me to speak today. The title of this presentation, The Golden Era of Endodontics, Reciprocation Movement. And as you know from the title, I'm going to talk about specific movement. They use it in rotary instrumentations, mechanized instrumentation, called reciprocation. The reason why I'm speaking about it because I've tried it since its beginning, and I find it safer and more reliable than the rotary instrumentation. Okay? And let's see how this works. Okay, this is only a pointer. Okay. First of all, let me introduce where I come from, where I work at. I work at Farwaniya Dental Center, and you're aware of where that is, right? Okay, it's in the Farwaniya province of in Kuwait, and let's see. Anyways, I don't know ليش ما يشتغلون الفيديوز. Okay. Oh, this is working. This is working. هذا المركز الفروانية التخصصي. By the way, anybody who doesn't speak Arabic here, كل يتكلم عربي صح? Everybody speaks Arabic? Maybe, yes, all right. Anyways, so basically this center was opened in 2017, and it's been built on 8,000 square meters, over 165 operatories, and all the clinical departments there, in addition to the cleft lip and palate department. In addition to that, the first floor, the school oral health, and the Kuwaiti Board of Pediatric Dentistry and Kuwaiti Board of Orthodontics. So it's a huge center. And the Department of Endodontics is 16, we receive referrals from 16 primary care centers. And in addition to that, internal referrals from the other departments and private clinics through we receive referrals from private clinics through the primary care centers, okay? So we treat patients from this province, all nationalities, all genders, everybody is welcome to be treated there, okay? We have doctors who completed their postgraduate education from diverse different parts of the world. England, Western Europe, Sweden, Hong Kong, the US, India, Riyadh, Saudi Arabia, United Arab Emirates. So it's a huge diversity and an excellent area for learning and exchange of information, okay? Now, I just felt tempted to start with this slide. This is a CBS report that was released at the end of October. And this is their conclusion. It was released in October by CBS News, busting so many dentists in the US, extracting teeth that are repairable or restorable. So, as a result, somebody has to respond. Dr. William Gianobelli, I think he's the dean of Harvard University. He made that statement, Gianobelli, dean of the Harvard. I really hate to say it, but many of them are doing it because these procedures, from a monetary standpoint, they are much more beneficial to the practitioner. Our specialty has been abused by these extractions, and we are not making the final decisions of whether or not this tooth is restorable or not. So, as a result, the American Academy or Academy of Periodontics, they also released a statement confirming what he said. So, we know that endodontic treatment is successful and it can restore the dentition, but many people are extracting teeth for the sake of financial reasons. Now, this is probably the most cited endodontic literature, in the endodontic literature. In 1965, somebody established and confirmed the link between bacteria and endodontics, endodontic disease, pulpal and periapical disease. All right, so in 1965. Prior to 1965, they were doing endodontic treatments, but it was based on empirical information. I pulp the teeth, the symptoms go away, but nothing confirmed scientifically as a result. Okay? So basically, that was in 1965. Now, there are so many success and failure studies regarding the success and failure and the outcome of endodontic treatment. You're newly grads, a lot of you've reviewed all this literature, and you know that based on strict criteria, the success rate of endodontic treatment is no less than 80%. Okay, so if you want to observe and you monitor the periapical healing of these teeth after how many years? Maybe this study of the famous study by NG, 2011, she did 2 studies. One of them is strict criteria, one of them is survival, loose criteria. The strict criteria gave 80%, 83% based on strict criteria, okay? Now, she also determined all the prognostic factors in that study. I really like that study, where she identified more than 10 prognostic factors: the working link, the irrigation solutions, EDTA, chlorhexidine, and all the factors that contribute to the success or failure of endodontic treatment. So, so based on survival, 90% of them are surviving. And we realize that in all of these studies, the most common cause of failure is lack of coronal coverage, coronal restorations. Most of the endodontically treated teeth that get lost, they get lost because of coronal demise, breakdown, okay? And you know that. It's not only knowing that, I see it every day. This is one of the most biggest studies. They analyzed records, the retrospective study, not prospective study, 1.5 million teeth, and approximately 1,126,000 patients over an 8-year period. And they realized that 97% of these treated teeth were retained in the oral cavity after 8 years. 3%, they had these adverse events, non-surgical, retreatment or treatment or extraction. So 3%, all right? 85% of the treated teeth, they lacked coronal coverage. So we're dealing with 3%, right? So this is not new. I sit every day in the center and I look at the OPGs of all of these patients. Beautiful root canals. They get these root canals, whether they're beautiful or not beautiful, and they end up getting them extracted. By the way, we open from 8 a.m. to 6 p.m., 2 shifts. So I sit and I look at these. It's a vicious cycle. We're doing our best, but the patients are not restoring these teeth, and they're ending up with extractions. This is examples of many teeth. For example, this one. And this one is like a third molar. This one probably, this is as a result of this. But this is majority of the cases. Our endodontic treatment is very successful. Yet, there are so many teeth get extracted because they don't get restored. Now, I'd like you to recall the fact that most of the literature state that bacteria is the cause of failures, and this is one of the famous studies that was done in 1991. He took biopsies and he realized that 70% of the teeth that were biopsied, they found bacteria inside the canals. Okay? So you might think, why is he talking about this? What does this have to do with the Wave-1 Gold or any instrumentation system? And this was Peters. You are all aware of this. We know that our instruments don't touch the walls of the canals, all the walls. About 40% of these walls are not touched. That's why some of the cases was shown by Dr. Kim, very nice root canals, but there is a lesion. And then you have terrible obturations and there is no lesions for 10 years. I've seen them. It's because of the ability to use the irrigation solutions for the specified period of time. Now we're worried about how it looks like, but then failures will come up after years. Okay? So, the most important, this is quoted from Schilder. Unshaped canals cannot be cleaned. Unshaped canals cannot be filled. I say, this is my stay, completion of instrumentation is the beginning of the root canal treatment. There are so many things inside that cannot be removed with the file. So we need to get down there as soon as possible so that we allow our irrigation to stay there and activate it and use the right concentration of sodium hypochlorite. Okay? And also the biofilm has been troubling us because it stays there. It's probably the cause of failure in the long run for that 3% or 10%. That's probably the cause of failure. Okay, do we need to resort to really sophisticated technique to achieve the principles of cleaning and shaping in successful endodontics? Like instrumentations and the activations. What about this tooth? This tooth, this treatment has been done 32 years ago. And it was done hand instrumentation, of course, before the rotary instrumentation, but the dentist really struggled. And it took like 2 to 3 visits with calcium hydroxide, probably hand instrumentations that probably required at least 10 instruments. By the way, this is my tooth, and I never crowned it. And just I had a big amalgam restoration, and Dr. Yusuf did this composite resin. Thank you. And it's been there, so it's been there for 34 years. So endodontic treatment works. We don't have to extract them. There is no lesion. Maybe it's short. Maybe she used the doctor in Washington, D.C. Why do I remember? It was during Al-Ghazu. So I was there 2 to 3 visits. It was, endodontic treatment was very cumbersome, very tiring. Maybe in your generation, you don't remember that. Before, we had to use all of these instruments to create that continuously tapering funnel and fulfill the principles of Schilder. So basically, it was not very pleasant. It was tiring. Yani, back then, when you do endodontic treatment, hand files, 40 is the end of your career. You cannot practice more than above 40-year-old. Seriously, it's not easy. That's why in 1990, they introduced nickel titanium files. And let me just show you a timeline. It's interesting, okay? هذا Schilder, طبعا قبل هني, before it was Kakahashi, Stanley, and Fitzgerald, 1965, 24 Zurcher and Hess, and then Wally in 1988 found out that nickel titanium can be used as a rotary instruments, mechanized manner. Before they used hand files, and they could not use the stainless steel in a mechanized, machine-driven manner. So he then Dentsply created the profiles. I belong to this generation. I started working from here, all the way pro taper, and then they made the M-wire to reduce the chance of fracture of the instruments. And then lastly, they started with the first version of Wave 1, and then the last version of Wave 1 Gold, reciprocation. Why reciprocation? There is plenty of literature right now that proves that reciprocation is safer than rotation. A lot of you don't believe in this. You stay with whatever technique you want. But for me, I feel comfortable and try it. By the way, reciprocation, Wave 1 Gold, is attractive to general dentists, newcomers, not those who've been practicing Endo with rotary files for a long time. Okay, this is one of the techniques. There are many million file systems, but there is plenty of evidence proving that reciprocation is safer. Okay? So, in 2002, they introduced the nickel titanium, and we thought it was the golden era, right? Okay, tamam. We don't have to use those 20 files. And these are cases we've done. I've done these cases, GT, profile, and then profile mainly. But you think, how many instruments? 04, 06, 304, 306, still we use 6 instruments. Okay? It was not nearly as the golden era. And now, above all, boom. Nobody likes this. Every endodontist I don't think, when you instrument a canal, I don't think anybody is 100% positive that they're not going to break an instrument. It might break. There is a possibility that it breaks. So, it was not we spent hours and hours to remove it. And then we realized that after studying the alloy in details, we realized that this instrument breaks by means of 2 mechanisms. By torsional failure, when the tip of the instrument binds, is a monotorsional failure. Okay? When the tip binds, when you don't have a glide path. And the other, when you have a glide path and this instrument rotates in place, it goes through cyclic fatigue and breaks further away. So this is the problem of this rotational movement. In addition, there were problems with this alloy. When you flex it, it springs right back. Okay, it's super elasticity and shape memory. It turned out to be that the shape memory is not an advantage, it was a disadvantage, because it might cause situation like this. Okay? Now, further investigation of the alloy, they realized that it exists in two phases, austenite and martensite phase, cubic structure phase, cubic organizations. The first one, the austenite, returns to the original phase after deformation, whereas the martensite is less organized. It's more flexible. They realized that they can do something where they determined that each instrument has an elastic limit, and then after the elastic limit, it begins to deform. The instrument begins to deform. Under certain amount of torque and rotation, it begins to deform. Somebody who is very intelligent back then in University of Toronto was thinking, let me determine that elastic limit and create an instrument that functions without that limit. It does not exceed it. Okay? Now, the concept of reciprocation is not a new concept. It existed since the 50s, but they used an equidistant rotation with hand files, which does not apply to the new concept of reciprocation. See, back then, they didn't have the hand pieces and motors that can measure the torque of each instrument. And they modified it nowadays to, in 2011, it started in 2008, 2015, they released this instruments, Wave 1 Gold. Now, there are so many things that couldn't have been done back then because they didn't have the technology. Like the window technique Dr. Kim was talking about. It was there since 1974. Dr. Fuad Khouri in Germany, he is the one who invented it. And then now they have piezoelectric saws where they can do it conservatively. The same thing with this. They didn't have the technology to create hand pieces that can control the torque. Not only the discovery of the reciprocation movement that facilitated this transition and allowed us to use the minimal number of files, it's also the alteration of the alloy itself. They realized that if we heat the file, this is the M-wire. For those who don't know what's the difference, M-wire is a treatment, heating treatment before the milling of the file. After the milling of the file, يسمونه heat treatment, which is post-milling. This is what makes the file flex and it doesn't spring back. It gives it more martensitic properties than austenitic properties. But the key is, when you say this is proprietary to Dentsply, there are hundreds of companies that make heat-treated files now all over the world. I go to different exhibitions and I see hundreds, China, Korea, Turkey, all over. This heat treatment does not make it in the, it's not an austenitic file. It's a hybrid. It's not a martensitic file. It's a hybrid. It has austenitic properties and martensitic properties. Why? Because martensitic files don't have all the advantages. They're flexible, they're resistant to cyclic fatigue, they can follow curves, they can break less when they are in curves, but they lose their cutting efficiency. So Dentsply, proprietary to Dentsply, because they maintain some of the austenitic properties to allow it to cut more efficiently. So it's really possible to do the procedure without all the hassle that we used to go through. This photo was taken by the CG Optic. All the operatories we have in Farwania Dental Centers, except the examination room, has microscopes, Zeiss and CG Optics. Also, I forgot to say, we receive approximately 50 patients a day. We examine them and we perform various types of treatments, non-surgical endodontics, surgical endodontics, vital pulp therapy, microsurgical, of course, and what else? Sometimes when the prosthodontist are not in a good mood, we do the posting course for them. So basically, this heat treatment is supposed to be a secret, top secret. It's gold, not because there is gold. No, it's the oxide layer that forms that causes the the refraction, the wavelength refraction. So the thickness of this layer determines the color. So I told you I have until 4:15, right? 4:15, right? Until 4:15, صح? Huh? 4:20, 20, okay, good. So this is the one that was the mastermind of the reciprocation. He was like thinking, begin with the end in mind. Let's use the dense-ply files and handpiece to design a file that can get to the working length from the beginning, rather than going through 4 or 5 files. So dense-ply helped him a lot. And then a wave of research came out to investigate the reciprocation. Then dense-ply gathered the best team leaders, the endodontists in the world, to design a file that can fulfill this objective. Cutler, Florida, Pertot, France, he came to Kuwait. Cliff Ruddle came to Kuwait. Jim Weber from England, he didn't come to Kuwait, so most of them came to Kuwait. At that time, Ghassan Yared developed his own system called Reciproc Blue. All right? Now, so they released it in the IDS in 2015. After they collected data from everyone, they realized that we need to make a file that can work as a one-file system. And at that time, back before 2015, they wanted to make this concept, single file, single patient, because there were many diseases that were resistant to sterilization back then. So they developed this file and it came out. So there were concerns about certain things, like the fracture by torsional load, fracture by cyclic fatigue, canal shape and transportation, debris extrusion, microcracks, cleaning and disinfection. Am I gonna go sit here and show you all the studies? No, I'm gonna just tell you the first study that was released, it was 2016, dental students, they realized the conclusion that most of the dental students preferred reciprocation on rotation due to its safety. Now, just as a review, there were 4 generations or 5 generations of endodontic files, and we are here. Modern reciprocation started in 2011. This is the offset center of rotation, like ProTaper Next. Okay, so instead of going through all of them, these guys, Grande and Platino, Italians, they reviewed all the literatures and they came up with the following. Elimination of screwing effect is better. Torsional failure and cyclic fatigue, they are better than rotation. I doubt this to a certain extent. I think some of the austenitic file resists torsional failure better. But when you open the canal for the Wave 1 Gold, as the manufacturer recommends, they are equal, torsional failure. Canal shape, there was no difference. Debris extrusions, there is conflicting results. There is no consensus agreement that rotation doesn't cause extrusion or not. Micro cracks, that was the first criticism of the reciprocation. Someone published an article that it turned out to be a faulty methodology. He used 0.8 on lower incisors, and those cracks existed in these teeth even before the experiments. What about cleaning? I'm not gonna say it's better than rotation. They cause the same, they give the same results, okay? Now, what about the rotational movement? It's reciprocation, that's what's so different about it. 150 counterclockwise, 30 clockwise. Why within this range? This is the range when the elastic limit of the instrument is not exceeded so that it does not break. Doesn't mean they don't break. I would be lying if I tell you they don't break. They do break under one condition: when you sterilize it, or you don't make a glide path. This is the conditions. Or when you let it run in the same spot for extended period of time, more than 3 seconds, for example, or 5 seconds, you let it run for that time, it's gonna break. So if I tell you it doesn't break, I wouldn't be honest with you. Now, why did I give you this entire introduction, and what does this have? That system is fast. It gets you to the working length fast so that you can begin your root canal treatment. I said root canal treatment begins after the instrumentation. We know now, based on evidence, that so much of this biofilm and bacteria cannot be removed without some kind of adjunct techniques. Sonic, ultrasonic, heating the sodium hypochlorite, high-end, laser, photon, all kind of, we know that our irrigation with half concentration, if it works for 5 years, maybe after 5 years, things will come up. And that might explain why some well-treated teeth develop periapical lesions after a few years, because we don't pay attention to the areas that are inaccessible with the files, okay? So how can we take care of this? By activating the sodium hypochlorite, warming the sodium hypochlorite, and using the right concentration. Back then, a lot of good cases came out. These are not my cases. Before I show you my cases, and we were like impressed. They look pretty nice. And this is one case that I tried in the lab, forced the instrument, created a glide path, and it was possible to do curved canals, even though it's not indicated for that curvature. Now let's talk about the system. The simplicity of this system is what attracts many practitioners. The workhorse is this, the primary. We start with the primary in 85% of the cases. And 85% of the cases can be treated only with the primary. Endodontists are not gonna like that. I understand that, I respect this. The endodontists believe that there's no cookbook, there's no one size fits all, I understand. But it doesn't mean that you should not try it and find out. So 7% taper, 6 for the first 3 millimeters. It regresses is small, it's regressive taper. That's why it's minimally invasive. It does not affect this pericervical dentin, okay? So it's minimally invasive. Also, there is a Wave 1 Gold glider, which has a tip size of 15 as a glider for this system, and it should be replacing 15, the hand file 15. What is the requirement for this system? You start with this. Unless you're using, like you look at an anterior tooth, a big canal, you're not gonna start with this. You're gonna start with the largest. What is the determinant of what size you use? After you open into the canal, it's this file, the scouting with this file. If this goes to working length from the beginning, that means this is gonna go after you use this. If you have a hard time getting to the working length with this, you have to use 8 or 6, most likely you're gonna use the yellow, okay? So almost 80% of the time we can do it with the primary. Why am I showing this? For those who are been taught that in order for you to produce good results, you have to open the apex to 35. We know that. There is a school that says if you want to improve the success, you have to open to 35. You can do this, and this area is even less than a millimeter, so you're not really destroying the dentin up there. You can open it apically to the point where you allow the irrigation solution to get down there. Now, there are other features. If you sterilize it, this is gonna expand and you're not gonna be able to put it in the handpiece. Some people do. You cut it and do it. But I've been using it for like 8 years. It broke with me approximately 3 or 4 times, something like this. 2 times because I removed this and I put it back in the handpiece. Okay? So it has a parallelogram. The cross section it's a parallelogram. What does that mean? Again, the parallelogram is when, let me just show you this rotating, when 150 counterclockwise. You know, this is the opposite direction. This is 150 clockwise. Okay, but it's 150 counterclockwise, 30 clockwise. Okay, the cross-sectional design is unique in terms of every 1 millimeter you have either 2 points of contacts or 1 point of contact. This to center the file in the canal, and this to allow the debris to auger coronally to exit. That's why it cuts efficiently. The debris has the opportunity to go up. So what about the tip? The tip is semi-active, it's modified. Now, let's just look at this and complete the presentation. Okay, gentle stroke and motions. This is like a curved canal. Number 10. Scouting with number 10. And then 15, 7, 8 minutes. All right. Take a working length, wave 1 gold glider, tip size is 15. Now you might think it's, how do you transition between 10 and 15? This is a big transition. Try it and you see it's not a big transition. Okay, and let's see if it's, that's the same one. Okay, so after irrigation, that's the main file. I got it. You see how the debris is coming coronally? Back with number 10, and let me back with the wave 1 gold primary. Irrigation, sodium hypochlorite, half strength if you're not happy with full strength. Even though full strength doesn't work completely with retreatment cases, half strength, sorry. It has to be full strength. Okay, so that's the gutta-percha cone has been designed and machined to fit perfectly to the design of the file. Okay. You can also use this, have you heard about the endo activator, the sonic activation? That will help. Let's see. Yeah, this is the endo activator, sonic activators. Be careful with the sonic activators. The literature doesn't say great results about them. You have to look for the high power ultrasonic machine, sonic machine that has at least 7,000 hertz in order for it to be effective and as good. These are the results. Okay? This is wave 1 gold, primary and medium. And you know what I like it? The patient comes at the end of the day, the tooth is all the way in the back, near his throat. I can pre-curve the file, and I can complete the procedure with 1 file. Okay? So this is the other advantage. It allows me to do the procedure with 1 or 2 files. I did not use a path file, 10 and 15 hand files, and this is just like at the end of the day. It's 11:30, this patient shows up. And another patient, he was like, they said, you're gonna extract this tooth, and He was like very sad, and he came also, and this thing allows me to maneuver through difficult to reach areas. This is what I like about this file. Okay? 3 minutes. You see? That's after 15 hand file. Okay? And I have the opportunity, this is pre-op. I adjusted the working length. And this is post-op. See how it's very conservative. I allowed the sodium hypochlorite to settle there for 5 minutes with the activation. I was able to do the instrumentation in a few minutes. I dedicated most of the time for the sodium hypochlorite soak with the activation. And then he was like, I restored it, and he was happy. Now, what about this tooth? Does it work for all the cases? Be careful, may not. It's an O7 taper. This is very thin root. I would not probably use this file for this situation, even though maybe small will work. But this is, I had to use another system, which is another great system, rotary system. It's called True Anatomy. Okay, and this one also, one file, and you can follow curves. This is even without path file, without 10 and 15. And I can show you how after the pulpectomy, the pulp is pulled by one primary file. Okay? Okay? Now, literature says you can do up to 10 canals with one file. These are 6 and 7s together done. This is a small. I had to soak with 10 minutes because this is a small apical area. Soak and activate. These are not my cases. Dr. Weber, Julian Weber, one of the developers. So it creates nice shape. Pre-sterilized blisters, a precise gutta-percha cones, precise paper points. Simplicity is the ultimate sophistication, and it's 4:15 sharp.
I would like to thank Dr. Mohammed Al-Yaqub for the very informative lecture. I use the same file.
I commend you for it.
Unfortunately, because if we are running late, so there's no chance for a question. I think Dr. Mohammed will be happy to answer any question afterward.
Honestly, it's just like when you reach certain age, you cannot monkey with so many files and run the risk of stress breaking or not breaking. I found this system, maybe there are other systems, to be comfortable with me.
I think this is a lifesaver for me.
Thank you. At least somebody doesn't disagree with me. Okay. All right. Thank you. Any questions?
Dr. Mohammed. Thank you.
That's it?
Yes.
All right. Here we go. How are you? Thank you so much. You're going to talk about management of large lesions, right? I'm waiting for it. Sure. Sorry about that. Did I remove this?
Good afternoon. I'm happy to introduce to you Prof. Mehmet Kaval, graduated from AG University School of Dentistry in 2004. In 2010, Prof. Kaval obtained his PhD degree in endodontics from the University of EGE. Currently, Prof. Kaval is the head of the endodontic department at EGE University. Please just welcome Dr. Mehmet Kaval. Okay, I'm happy to introduce to you Prof. Mehmet Kaval. He graduated from EGE University School of Dentistry in 2004. In 2010, Prof. Kaval obtained his PhD degree in endodontics from the University of EGE. Currently, Prof. Kaval is the head of the endodontic department at EGE University. Please just welcome Dr. Mehmet Kaval.
Okay. Thank you very much, Chairman. I would like to thank the Kuwait Dental Association for the invitation to the Congress and for the hospitality also. Today, I will give the lecture about the management of large periapical lesions. I came from Turkey, Izmir, Ege University. I'm in the Department of Endodontology. I'm the head of the department. And this is my colleagues. This is my birthday celebration at that time. This photo is at that time. So this is the pre-clinic education places of us. Here, Phantom Laboratory. And the other side is undergraduate and postgraduate clinics. We have 40 postgraduate students and 200 undergraduate students. This is an education process in our faculty. We give lectures about the nitile reciprocation files, nitile rotary files, obturation systems. And after the postgraduate, these students come to us and we teach them about this issue. This was last year in our faculty. Theoretical and practical education was given there. We are 6 educators in our department, 2 professors and 4 associate professors. And at that time, we give lectures and educational theoretical courses. So today's topic is by me, endodontic management of teeth with large periapical lesions. It's difficult to speak after Sinju Kim because he gave a very nice and comprehensive lecture about this issue. But in my lecture, I want to give non-surgical treatment protocols, and I will focus on the non-surgical treatment protocols because we can also successful at this treatment protocol. So treatment options are root canal treatments, endodontic surgery, and nowadays also decompression treatments combined with surgical treatment, because in some cases the lesions are so large and we should decrease the volume and the size of the lesion before the surgery. I will explain about this issue. So I want to repeat, our first option should be non-surgical endodontic treatment in large periapical lesions, because we can manage most of the cases treating with non-surgically. As you can see, these are routine protocols that we treat in our clinics. So the patient came to our clinic, but as you know, some of the patients are nervous about this issue because the experience of the treatment protocol is sometimes painful and there's still swelling. We look to clinical appearance of the patients. First, clinical signs and symptoms, so swelling, pain, and other options. And then we look the size and location of the periapical lesion. So the third important factor is vitality of the pulp, because if we find the non-vital teeth, we are so predictable and happy at that position. If there isn't non-vital teeth, it's okay, but in some lesions, all teeth are vital. So at that case, it will be more difficult to treat. And the end of the treatment, we are looking for the characteristics of the lesion. Always at the beginning of the treatment, we are thinking about the cyst or granuloma, but most of the cases are granuloma in our cases. So we are beginning step by step, and here looking where the size and location of the periapical lesion. Nowadays, all dentists have periapical radiographs in their clinic. It's not so predictable, but it's useful for us because Sinju Kim said that CBCT is must during the treatment, but nowadays we couldn't manage sometimes CBCT in our clinic. First, we look to the periapical radiographs, and we see most of the signs of the lesions on the periapical radiograph. Yes, we need sometimes CBCT, but not in all cases we need CBCT. So when we are looking to the periapical radiograph, if we are seeing some lesion that is near to the anatomical structures, so we need CBCT there. Because when we are treating the patient, nasal floor, maxillary sinus, mental foramen and inferior alveolar nerve is very important during the treatment process. The patient has sometimes paresthesia. Sometimes we need surgery, but if the lesion near to the nasal floor, so we should decrease the size of the lesion, not immediately going to the surgery. Because if there is a connection with the nasal floor, it's very difficult to stabilize the lesion, and also during the healing process, we will have some difficulties that we couldn't manage as a dentist. So we should send the patient to the hospital. So we should use CBCT. Yes, here's an CBCT image. And as you can see, the lesion is beginning here. On the palatal side, there is a perforation. It's important for us. Also, here, there is a resorption on the central incisor. We should also look and think about the resorption during this period. Yes, you can see the perforation here. And after that, in most of cases, I look the size of the lesion. I know basically the size, but I always measure the size of the lesion in that cases. The most largest diameter, I look there, and then opposite of the diameter, I look the other side. Yes. Why is it important? I will explain you during this other slides. Yes. And sometimes we should also be careful on the other structures. For example, here is a nervus incisivus. If we perform endodontic surgery, we should be more carefully. So here, nasal floor. Nasal floor is very important, that I said before. And here we are lucky. Nasal floor is intact, okay? So we have chance to treat this patient non-surgically. Yes, the size is big, large lesion, but we have the chance because it's isolated on the anterior area. Okay. So, I said the size of the lesions give some signs to us. Eversole in 1984 have a theory about this issue. He said that if the lesion is bigger than 200 millimeters square, and if there is a straw-colored fluid contains cholesterol crystals, and more important, if there is a non-vital teeth one and more than one, so it could be cyst. So you try to treat it non-surgically, but your chance is a little bit lower. We should know this, but at the beginning, we always try to treat the patient non-surgically. But some modifications are there for elimination of the cystic lesions. So, cyst or radicular granuloma, the researchers are working too much about this issue. For example, digital analysis with CBCT. Yes, CBCT is sometimes a good sign for the radicular cyst due to its density. You can guess that it's a radicular cyst. But not exactly we can say that after the CBCT that it's a cyst. And also Coty et al. And other researchers work on the ultrasound power Doppler flowmetry. It's always difficult to evaluate these patients because if there isn't no perforation on the buccal or palatinal area, it doesn't work. Always there should be a perforation to use aqueous texture during this evaluation period. So what can we do? First we take CBCT, we solve the perforation, and after that we can use powered Doppler flowmetry. So the architecture of the lesion, the characteristics of the lesion shows us really that it's a cyst or granuloma. Here, very good study about G and his colleagues. They found that when they used power Doppler flowmetry, they can really high percentage success to give the successful results and for determination of the lesion that is a cyst. It's really important at the beginning knowing that this is a cyst or periapical granuloma. But sometimes you begin the treatment and the patient, the case shows you that it heals or not. Because if the signs and symptoms will quickly going down, so you can understand that your treatment will be better in 6 or 7 days. The signs will be disappeared. So we had also a study about this issue. We looked about the radiopaque line surround the lesion. Yes, this is a sign, but it's the correlation of the radiopaque line is not so predictable to manage and to say it's a cystic lesion. So the most conclusion of the studies about this issue comes that histological examination is required to reach the definitive diagnosis. When you read the articles, when I read my article, I read a lot of papers about this issue, and the conclusion sentences are mostly similar. They said, yes, you can take some information about the lesion, but the examination, histological examination, is the gold standard. So, the third step, we are looking for the pulp vitality. Assessment of the pulp vitality is also important for us. So, we are using neural sensitivity tests or pulp vascularity tests, but mostly we are using neural sensitivity tests. Thermal tests or electric pulp tests are mostly used tests. But sometimes you should use cavity test as I used here. This is an old case of mine. I begin to test the pulp vitality. Both teeth doesn't give any signs of vitality, and I plan to do root canal treatment. But first I open the cavity, right central incisor, and then left lateral central incisor, and I see that the patient give pain, some signs of pain to me, and I stop there. But I couldn't believe that this tooth could stay vital. I didn't perform at the beginning root canal treatment, but I said that I will control the vitality. It will be necrotic in the follow-up periods, but it doesn't goes to necrosis. It survives. At the third year's follow-up, as you can see, there's a significant healing there. But also, when I look at the apical side, there's a resorption due to the periapical healing process. So always, I'm speaking with my colleagues, they say that this teeth will be non-vital, but we will see at the 4th year follow-up. I don't think that this tooth will be non-vital. So the characteristic of the large periapical lesions is the presence of drainage. And it's a difficult site for the patient, swelling and drainage. We should always maintain the active drainage at the patients. If we could manage it, the healing comes frequently. In most of cases, we are performing the drainage from the access cavity. It's more easy, more non-invasive, and more predictable for us. But sometimes we should do also excision. If the lesion and swelling is on the palatal side, sometimes we couldn't perform exact drainage during the treatment process, so we are using needle aspiration in that cases. Needle aspirations work well in that cases, and also we can see the characteristic of the cavity lesion cavity. So, apical patency. Apical patency is an important key factor for us. Why? Because if we couldn't manage the apical patency, we couldn't maintain active drainage, and also we couldn't relieve the pain, and also the pressure is still there, and the treatment protocol will be go to failure, as you can guess. And sometimes, if there is a persistent lesion, we need to use the antimicrobial agents to the lesion. The activity and also the other effects could be useful for us. But when we couldn't manage the apical patency, it will be difficult for us. So how can we do apical patency? How can you manage the apical patency? In that cases, mostly if you are treating lateral incisors or cavities or teeth with calcification, it's difficult to manage. In that cases, we are using C files. C files are more strict and open the way that you can manage the apical patency. So what about the working length determination? 10 years ago, we did a study about this issue with my colleagues, and we are trying to evaluate the determination success of the electronic apex locators in teeth with largely periapical lesions. It was really a difficult study, but we see that we can usually determine the root canal working length accurately in that cases. This is very important for us, because when you can use apex locators in that cases, you can use easily the accurate points, and you can prepare the tooth more easily. So, should we treat the patient single visit or multiple visits? Sometimes my students come to me, Professor, there isn't no active drainage, and I couldn't manage any drainage. Could I treat the patient in one session? It's impossible. It's impossible because if you treat the patient in one session, you couldn't manage the active lesion sites. Always you should perform multiple visits, and the signs of the patients should be disappeared. It's really important for us. In most of cases, we need intracanal medication. If we don't use medical intracanal medication, in the future, we will have problems, and managing of the problems is more difficult for us. What about the irrigation? We have little problems during the irrigation, because if there is an active drainage, we mustn't use sodium hypochlorite. Are you using sodium hypochlorite in that cases at the beginning? I think we couldn't use it. If we are using sodium hypochlorite, there is a denaturation of the drainage, drained issue, and we closed the drainage. Do you understand this issue? At the beginning, we shouldn't use sodium hypochlorite. Sometimes, in that patients, the apical area is also connective with the root canal area, and extrusion of the sodium hypochlorite is easy at that cases. And sodium hypochlorite extrusion, as you know, is very dangerous and very difficult side of the root canal treatment. So first, we are performing active drainage, and during the drainage sessions, it's so episodic characterized. Drainage comes, and sometimes it stops, and drainage comes again. If you treat the patients, you can understand, you leave this issue easily. So during this drainage procedure, if drainage ceased, we use sterile saline irrigation. I know that in some cases, in many cases, sterile saline goes to the periapical area. Extrusion is occurred there. It's naturally, there will be a effectiveness of the saline there. But at the end of the session, we are seeing that the drainage will be decreased and ends. So at that time, we can use sodium hypochlorite. But sometimes, in the first session, second session, you can't use it. Very active and very persistent drainage will be occurred in that cases. But no problem. You, for example, you take the patient in the morning, you performed drainage in the root canal, and send the patient and say him, come 3 hours later to my clinic again. I did sometimes something like this. The patient came to me, and also there is drainage occurring at that time. Because the key point is drainage, diminishing the drainage. After that, you can go to the routine root canal treatment. So after the multiple sessions, we stabilize the lesion and the reaction of the periapical cavity. So it's similar to the routine patients. You can use sodium hypochlorite, and then at the final irrigation, you can use EDTA, sodium hypochlorite, distilled water, and chlorhexidine. We prefer here using chlorhexidine. It works well, I think, because the antimicrobial activity of the chlorhexidine is effectively works on the persistent microbiota. So I prefer and also recommend you to use chlorhexidine solution during the treatment protocol. So also we can use activation systems, especially ultrasonic activation systems are preferred frequently. So you can use also sonic, laser, or manual dynamic activation. And nowadays, I'm working also about the apical negative pressure systems. Have you ever been used apical pressure systems, negative pressure systems? Could you hands-on? Who are using these systems? Are you using apical negative pressure systems? It works well. It's safely used, and also the antimicrobial activity of the sodium hypochlorite, you can deliver it as soon as possible to the apical region. So for the intrathecal medication, always we prefer calcium hydroxide. It is the nowadays gold standard for us. When you control the drainage, after that you can use calcium hydroxide. Why? Because the antimicrobial activity, anti-inflammatory activity, and also here neutralization of the acidic products, and also promoting the healing of the periapical lesions during this process. We are always using calcium hydroxide in that cases. I will show my cases in the other slides, and in all cases I use calcium hydroxide. Some literature give advice about the chlorhexidine gel, but I don't prefer to use it. I'm only irrigating with chlorhexidine, but using chlorhexidine gel is not so efficient for the treatment protocol, because for the last inter-appointment session, for removing of the chlorhexidine is difficult for us. I use chlorhexidine at the end of the treatment, only at the end of the treatment. We are finishing a PhD study nowadays, and we see that removing of the chlorhexidine in the root canal system is very difficult. If there is a mixture with sodium hypochlorite or EDTA, there will be toxic components to you. So use chlorhexidine at the end of the treatment only. Yes, let's look at the cases here. So this is a large periapical lesion associated with the mandibular right molar. You can see. Also, there is a involvement of the furcation area. Do we need periodontal surgery or periodontal treatment in that cases? No, because the patient is periodontally healthy. There is no problem on the perio side. Why is here a lesion? It comes from the root canal and orifice chamber. There is also communication with that area, and comes here radiolucency and also lesion. It's the treatment protocol is 3 or 4 sessions working length treatment process. I used calcium hydroxide, and in the 18-month follow-up, really successful healing is appeared. This case, a 12 years old little child came to me. She had a swelling on the mandibular area, so too much pain. It's difficult to communicate also with the patient, but we manage it, and you can see the lesion is so extensive and active, and the roots are moving laterally. I do always drainage sessions in that cases. After 3 or 4 sessions, the drainage is controlled. I send calcium hydroxide, and again swelling is beginning there. You will also see that you control the drainage, you control the symptoms, and in some cases, if you use calcium hydroxide, there will be flare-up. So again, I worked about this patient, and when I control the drainage process, I used again calcium hydroxide. So I control all symptoms and obturate the both teeth, and you can see a very significant healing at the 16-month follow-up. Another case with huge, extensive, large lesion. In this case, I'm a little bit uncertain. I speak with the patient and say to him, first we try to treat you non-surgically, or we can decrease the size of the lesion, because we couldn't perform endodontic surgery in this position, especially in our department. Maybe I will send him to the hospital for maxillofacial surgery, because there's a communication with the nasal floor. So we begin the sessions. The symptoms are disappeared. The patient is happy. He doesn't have any problem with the teeth, but I see the lesion is still there. I couldn't see enough healing here. I try to continue the follow-ups. He came in 2016 and 2018. Here is a little bit healing, but I'm not sure. And after that, the patient disappeared. He couldn't came to me. Maybe he think that this doctor is too much thinking about this lesion. And he came to me for another tooth, for the premolar tooth, 5 years later. But of course, at the beginning, I take the radiographs. He said to me, it's okay with my lateral incisor, but I said, if you come to me, I should take the radiographs. I take the radiograph, and it was nice. It healed significantly there. But still, here I need follow-up sessions. But it depends to the patient. If it's come, I will take the radiographs. So, another case, also furcation involvement is here. This is the 6-month follow-up. And after 2 years, everything is okay. It heals. Another case, here a retreatment protocol is here. I treat the patient, I retreat the canals, and it heals at the 24 months follow-up. Another case, it heals easily. And this case is a little bit important for me because very young patient came to me. There was swelling. He has also pain, and this is yes, in the school for soldiers school, and came to me. I begin the treatment, and it's difficult to control the drainage sessions. But after that, when I finished the treatment, 4 months later, you can see healing here. Very significant healing 4 months later. I think it's very quickly healing. In young patients, we can manage it more easily, more quickly. So what about the immature teeth? Because there's also lesion, and the maturation of the tooth is not completed. Two difficult sites, big lesion and immature teeth. So we have a prospective study about this issue. And huge lesions will heal using MTA or calcium hydroxide apexification protocol. It works well. And this is also an interesting case of mine. That was in the coronavirus pandemic sites. We are only doing emergency protocols at that time. The patients came to me from the pediatric dentistry department. They tried to manage this density vaginatus problem, but they couldn't, and I'm looking for the patient. There was a sinus tract, and on the sinus tract, the patient was asymptomatic. He doesn't have any pain. In that cases, I always begin after the access cavity preparation with saline solution, sterile saline solution. I recommend to you also to use sterile saline solution in that cases. I begin to irrigation and see that there is a solution on the sinus tract. The solution comes from the sinus tract. I didn't give any pressure there, but I couldn't control the solution. The patient has only sinus tract, but he doesn't have any pain or other symptoms. So I wait for the treatment protocol. I looked if I could manage a drainage or something. No, there is no drainage. So I used calcium hydroxide here and sent the patient for the next appointment, but he doesn't came due to the coronavirus pandemic process. When he came to me, it was really interesting. There was only calcium hydroxide there. It was not radio opaque, so it's radiolucent calcium hydroxide. I'm using not radio opaque calcium hydroxide. I'm using radiolucent. We are preparing it from Merck company. Maybe you know it. In our faculty, we are preparing it from the Merck. We take the powder, and then with distilled water we are using it calcium hydroxide. So when the patient came to me, the lesion is completely healed, but there is a problem. As you can see here, there's a dentin bridge. So I couldn't believe this because when I used during the working length determination the files, I can easily go to the working length, but I didn't use any sodium hypochlorite. I couldn't do too much for this patient, but the nature and the body reaction is very good. So you can see here is a very good dentin bridge. I couldn't go behind the apex. And after that, I placed here MTA and restored the tooth. But the family of, the parents of the patient came to me. They didn't say, okay, doctor, the patient healed very well. They said to me, doctor, what can we do with the diastema? What can we do the aesthetic procedures? They didn't say thank you for the healing process. And I sent the patient to the restorative department, and my colleague did it composite veneers. It works well. So, at the beginning of my lecture, I said that maintaining the apical patency is very important. We should maintain the apical patency. But sometimes, we published it in dental traumatology in 2015 with my colleague and Professor Çalışkan. We had cases like this, 3 cases. As you can see here is a spontaneous apical closure, but very big lesion. So what can we do? We placed calcium hydroxide, but here we mixed our calcium hydroxide with radiopaque calcium hydroxide. We wait 2 weeks, in some cases 3 weeks. We have 3 cases with this. And look at the healing. How can we manage it? It's really questionable, but we discuss it in the discussion part of my article. Maybe you can also read this. So calcium hydroxide works also periradicularly, because as you know, the dentin is not have some porosity, and also this dentin bridge has porosity. When you look to the obturation, you can see the little extrusion of the sealer, but you couldn't manage exact apical patency, but it works well. So, can we treat that patients with regenerative endodontic treatment? Yes. I have 7 or 8 patients that I treat with regenerative endodontic treatment. It works well. but I prefer it mostly in young patients, not old patients. It works well. After the drainage stations, working length, and then when I achieved bleeding, there will be regeneration there. And healing appears in 24 months follow-up. So I couldn't manage root lengthening here, but you can see there's apical closure. When you compare from the beginning to follow-up, apical closure is apparent there. Yes, we treat the patients, but sometimes, as Professor Kim said, we couldn't manage sometimes the patients. So, yes, we should also do endodontic surgery. Yes, we treat the patients surgically. What are the indications? First indication, failed non-surgical endodontic retreatment. After that, sometimes we need to do, after instrument fracture or root perforation or overfilling cases related to the iatrogenic complications. This is our research team. We treat the patients always in that research group. Professor Çalışkan, he's now retired, but he is the leader of our research team. We are always working with him about our articles and research projects. And also, we need oral surgeon for radiographs, for evaluation of the patients. Professor Güneri helped us during this period. Professor Nizam from periodontology department also work during this period, and also my colleagues in my departments, associate professors Seniha and Gözde. We are working together in that cases. Not always with oral surgeon, but in some cases we need to work with them also. So, if you do endodontic surgery, you should read this book. Really, it's very famous and so very useful during this process. And we are very lucky that today the lecture of Sinju Kim was very spectacular and very nice for us. So, at the beginning, you should always know what you can do during the treatment protocol. So, most of our cases are 2 large lesions.
Prof, we have 5 minutes.
5 minutes, okay, I'm finishing. So, you know that protocols, flap designs are mostly mucoparietal flaps, and also removal of the pathogens, and after that we send it to the pathology. Always, please send your cases for the evaluation of pathological definitive diagnosis. It's really important. And then root end resection, and after ultrasonic preparation, MTA placement. 3 mm is always gold standard. As you know, the lateral canals and apical ramifications should be eliminated when we cut the root 3 mm length. Yes. At the end of the surgery, always, it's really funny for us to see that apical retrocavities with MTA. I have lots of pictures like this, and always I take pictures again. So what about the characteristic of the cyst lesions? For example, here is a dentigerous cyst. you can see there is a supernumerary tooth, and due to the supernumerary tooth, there is a very large lesion, but it heals very well. But always long-term follow-up sessions are needed. Please follow the follow-up sessions are very important. Please follow up your patients. We published in International Endodontic Journal our cases, and most of them are granuloma or cysts, and the success was 80%. But you can we used here complete healing protocol. Complete healing protocol. I'm showing the cases to you. For example, here we achieved after 5 years complete healing. But here, after 6 years, incomplete healing. Why? Because there's a scar tissue. The patient has no signs or symptoms, but it should be follow-up. For example, this patient, no signs or symptoms, but uncertain healing. It is not successful for us. We are evaluating the patient furtherly. Always, we are trying to manage complete healing. Another dentigerous cyst. Yes, you can see very large lesion. Another one. And sometimes keratocysts lesions are difficult to manage because the recurrence of that lesions are apparent. We can see the recurrency, and these cases are really aggressive cases. You can see the lesion here. And after the 7 years follow-up, yes, there is a healing, but we are not sure about this case. We are evaluating the case furtherly. And lastly, I want to say something about the decompression treatment. Please use this treatment protocol also for your cases, because you can find sometimes no solution for the cases that are very big, very large. So if you have any opportunity to treat these patients, use decompression treatment. It's very easy. Here is an opening inside the lesion, and then you put a tube there, you suture the tube, and in 2 weeks, the lesions and the symptoms will be disappeared. The patient irrigates the cavity with saline, and it works well. Another case here. You can see the tube inside the cavity. It's radio opaque also, and it works well. Thank you. Thank you very much for your interest.
Thank you, Prof, for the lovely lecture. Does anyone have a question? Yes.
I couldn't hear you, sorry. Yes, yes, yes. Yes, in all cases. At the end of the treatment session, we are completing the treatment with endodontic surgery. But at that time, they will be always decreased enough for us.
Any other question?
Sorry?
while you prefer using calcium hydroxide with distilled water?
Thank you very much for your question. So the vehicle of calcium hydroxide is very important for us. If you use distilled water, it works very quickly. But if you use glycerin or other solutions or glycol sometimes, it's the reaction and the effectiveness of the calcium hydroxide will be decreased. It comes slowly, but it decreased. So we can maintain very quick the reactions and effectiveness of calcium hydroxide. Therefore, we are using distilled water.
Thank you, Professor.
Okay, thank you.
In 2019. Currently, she is a senior registrar at Jaber Al Ahmed Specialized Dental Center. And I'm pleased to present Dr. Lulwa now.
Okay. I'm honored to be here in this big conference, and I would like to thank the committee for this opportunity. Well, today I'm going to talk about guided regeneration in endodontic microsurgery. Before I start, please keep in mind that this topic is about guided regeneration, and so I don't have enough time to do a detailed explanation about the endodontic microsurgery itself. It's a literature review to help you know when and when not to use the guided regeneration. I'll give you a brief about the endodontic microsurgery so all the audience will follow up with me in this presentation. Now, imagine with me patients who have endured years of pain due to a persistent periapical lesion. Despite multiple treatments and retreatment, the pain does not only affect the patient tooth, however, it's affecting the overall self-confidence and discomfort. So, long time ago, this type of cases had a limited treatment option where they ended up with the extraction and placing an implant. Nowadays, the advancement in the endodontic field have gave us a tool not only to save the tooth, but only to restore the patient comfort and self-confidence with using the guided regeneration in endodontic microsurgery. I'll start the presentation with the outline that will involve the introduction about endodontic microsurgery, followed by the biological rationale behind guided regeneration and the regenerative material available to be used in such procedure. The main aspect of this presentation will focus on when to consider guided regeneration with endodontic microsurgery and the role of guided regeneration in cortical plate and ridge preservation. I'll conclude the presentation with some of the disadvantages and complications, and I'll let you know how to prevent them and manage them. So, in introduction, the endodontic microsurgery became more of a popular treatment option from generation to another due to the increase in awareness of saving the patient's teeth and preserve them for a long period of time. The surgery itself had a success rate that ranges between 88 to 94%. Briefly, it is indicated in cases where we have a persistent periapical lesion that could not be treated non-surgically, or the retreatment had been attempted and it failed. If in cases where the non-surgical root canal retreatment is not feasible, in cases with a complex prosthetic work, or an endodontic mishap in the apical third that is not feasible to be treated with non-surgical techniques. The main objective of endodontic microsurgery is to eliminate all the infection and optimize the healing environment to restore the dentoalveolar tissues. By conducting our endodontic microsurgery, it involves raising a flap, creating the osteotomy in order to reach the root tip, doing our resection, retrograde filling, and the preparation. Then, by doing this, we are unintentionally doing a defect that could be more complicated and complex. In literature, these types of defect include the very large defect, through and through defect, along with apicomarginal defect. They have been shown to have unfavorable healing. As in Boyne in 1969, they created a bone defect in the monkey alveolar process and followed them histologically up to 3 years. They found that the small defect healed completely with bone filling. However, a larger defect, which reached up to 9 to 12 millimeter in diameter, healed with a scar tissue formation. Kressler also in 2013 tried to estimate the defect size by measuring it volumetrically, filling the defect with saline, aspirate it, and tried to measure it. They found that if the lesion size was less than or equal to 0.06 milliliter, the success rate was 90%. However, if the lesion was more than this measurement, the success rate dropped to 86%. And in cases where the defect perforated both the buccal and the palatal plate, the success rate went down to 71%. As for the apicomarginal lesions, Kim in 2008 conducted an endodontic microsurgery and divided them according to the lesion type. They followed all lesions up to 5 years, and they found that if the lesion was of isolated limited periapical lesion, the success rate reached up to 95%. However, if the lesion was of endoperio origin, the success rate went down to 77%. Also, Song in 2013 conducted an endodontic microsurgery and found that the effect of the buccal bone height on the success rate of such a procedure. They found that if the buccal bone height that is indicated with the letter B in this figure, if it was less than or equal to 3 millimeter in height, the success rate went down to 69% from 94%. So from these two studies, we can find that the apicomarginal lesions have unfavorable outcome. To optimize our healing outcome following the endodontic microsurgery, guided regeneration have been adopted to the endodontic field. So let us know what is the guided regeneration and how can we define it. It is basically to regenerate the lost dentoalveolar tissue by selectively inhibit the scar tissue formation to optimize the bone healing quality and quantity. What is the biological rationale behind this procedure? In order to understand the biological rationale, we have to know that following an endodontic microsurgery, the healing is completed with 5 types of cells, starting with the epithelial cells, the fibroblast, the alveolar bone cells, the periodontal ligament cells, and the cementum cells. The last 3 types of cells are involved in the dentoalveolar healing. However, the fibroblast and the epithelial cells are responsible for another type of healing, which is the scar tissue formation. You have to know that epithelial cells are 10 times more faster than our osseous cells. They repopulate the defect as early as 2 to 3 days following the surgery. However, the osteoplastic cells will start to repopulate the defect as at 14 days following the surgery, completing the remodeling at 28, and the complete maturation and remodeling of the bone will take up to 5 months. Now you know that there is a competition between the epithelial cells and the osseous cells. Here comes the role of the guided regeneration, which aims to exclude the epithelial cells for at least 14 days to allow our osseous cells to repopulate the defect to prevent the scar tissue formation and hence regenerate our dentoalveolar support to the tooth. Now we come to the question, do we really need guided regeneration to prevent what I call the healing with scar tissue formation, or we don't? To answer this question, we have to raise another question. What is actually the scar tissue? Is it really bad? Do we really need to prevent it? We have to understand that the scar tissue is a reparative response. However, it fills the defect with a fibrous, dense, collagenous tissue instead of the bone. Red and Andreessen in 1972, they found in their histological study that lesions healed with scar tissue formation have varying degree of inflammation. Moreover, the scar tissue is shown in the periapical radiograph as a sunburst appearance with a radiolucent center and radiating radiopacities that in some cases will be deceptive for some dentists and warranted further unnecessary interventions. So now let's know what are the regeneration materials available in our field in order to prevent the scar tissue formation, optimizing the dentoalveolar support to the tooth. We have the barrier membranes, the bone graft, and the host modulating agents. Barrier membranes function mainly to exclude the epithelial cells, maintaining the space for a new bone formation and the stabilization of the blood clot. Ideally, they have to extend 2 to 3 millimeters beyond the defect margin, stay stable in the defect for at least 3 to 4 weeks following the surgery. They are divided to 2 categories, either the non-absorbable membranes, which are the expanded polytetrafluoroethylene, which unfortunately needs second surgery that is not ideal for our apical surgeries for retrieval. And the absorbable membranes are the second type of the membranes, which, for example, the collagen membranes. And they are commonly derived from equine, porcine, and bovine, such as the BioGuide, the Jason membrane, and the Cola plug. The main advantages of the collagen membranes lies in its low immunogenicity, in its flexibility and adhesion properties. Mainly, they have the property of augmenting the native collagen property that is found within the defect by promoting platelets aggregation to facilitate the hemostasis and along with its chemotactic action on the regenerative cells to accelerate the healing. The disadvantages, as the name implies, it is absorbable and having a different and unpredictable resorption rate will affect our rationale behind using the guided regeneration. The collagen membrane can stay for short as 10 days or can last up to 6 months. In order to slow down the degradation process, a cross-linking mechanism have been adapted to the collagen membrane by creating a covalent bond between the collagen fibers, trying to increase the tensile strength, decreasing their solubility, and hence the enzymatic degradation. This was proven by Moses in 2008, where they found that the residual collagen membranes in the defect was up to 91% in the cross-linked collagen types, as opposed to 14% for the non-cross-linked collagen's membrane. This was also confirmed by Calciolari in 2020, conducting the same methodology and yielded the same conclusion in his study. Moving on to the next type of the regenerative material, which is the bone graft. They function mainly to support the membranes from collapsing into the defect, and by themselves can have an osteogenic activity where they produce the bone, or they act by osteoinductive mechanism to induce the neighboring cells for bone formation. They also can act only as a scaffold for a new bone formation. Bone graft can be categorized according to the source. We have the autograft, which is the gold standard. It can be derived from the patient himself, either extraorally or intraorally. However, this type of bone graft has the disadvantages of the second surgery site that might increase the morbidity for the patient. The second graft source is the allograft, which is derived from cadavers such as the freeze-dried bone allograft and the decalcified one. Third type is the xenograft, which is derived from animals, and this is mostly used in our endodontic field such as the bioos. The last thing is the synthetic source, which is the alloplast. For example, is the calcium sulfate that we use to cast our patient impression in our laboratory. The last three types have the disadvantages of creating a foreign body reaction. The latest approach for the regenerative material is the host modulating agent, which is basically a process that involves withdrawing the patient's blood, centrifuge it, and extracting the growth factors and the immune cells, implementing them in the membrane and the bone graft in most of the cases. They found that the growth factors have the characteristic of signaling the mesenchymal cells to differentiate into a cell-specific, to differentiate into a tissue-committed cells for more angiogenesis and bone remodeling. For example, we have the bone morphogenic proteins, the platelet-derived growth factors, and the transforming growth factor beta. The endodontic literature have investigated the use of the host modulating agent, and in the meta-analysis conducted by Liu in 2021 found that using such technique will improve the patient quality of life at early stage of healing by having less swelling and less pain, along with better sleep and speech function. They found that there is a trend of better outcome with using such modality, along with acceleration of the healing process. Now we can ask the question, do we really need to accelerate the healing process in our apical surgery? Well, in my point of view, acceleration of healing is much of a need in the periodontal and the implant surgeries, as shortening the timeline for the patient is much of a need to further proceed with the treatment plan. To conclude this part about the regeneration material, Tobon in 2002 conducted a randomized controlled trial on a 26 limited periapical lesion. Histologically, after 1 year, they found the group of patients where they did not apply the guided regeneration technique, the bone was filling the defect in only 25% of the cases. However, it increased to 62% in cases where they used membrane only, and increased up to 100% healing in the cases when they used the combination of a bone graft and membrane. So they concluded that guided regeneration will enhance the healing. A more recent meta-analysis was conducted by Macho in 2022, including 11 randomized controlled trials to compare 6 different regenerative techniques with a minimum follow-up of 6 months. They stated that the use of a membrane alone or a bone graft alone is more efficient in cases where the periapical lesion is of limited nature and small in size, that for the bone that is available in the defect have enough capability to repopulate the site. And they found that the combination use of the bone grafts and the membranes is more efficient in cases where the lesion is complicated and of a large size, that the addition of more support to the bone is needed for promoting the healing process. This emphasized on the tailored strategy for using guided regeneration, which the lesion size and complexity will guide us for our material selection. So let us know what are the lesions that we might face during conducting the endodontic microsurgery, and hence to answer the question of when to consider the use of guided regeneration in endodontic microsurgery. Von Arx have categorized the preapical lesion into 3 categories. The first one is the limited preapical lesion, the 4-wall defect. And the second one is the apical through and through lesion, which involve a lesion that perforates the palatal plate with or without perforating the buccal plate before conducting the endodontic microsurgery. And the last type is the apicomarginal lesion, which involve a complete loss of the buccal bone for the root in question. We will start I will show you some evidence that support the use of guided regeneration or not for each type of lesion. So a randomized control trial was conducted in 2007 by Tascari to investigate the use of guided regeneration for such lesion, comparing it to a control group. They found that there is no big difference in the success rate between the experimental group of 87% to a control group of 82%. So they concluded that there is no added benefit for using the regenerative material for such lesions. In this clinical case of limited apical lesion, Bernabe conducted a histological study in 2010 where they induced a standardized 5 mm limited periapical lesion for the dog's premolar. And they divided them into different regenerative groups using different materials compared to a control group. And at 6 months, histological analysis was conducted, and they found that all groups healed similarly. There is no difference whether they use the guided regeneration with different techniques or where they didn't in such lesions. They all healed with thick PDL and mineralized tissue. So now we can conclude that guided regeneration is not needed for such lesions. We cannot apply it for limited periapical lesion. However, it's worth mentioning that the limited periapical lesion comes in various sizes. And as I mentioned before, the large limited periapical lesion healed mostly with inflamed scar tissue. Kim and Kratchman in 2018 stated that 26% of the limited periapical lesion heals with a scar tissue formation. Leo, in 2021, his meta-analysis concluded that using the guided regeneration for a large periapical lesions enhanced the healing outcome. So now, let's add more confusion to this aspect. What do I mean by large periapical lesion? Is there a critical size where we can say, let's apply the guided regenerative technique or not? To answer this question, I explored the endodontic literature, and I found a recent study conducted by our colleague, Dr. Fatma Al-Kandari and Dr. Samhan Al-Ajmi in 2024, where they did a retrospective study with a minimum follow-up of 6 months. They found that applying the guided regenerative technique is more effective for cases which measured in height of 3 to 6 millimeter and in depth of 3 to 9 millimeter. As you can see, the height is highlighted with a blue line and the depth with a red line. So they concluded that the use of the conventional endodontic microsurgery without adding any guided tissue regeneration techniques is effective for a small lesion which measured less than or equal to 3 millimeter in depth and height. However, in large periapical lesion, the use of guided regeneration is more effective. Adding to this study, back in 2016, a meta-analysis was conducted by Ding, including 8 randomized controlled trials, and they concluded that regarding the lesion size, it is recommended to use the guided regeneration in large periapical lesions of more than or equal to 10 millimeter in diameter, irrespective to the lesion type. So to conclude this lesion type, I included a case that I did back in my residency in the Kuwaiti Board of Endodontics. It is a case of a 40-year-old male who presented to the clinic with pain on teeth number 1, 2, and 1. Both teeth were tender to percussion and palpation, and the endodontic microsurgery was the treatment of option due to the complex prosthetic work coronally. And the guided tissue regeneration was applied along with the surgery due to the fact the lesion size was of 13 to 10 millimeter in diameter. As we can appreciate from the sagittal section of both teeth that it is of a limited isolated periapical lesion type. The endodontic microsurgery was conducted with 2 separate osteotomies, and the Jason membrane was cut and adapted to the osteotomy site and extended at least 2 to 3 millimeter beyond the defect. This is the intraoperative radiograph showing you the defect after the surgery. The patient was followed up to 6 months, and he was completely asymptomatic with bone filling in the defect that was improved at 2 years. That is shown in the sagittal section of the CBCT for both teeth and in the perioperative radiograph. Sorry, in the recall 2 years using the periapical radiograph. So moving on to a more complex periapical lesion, which is a through and through periapical lesion. I have to highlight here that for such lesions, preoperatively, we have to see the loss of the palatal cortical plate. However, the buccal cortical plate, it could be lost prior to the surgery, or eventually it will be lost during our osteotomy. So eventually, we are creating a through and through apical lesions. In through and through lesions, which are among the most complicated lesions, it was proven in literature that adding the guided regeneration will positively affect the success rate. As in Taskeri, also in 2008, found that after conducting a randomized control trial, the guided regeneration group had a success rate at 1 year of 88%, while the control group had only 57% success rate. This was proven by Damija in 2020, where they collected a through and through periapical lesion and divided them to 2 groups, the experimental and the control group, followed up the patient at 1 year, where they published their first article in 2020, and again at 5 years, and the other publication was in 2024. As you can see from the sagittal sections of the anterior teeth, that preoperatively we can anticipate that we will have apical through and through defect after conducting our osteotomy. At 1 year follow-up, the use of a platelet-rich plasma as the guided regenerative technique showed a healing of 85% compared to only 45% in the control group. This was improved at 5 years, where the guided regeneration group had up to 100% success rate compared to 64% in the control group. So they concluded that the use of platelet-rich plasma led to significant better healing in such lesions. However, this conclusion should be taken with caution due to the limitation of such study. They stated that the sample size was very small, and along with a short follow-up period, and also at the recall at 5 months, they had a lot of dropout, up to 25%, mostly from the control group. So the investigation for using only host modulating agent for such complex lesion should be revisited and continued in order to take this conclusion into granted. Now, this is a case about a large through and through periapical lesion conducted by Casimiro in 2022, where we can see from the sagittal section the through and through type of lesion. They conducted the endodontic microsurgery using both the membrane and the bone graft, and they followed up the patient at 2 years, where we can appreciate the healing at the surgery site and the periapical lesion. This was maintained up to 7-year follow-up. Moving on to the last type of the periapical lesion, which is the apicomarginal lesion, which is very complex due to its proximity to the gingival line. Epicomarginal lesions have been studied by Detrick on 23 lesions where they used the BioGuide and the BioUS. In this study, they didn't have any control group, and they found that 83% of the cases had a success rate at 1-year follow-up. However, and moreover, the pocket depth reduced from 9 millimeter to 3 millimeter. This was supported by a histological and radiographic study conducted by Pritan in 2005, where themselves induced an epicomarginal defect in dogs' premolars, conducted their endodontic microsurgery using different regenerative technique and comparing it to a control group. As you can see, after 6 months, they conducted their histological analysis and radiographic analysis where we can appreciate the new cementum formation and the new bone formation in such lesions after using the guided tissue regeneration was higher than the control group. Here we can see a clinical case of epicomarginal lesion, which from the preoperative periapical radiograph, we can appreciate the presence of the periapical lesion, and intraoperatively, the epicomarginal defect was evident. They conducted the surgery with using the BioUS bone graft. This will highlight the stability of using the guided regeneration. After 8 years follow-up, the tooth is, the treatment was still successful with no, and the patient were asymptomatic.
دكتورة لو 10 minutes. 10 minutes.
خلصنا?
We have 10 minutes.
5 minutes, okay.
10 minutes, 10 minutes.
Okay, okay. So adding to the role of using guided regeneration in increasing the success rate and enhance it in the endodontic microsurgery, the use of regenerative procedure to re-establish the cortical plate and hence for more ridge preservation is highlighted. So in order to address this aspect, I included the famous study, which is the Buffalo study that was conducted by Azim in 2021. They actually collected 85 lesions and they used the guided tissue regeneration only on limited lesion. They did not do any randomization, and they used the guided regeneration, they did not use the guided regeneration for the limited lesion. However, the more complex lesion, the through and through or epicomarginal lesion, they implemented the use of guided regeneration with bone graft plus minus the collagen membrane. They followed up the lesion for up to 1 and 3 years follow-up radiographically, and they found that there is no significant difference with using the guided regeneration or not. As you can see, there is no randomization was done, so no conclusion about the success outcome from this study can be made. However, the re-establishment of the cortical plate was evident in 86% of the guided regeneration group, where we can see, for example, in the epicomarginal lesion type, when they added the guided regeneration, the re-establishment in the cortical plate was evident at 1 year follow-up. However, in the control group, where they did not use the guided regeneration, the re-establishment of the cortical plate was only at 38% of the cases. Even though the limited periapical lesion was of a small size, we can still appreciate the indentation and loss of the cortical plate at the surgery site after 1 year follow-up. Let us investigate more of using the guided regeneration only and specifically for the limited periapical lesion and see if it have actually a role in re-establishing the cortical plate for such lesions. Dr. Amna Al-Baghli, our colleague, conducted a randomized control trial in 2023 where they included 58 limited periapical lesions, divided them to a control group compared to a guided regeneration group, and followed them up to 1 year. They found that the success rate was not a difference between the control and the experimental group using both modalities of radiographs. And however, for the cortical plate, it was evident to be re-established more in the guided regeneration group, up to 69%, compared to only 46% in the control group. They concluded that higher percentage of cortical plate re-establishment is evident, and it could be of a clinical benefit for a future ridge preservation need. So now I reach the end of the presentation, and despite the benefits of using the guided regeneration to enhance our outcome, we still have some disadvantages and complications that lies in the high cost of such materials and the high operator skill that is needed to implement this technique. Along with increased chance of swelling, exposure of our membranes or bone graft, increasing the risk of infection and contamination. Awareness of these factors will help us manage them well and prevent them in the first place by eliminating all the root canal infection prior to conduct this surgery. Along with any periodontitis, and during the surgery, we have to maintain a sterile surgical field to avoid any contamination. Pain and swelling or infection post-surgically can be managed with an appropriate prescription for antibiotics and anti-inflammatory analgesics. And in severe symptoms, the resurgery might be indicated to retrieve the regenerative materials and enhance our surgery site. And to conclude this presentation, applying the guided regeneration is important to improve our endodontic microsurgery outcome in complex lesions, along with its role in preparing the site for a future failure for the tooth for any reason, either prosthetic or periodontal reason. The site will be good with its re-establishment of the cortical plate and ridge preservation. And thank you for your attention, and I would like to see if anyone have any question.
Thank you, Dr. Alula, for the very interesting and informative lecture. So if anyone has a question for Dr. Alula?
مشكورة على البرزنتيشن وايد حلو. I just have one question.
Yes.
If we are using any bone graft and membranes, do you recommend prescribing prophylactic antibiotic or giving corticosteroid even?
Actually not. When I read the literature, it is not routinely recommended unless there is risk of increasing an infection, such as in like diabetic patients or other reason that necessitate the use of antibiotic. But prophylactically, I wouldn't use the antibiotic.
Steroids?
No, I wouldn't.
Thank you.
Welcome.
Any other question? Anyone has any question?
Thank you for the excellent presentation. Just one question. Is there any, besides the type of the lesion, are there any contraindication for using this technique?
Actually, the contraindication will be if the patient is not compliant with his oral hygiene, or if there is any like medical systematic disease, such as, of course, the use of bisphosphonate, or in cases where the diabetes is not controlled. I wouldn't recommend the use of guided regeneration because the increased risk of infection and impaired healing in such cases.
Thank you for this beautiful
Thank
presentation. The question is, what is the strongest evidence in the entire guided regeneration regarding the superiority of the guided regeneration in non-through and through lesions?
You mean?
What is the strongest evidence supporting the use of the guided bone regeneration or guide tissue regeneration in non-through and through lesions?
We have the meta-analysis that was conducted by Leo in 2021, where they found that it should be used in large limited periapical lesion along with apicomarginal lesions. Did this answer your question?
No, because it's just like sometimes we get we're not sure. When we do the surgery, should we use it? Should we do it?
Yeah, you have to like study your
We
case.
learned when we were in the graduate program, picora, through and through lesions. That's it.
Yeah, but
now it's as you mentioned, things have changed. So we have to measure the lesion and see if it has a certain size, and then we decide,
yes,
right?
even if it's of limited type, you have to measure it.
Yeah.
And also you have to consider the endoperioral lesions. It's also recommended to use the guided regeneration for this type of lesion.
So you do the measurements by the CBCT, and you
Yes.
see if you're exceeding that threshold,
Yes.
it's better to,
Yeah.
regardless if there is a through and through lesion.
Yes.
Thank you
it
so
is.
much.
Welcome.
I think for Dr. Mohammed Ali Yaqub, most of the studies, all of them, they talk about large lesions and through and through. But I guess there's a Hartwell-wise against that. He said it wasn't beneficial for large lesions. I think he's the only one that, like in my brain, that he was against using GTR for the large lesions. Hartwell. Also Hartwell, and I think also Travanijad also. Yes.
Okay.
Thank you, Dr. Alulwe.
Thank you.